Just seeing his article that
Good morning, everybody. We are slightly late, but we don't want to be very late. And I think the people who could come yesterday, almost all of them are here. So I would invite Dr. Shantanu Pandey to start the program with introduction.
my talk is very good, so I don't make it. तो सारे जितने मंकी दवाए थे वो सब भी दे जाओ ना फिर तो तब तक ये इंट्रोडक्शन दे देता है आप ये वेट आफ्टर इंट्रोडक्शन फॉर फ्यू मिनट्स एंड देन
मैं बता रहा हूँ ना सर, थोड़ा सा वेट कर लेंगे आफ्टर दिस इंट्रोडक्शन. हाँ
आई डोंट वांट टू मेक माय टॉक टू 10 people.
सर, विवेक सर आ गए. हाँ, एसके सर बिहेवियर. अमित, थैंक यू. इसके सर आ गए, इसके सर आ गए. यस बेटा. ठीक है, सांस ले रहा है ना, बढ़िया। वो हाँ हाँ कुछ हाँ ठीक है देखो, ट्यूब तो नहीं निकल रहा। प्रेशर हार्ट रेट ठीक है। ठीक 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 So, welcome all to fifth annual Foundation Day of Department of CVTS. We are meeting after a long time. There was COVID and we had little bit of inertia in doing this workshop, which we usually do every year. So I'll give you a glimpse of the department, how it has grown over 35 years. This department was founded on 16th of July, 1987, with Professor P.K. Mittal joining as the first faculty in the department. So we had initial group of 5 exceptional faculty, Professor Prabal Ghosh, Professor T.S. Mahant, Professor Pramod Mittal, Professor A.K. Srivastav, and Professor A.K. Ganju. So in starting in 1987 from scratch with 2 major departments around this place, one King George's Medical College and the other was Kanpur GSVM Hriday Rog Sansthan, which is known as Hriday Rog Sansthan today. So they were very old departments. So starting a new department from scratch in this place, in just 1 decade, we were able to produce a very robust pediatric cardiac surgery program, coronary surgery program, minimal invasive cardiac surgery, as it was known at that point of time, doing ASDs, valves through lateral thoracotomies. And the first attempt at beating heart surgery was made, and that was successful in 4 patients. And I was assistant to Dr. A.K. Srivastav that time. And we performed that without use of octopus. So that was the kind of people who founded this department and the kind of commitment they had. And in just 1 decade, we had a platform to jump from. Then in the second decade of the department, the actually building of department started with more faculty coming. Unfortunately, most of them did not stay for very long. Professor V.M. Kanhare, who is here with us, I was his student, and his presence here brought us a very new way of doing coronary artery bypass grafting. So I'm telling you this from my experience. We were not exposed to that kind of coronary artery bypass grafting, and he is an exceptional teacher. So he can even train and teach a bull like us. So the next to join was Dr. Surajit Dan, and he had a very short stay in institute. He had extremely short stay in institute. There is something wrong with those steps, sir. SK sir, there is something wrong with those steps. We have to do something for that. So Dr. Surajit Dan is very lovingly remembered by people in department, though he had a very short stay with us here. Professor Sushil Singh joined again in the department for just 7 months when I was already appointed as assistant professor here, and his footprints can be seen in off-pump coronary artery surgery of SGPGI of today. Sachin Talwar joined us again for a very short time, 10 months, but he brought a new kind of working environment from All India Institute of Medical College. And we are also very grateful to his contribution to our department. Gauranga Majumdar stayed with us for a quite long time. He became professor here, joined us as alumni, he's an alumni of this institution. He joined as assistant professor and went to become a professor, and then he has left for a better job in the same city of ours. Our department in this institution has touched for 60 professional lives, and some of our alumni are here, and I'm proud to say that almost all are doing very well in their field. This is the current department. Sitting left to right, Professor Vipin Chandra, Dr. Varuna Verma in center, Dr. Ankush Kotwal, he is assistant professor with us. Dr. Nirmal Gupta is head of our department, and Dr. S.K. Agarwal, sir. He was my teacher, and he is the longest standing person in this department. He has been, you can rightly say, he has been pivotal in whatever has happened in this department, and he is like time of Mahabharata, who has seen everything in this department. So where we are today, from that contribution of all the faculty members who have worked here, and the pedestal which we got to jump on, we have a pediatric and neonatal cardiac surgery program, not much different from what Professor P.K. Mittal and Dr. T.S. Mahant had left in this institution. There is a possibility of a very big pediatric hospital coming in our institution. So in future, we'll be talking about that. Minimally invasive cardiac surgery program, we have taken it to from where it was in 1999 and 2000, we have taken it to the modern kind of minimal invasive cardiac surgery. Robotic cardiac surgery program started in this department in 2021, and we have started thoracic surgery in robotic also. We have a very robust program of total arterial revascularization with approximately 70% of our patients of coronary artery bypass receiving both internal mammary arteries. So with this small introduction to people who do not know much about our department and a revision to our alumni, so I welcome you all again to this meeting. There is a small amendment in program. Dr. Sushant Mukhopadhyay, who is a very prolific minimal invasive surgeon in Kolkata in East India, he is unable to attend this CME because of commitment, some judicial commitment, some patient-related complaint in Kolkata. So he has to stay back there. So I'll be taking over his talk in session 3. Thank you very much and welcome again.
A very good morning. Thank you, Dr. Shantanu. I'm Rizwan, your MC for the day, taking the 5th annual Foundation Day CME functions at Department of Cardiovascular and Thoracic Surgery, Sanjay Gandhi Postgraduate Institute of Medical Sciences ahead. We're starting with our first session. And may I please have the honor of inviting the panelists. May I please request Dr. Satyen Tiwari to please take a place on the panel, please. Thank you so much, sir. Dr. A.K. Srivastav, you're also requested to please take a place on the panel. Dr. Vinay Krishna, may I please request you if you are there in the house. And may I have Dr. Sanjeev Garg. Then we have chairpersons. We are requesting the chairpersons, Dr. Abha Chandra, to please join in.
We are not a lot of people.
May I please request Dr. A.P. Jain to please join in. May I please request Dr. S.K. Singh as a chairperson. And may I please request Dr. Sanjay Singh as a chairperson to please. Thank you so much. Thank you, doctors. Over to the panelist.
मैम पहले बैठा पसीना पे बुला दीजिएगा सर क्या बोलेंगे
Morning to everyone, and we will just proceed with the first session as per the schedule. I would like to invite Professor Vinayak Shukla from CMC Vellore, and he's one of the best cardiac surgeon, and he has been the head of the department also there. Would you like to talk?
Second so you want to give your talk? My talk time is over.
Okay, so we have Professor Prasanna Sema from Jayadeva Institute of Cardiology and Cardiac Sciences from Bangalore. And he would be speaking on rheumatic mitral valve repair, relevance in current era.
Can we load that? Is the slide loaded, please? While they are loading, rheumatic heart disease, as everyone is saying, is actually the toughest subset in a way to repair. But one must not forget that Carpentier started his career with rheumatic heart disease and rheumatic valve repair. So people keep asking me, do they last? Do they this? And what's the durability? And then I say, you don't have to go too far away. You have to go and see Carpentier's data, because his original papers were all on rheumatic valves. It was later on that he started doing, because most of these patients who were coming from Morocco were coming and North Africa were all coming to Europe. And at that time, even in Europe, there was rheumatic heart disease at that time. And no, I think what happened? Okay. Now, is it relevant in the current era? Yeah, I'll just put it in perspective while they still load it. When I started doing around 3 decades back repairs, rheumatic repairs represented around 90% of the cases which we are doing. But today, I will tell you from statistics which we have got from the pediatrician, there has not been a single rheumatic heart disease case reported in Bangalore urban. However, Bangalore rural and the rest of Karnataka do have this thing. So we know from our pediatricians that it still exists. And it is reflected in our practice. What was 90% is still there, around 60 to 70% of our cases still remain rheumatic, but they all are coming from the hinterland. So is it relevant? It's very much relevant. And this is what happened. We did actually a survey with the Cardiological Society of India, and even there we found that there is still a significant amount of rheumatic heart disease in rural India, and so this cannot be washed away. And the other thing is that the time lag of 20 to 20 years, which we would roughly say, is going to be there. So rheumatic heart disease is going to be there for us to stay. And so it's going to be there. Now, even now, 40% of the global RHD population still belongs to India. It's coming down relatively, but it's still there. And it's around 0.5 to 1.47 in different states. States like Kerala, where there's a tremendous reduction due to increase in this thing. And as I told you, even in Karnataka, we have seen zero. There has been no reported. It's a reportable disease, and it's not in Karnataka, and we have got zero in Bangalore city, but Bangalore rural we are getting, and other parts of Karnataka we are getting. But there is a trend, but so you're going to have a lot of variation. And we do get patients from all over India for repairs, and we are seeing this similar trend where urban people are not seeing the rheumatic heart disease, but still the large populace needs to be treated. Now, what is the results of repair? As I said, Carpentier's original work, then the current repair results are similar, roughly around the same. And you can say that at least for around 10 years that you would get good. And this could be vital, because today the mortality of redos have come down significantly. And if you can give rise to an anticoagulation-free survival life, it's significantly advantageous. Another thing that we've seen is that what is the 10-year survival with a mitral valve replacement? 60% is the claim. But one of my cardiologists who's very diligent in this thing, he says that I ask a simple question: how many mitral valve replacements are there after 5 years? You must be doing a large volume, but see how many MVRs. You only see the successes, but you don't see the large number of deaths which occur. And if they're not following, they're dead. And the main advantage of doing a repair is that they can come back to you with a problem. They can come back with an MR. Whereas with a person who dies at home because of a choked valve or a intracranial bleed, he never come. I still remember when one of my colleagues who was doing replacement said, my patients have got good. I said, right now, do you realize that your patient is there being thrombolized? It took a lot of difficulty to convince people that you need to do it. And that's a fight which I have been doing for over 3 decades. And today I'm happy to say that my cardiologist, I now have a selection bias, which I was telling, that my cardiologist asked me, is this valve repairable? If this valve is repairable, go ahead and repair it. Otherwise, we'll delay for a replacement. So that's the thing that we have to build up our own clientele, and our job is to convince our cardiologists and our physicians. In fact, I was just telling my pediatric cardiologists are now talking of preservation of LV. Don't allow the LV to go into dysfunction. So they want me to do it earlier than late. So that's a paradigm shift which Carpentier had actually predicted, that this was the ideal way of going about it. But then there is a lot of convincing that we have to do as surgeons. Now, what is the typical rheumatic fever? This is an old photo. This is a kid, and this is what you're going to see most of the time, that there will be some amount of AML prolapse, a significant amount of PML retraction, and there will be commissural fusion. This is one of the commonest things. So rheumatic heart disease repair requires a segment by segment analysis of P1, P2, P3, commissures, and A1, A2, A3. So it's very important. It's not going to be just an isolated P2 prolapse, which is something which I make my residents do, but you need to be able to analyze. So this comes with, and now I'm happy to say that my second rung can do these repairs very consistently. Now, how do we select? This is a common question that I say. Now, for a beginner, I would see, we described, and unfortunately, this work was done by one of my cardiologists who was a PG at that time. He unfortunately died of an intracranial hemorrhage when he was a consultant, and we could never publish this. He had all the data and he did it, and somehow I never got to publish it. But this is the working thing which we follow in my hospital. His name was Dattatreya. He died. And we have described what is called as the infra-PML triangle. That is under the posterior leaflet. If you see it, is the arrow coming there? If you see the triangle which subtends between the PML, the posterior LV wall, and the caudal apparatus, and then we did 100 consecutive cases, and we followed up them over what would happen. Actually, it was 106 consecutive cases, and then he presented it in Indian Society of Echocardiography, and he won a prize actually for this. And we found that if the infra-PML triangle is greater than 1.5, the repair rate was 98%. This was at the beginning of my career. And if it was less than 1 centimeter, then the repair rate was 60%. In between 1 and 1.5 centimeters, somewhere around 85 to 90. Now, using this, we could sort of predict, and I will tell you now that my repair rate is much higher than this, but this was when I was a beginner, and that I should say should be translatable to people who are embarking on repair rate, that you should select a patient who has got a good infra-PML triangle, then you will be able to do it 98% of the time. Then as your skill set improves, you can start taking more and more difficult cases. Now, if you see the second one, you can see down here, you can see what should not be repaired, especially for a beginner. You find a calcified valve, you see a small infra-PML triangle, and extreme crowding. These are the sort of cases I would not recommend a beginner to do. Even I would be circumspect for doing such a case, but it depends. See, the push is if it's a young patient, a lady who wants to get pregnant, this thing like that, you would push and try to do a repair in more complicated cases. Whereas if she's finished her family, is more elderly, this thing and that, then you would have to choose, and that's where decision making becomes important. Now, if you were to talk about it, I would always divide it into the bad PML. Now, retraction is typically the P2 or P2, P1, P2, P3 is retracted. And the first step that I always say is divide the posterior basal chordae. This immediately makes the leaflet more pliable and allows it to do. Then you have to do a good OMV. When I started my repair, I had not even seen repair being done. The only repairs were for things like congenital MR, cleft AML, like that. Otherwise, there were no repairs being done when I had not. But all I knew how to do was a good OMV, and trust me, that was the one thing that helped me do a lot of repair. If you need to release the hinge point, and you need to do first a good OMV and good release of subvalvular apparatus. Once that is done and release the posterior basal chordae, you convert pure MSMR. Very commonly there is MSMR. Even sometimes 1 to 2 millimeters a cut may be required because the hinge has to move. The door moves around the hinge, and if you don't release the hinge, you will have a residual gradient. And so this is the thing which I said. There are three. What are the strategies? Either you divide the posterior basal chordae so that it roundens up the flat thing, or else you pull it, or you patch it. And another thing which I call as a veil. Each one depends upon how bad the PML is retracted. And if it is a focal retraction, you can just close the pseudoclefts, and I'm using that less and less nowadays. But what I do is a contralateral tethering stitch. I think I'll be putting it. This was described by Kalongas, but I was actually using this much. This is what we tell now, we are lazy and we don't publish, and that's our problem. And I was using it for decades, and then I suddenly realized Kalongas published it. Fault is ours. And then the next is a local or a pericardial prosthetic veil. So this is a Kalongas stitch where many times you do a repair and you find a small focal leak, irritating focal leak. You just put a pledgeted, you get these VSD sutures, 4 T-bond with the pledget. You pass it from the area of the PML and you hitch it to the anterior part of the ring. And this is an example of a ring which I used to make in the olden days, the old slide. And you can see that irritating leak will go away, and it will allow you, and trust me, I always tell the difference between having a repair rate of 70 and going to 98 to 100% is eliminating these small things, what I call as nips and tucks. That's what makes the difference. So you can, here you can see, I have closed this cleft, and then I have to, actually you can see, I have put a contralateral tethering stitch, and you can see the excellent coaptation that occurs. Now, if there is a focal retraction, then I call it as local veil. Oh, sorry. So if there are in rheumatic repairs, you may have crests and troughs which are irritating on the PML. It's a rugged surface, so you can smoothen out that by putting. I mean, in this patient, I put a Gore-Tex membrane, but many times I put this thing. Now, if you have you can put, you can augment the PML, but trust me. One of my colleagues who was trained under me does a lot of this, but I usually say that if you need to augment, usually there's something wrong and you are just shifting the irregular surface a little down. But one of the key points that I tell is that you need to, if you're augmenting, you need to put a massive level of augmentation. So don't put too less. Don't worry about SAM. Rheumatic health never get SAM. So augment and augment well. In fact, the patch should be nearly as big as a sizer of that size. Okay. And another thing which I have done, and this especially I have done in kids, is that I have placed a ring, and then what you see here is actually an entire artificial PML, which has been made with pericardium, so that now you can see that when you coapt, you will get competence. The push to do a repair in a kid is so high, but surprisingly, I found extremely good long-term results with this. And though even I don't do this very often, but paradoxically, sometimes I think I have to revisit this because this seems to be giving, and fusion is impossible. Re-MS is impossible with this method because they are having something into it. And it's something which even I have to explore doing more. And this is, for example, a total, this is a 4-year-old child with rheumatic heart disease. What are you going to do for this? The push was so much. And in such cases, you can see I have actually not been able to put a ring, but this child was put with a totally artificial, that's a totally a veiled, there's a veil over the existing PML, and we got a very good orifice area. It looks terrible, but it's functional. And I have not replaced this child. He's grown into adulthood, I have not replaced this child so far. So we need to have out of the box thinking. And just incidentally, if you can see, this annuloplasty was all done with a pacemaker wire. I used to use a epicardial wire as an annuloplasty thing at one time. So now the next thing is for AML prolapse. The common thing was to use Gore-Tex, and initially I used to use what Tyrone David describes as loop over loop technique. Problem for us is in a teaching institute, Gore-Tex cordae are expensive. If I were to use more Gore-Tex cordae, they would tell me don't repair if the cost is going to become. So I had to start trying things, how to reduce and the problem with loop or loop technique is I could do it. It was a little painful for me also, but it has to be transferable to the next generation. So then I realized that this is not very good. So this is what I do, which I called as combined cordoplasty. And I will see when I started doing no internet, nothing, all of us, the seniors, there was nothing there available. I had only Carpentier's French correction article with me. When I used to do the repair, I used to sit, read it, and then do it. Then again, read it and do it. Every time I used to read the article and then I used to go in and repair. So then he had abandoned doing trenched cordoplasty because the suture would rub and cause the cordae to tear. I said, then let's eliminate that. And I started doing it. And you can see here, we shorten the cordae by using the Gore-Tex cordae. But the most important thing is no trench. The other thing that I do is I use the same Gore-Tex cordae and make it into a strut cord. So now it deflects the tension across all the cordae that you are having, because the strut cordae is one which is going to decrease this thing. So this ended up with, actually now I've been using it for more than 3 decades now, 3 decades of repair work. And trust me, this is the stablest part of the repair. The nemesis is P3 in rheumatic heart disease repairs. P3 retracts. So actually that I tend to put a contralateral tethering stitch many times. In P3, if I find any fibrosis in that areas, because I know that in the long term, failures, there are 2 types of failures: stenotic failure, which some of them have been reballooned by my thing, and then regurgitant failures. Regurgitant failures are primarily P3 retraction. There is one more type, which is where AML is retracted, that no one can do anything because that represents typically patients who don't continue their rheumatic prophylaxis. But if you fix your P3 tight, it can't retract, and that's one way of eliminating. And those are the patients who actually got good long-term results. So you can see this is the way we do it. So what can be achieved? Progressively with experience, you can do calcified valve. You can see here, for example, I've actually removed a piece of calcium. I have patched. I've done all sorts of things. So you can get all these things. Now, we have done, now we just analyzed the data some time back, and 80% of the data over the years from 1997 to 2022, 80% were rheumatic heart disease, because primarily in the initial phase, most of my repair work was rheumatic. And in 2104 mitral valve repairs, see, there is a bias in the sense, I don't know how many went to Saint elsewhere. But we've done personally, we had to do 34 redo replacement were all rheumatics, 5 redo replacements and this thing. So we are analyzing our data. And as far as myxomatous valve repairs, one small point for P2 prolapse, please don't use Prolene, because we had perforations, 2 cases, and we abandoned using Prolene and we use either Ethima. We are getting Cardionel, you use Cardionel if it is available, or Ethibond, 4O Ethibond is what I use. But where do we get redo replacements? Have all been essentially in rheumatic. And then another thing is follow-up is very important because of endocarditis. So is it worth it? See, this was a boy who had operated today he has come. He was a school student when he came. Now he has come with his wife. And now he's actually, the later thing is that unfortunately I have not taken the photograph of him bringing his child. Would he have survived to be able to this thing? I had a rheumatic double valve repair. I had to do a Zaki plus mitral valve repair last week. Unfortunately, the repair failed and I had to do a DVR. I said, I've sentenced this child to death. She will not become an adult. I was so upset. Whereas, see this, he can come back to me. And I said, I literally say a DVR in a young kid, not going to see 18 years. Let's be honest. So another thing which I have been doing is, you can tell me to stop if my time is out. Another problem that we face with rheumatic heart disease, this is one thing very dear to my heart, is that what to do with patients with severe RV dysfunction, because we have burnt, I think every one of us have burnt, the patient comes off bypass, starts getting progressively, RV liver enzymes go up, then around the 7th or 8th day goes into hepatorenal failure and then dies. So very common. This was what I used to face. And so it was very difficult. And then what was the thing? So we did a study, and then with patients with RV dysfunction, we just started to follow up these sort of patients, and then we found 2 things which we noticed that patients who had a TAPC less than 10 were the ones who were dying. So we wanted to analyze how things were, and in the meanwhile, another thing that I was doing is I started noticing that these patients who were dying of hepatorenal failure, typically between 6 and 7 days, they go into SIRS. We noticed that these patients, I was struggling with sort of these patients as a young surgeon. And I noticed that I was I had learned echocardiography myself, because I used to beg cardiology, come do my heart pound jod ke, I used to ask, come do my echo, come do my echo. Very difficult. So I said, I quit begging and do my own echo. So I started putting the ultrasound probe onto the liver, because they're developing this thing, whether what is happening. And I started noticing that there were no hepatic arterial Doppler, this thing was not there. I had to learn how to probe the, how to image the hepatic artery, and I found. Then one day what happened is I had a patient whom I had put an IABP out of desperation, trying to do something to save the patient. And I had some amount of limb ischemia. So I started giving intra-arterial nitroglycerin through the central lumen of the IABP. And then I see this patient's and trying to see where is the thing, what is happening. And I started noticing that the hepatic arterial flow started coming back. That made me think. Then I gave sublingual nitroglycerin, didn't work. IV nitroglycerin didn't work, but intra-arterial through the central lumen of the IABP was working. So then I sat and did a study on this, and we actually published it and showed that and there is a scientific basis to it, because in patients with chronic venous congestion, the hepatic arterial flow overtakes the portal flow as a nutritive flow for the thing. And when you go on bypass and the hepatic artery goes into vasospasm, we showed that this vasospasm lasts for 72 hours. So you get progressive ischemic hepatitis over a period of time, despite having good BP, everything afterward, and then they go into the SIRS-like state. We actually wanted to work further and try to measure endotoxin levels, because I thought that SIRS that happens there is due to endotoxin release through the gut, but we never could do that. Was difficult. So between 2009 and 2030, we followed up 456 patients with severe TR and with RB dysfunction with TAPSI less than 14. Always 6 cases. And when we saw that, you can see that patients who had a PA pressure less than 50 and who had a TAPSI less than 10, 9 out of 9 died. We had 0 survivors in those. So I presented this in the Brno Symposium in Croatia, and there we had a big discussion on this. And so in my this thing, if the TAPSI is less than 10 and the PA pressure is normal, we don't offer surgery. Because I say this is significant end-stage heart disease, and these patients should probably go for transplant pathway or VAD, whatever you want to do, but they will not survive. So, but whereas if you see here, even though they had TAPSI less than 10, if the PA pressure is high, they will, as long as the PA pressure falls. So just see that they don't have some COPD or something like that. I would like to add as a qualifier. And so don't take such patients if you have COPD, high PA pressure, which you don't think that is going to, but if their PA pressure is going to come down, that is, you don't have other pulmonary cause of this thing, they do very well. I mean, don't think of mitral valve disease, lung laden with fluid type of respiratory issues. So these were the lessons I learned, and with this we have been able to significantly offer surgery to a large populace and over the years. And in fact, many of my references now come for patients with bad livers, specifically with the cardiologist asking, can you do it? We offer surgery for childs A and B, but not for C. C should get liver transplantation. The mortality will be too high. I mean, I don't think, and even if you were to repair them, you're not going to do well. They should go for heart liver, or repair the heart and go for liver transplantation. But A and B, we significantly reduce the mortality with such an approach. So those are the pointers. Is it, and so to end it, is rheumatic heart disease relevant in India? Yes, it is. There is still a large population. If you are not getting them in your practice, especially in private practice, I know, because there will be people going, that means to say you are not attending to that practice. But if you offer it with better income, all those patients as they come up, you will get for the next 10, 15 years till India progresses in its economic this. We are going to have to attend to all these patients. Thank you.
Thank you, Dr. Prasanna. This was a very lucid presentation which you made, and it has been a personal experience. That was really wonderful. So we'll keep the questions towards the end of the session. Question at the end of the session.
Okay, very nice talk. Being a cardiologist, I have a question and opinion. We used to get, most of us get rheumatic patients, and very uncommon to have isolated rheumatic mitral regurgitation. And most of these patients comes with us with cholesterol, calcium, and blocks of calcium on AML, PML tape. So how many of your patients being referred electively for mitral valve repair comes out with a replacement? The percentage, right?
Yeah, I do around, with my selection protocol, which I have roughly, I do around 250, 250 repairs a year roughly. In a year, I have to abandon probably 2 or 3 times. But then, you know, I take, those where I'm abandoning probably are the ones where I'm pushing myself to the limits of the repair.
So, as being a cardiologist, if you have a conventional calcium, so is it
not that directly a contraindication? I like to inspect the valve, because certain percentage of them you can unblock, excise the calcium and repair certain percentage. But that I'd like to see. So usually what happens is, in such cases, my cardiologist
ask me, see the gap and decide. Okay. So if if I say, yeah, I think I can give a try, they will tell, okay, go ahead. Or else they will use the standard guidelines for the LBR and then, so there's always a discussion between me. In fact, now the reverse problem is that my faculty will push me to do things which I don't want to do. Because I especially in pediatric side, they want me to, because they say that that's not better than doing the replacement. In fact, in pediatrics now, they're telling me, let's save the LB, let's save the LB, let's not get the LB done. But
Sir, I have a question. Thanks for brilliant presentation. My question is, CMV is a type of repair, closed mitral valve. Why we suddenly stop doing CMV?
I'll put it in my hospital is one of the largest centers doing balloon valve. They have to tell a gatekeeper. But I still do a lot of open mitral valve in the LA body clot.
I am talking about closed mitral valve.
Closed mitral valve.
Why we have stopped doing that? Because we have excellent long-term results.
See, you will say that, but you have to argue with the gatekeeper. You will have to tell us the time. They will do. See that I have personally no problem with the balloon valve because for me they come back to me for a re-OM. At that time, when there is a valve crowding, they will not want to do it. I do the OMB at that.
Dr. Simha, I really enjoyed your talk. I just have one question for you. This is one of your slides which showed that in pediatric patients, when you do the repair, quite often we see the patients who come with pathology is so bad that younger kids that we don't know whether we should wait any longer to offer them surgery at a later stage in terms of valve replacement or take a chance and do the repair. So when you do repair for this pediatric patient, so do you use the ring regularly? Because I always have that reservation that it may impair that growth of the annulus.
It's a simple bit like for a child who cannot accommodate a 24 size, today we have 24 size. Two things I do, I look at the parents. If the parents are short-sighted, you can have to, and it's not a totally predictable thing, then you can put a thing. If the parents are short-statured and the child is, but if my minimum size ring that I would put is 24. If I can't, I do a ring-based repair. And the thing that I do is I usually put two hemispheres and I leave a ring for to accommodate for annular growth. I don't put a ring in small kids. For example, you saw one of the kids where I had put that PML over there. There was no ring like that here. So you have to pattern. And another thing is I have done really do repairs in such case. Sometimes we just turn out of really hard to place a ring because remodeling becomes so. These children don't. Let me be honest. There is no such thing as a one surgery for life in rheumatic arthritis. Let's not talk that way. In fact, what my pediatricians are now, I told you, they're more. They're saying let's go away from getting to preserving the LV. So I said they are pushing me more to go earlier so that the child's LV is kept good. Because we know now that survival in pediatrics.
मैक्स नहीं दे रहे ना सर, तो मैक्स नहीं दे रहे ना, सेल्फ देंगे ना, मैक लगा के तो नहीं
3 points. Is the fact that you continue to see a lot of rheumatic work, vis-a-vis degenerative work, is it related to the institute you're practicing? I mean, my point is that perhaps you were to go to
11
slightly
o'clock.
affluent private sector.
Definitely.
Maybe you will get more degenerative.
Now I'm getting more. I get a lot
करना नहीं
of. I know myself I'm getting a lot of degenerative work.
सर गुड न्यूज़
People who are in private will get less of rheumatic. I told you it's a selection bias which is there, but
Also, interesting, you should point out that urban Bangalore has 0% incidence. I would think slums would still have rheumatic fever.
no, but paradoxically because everybody goes and gives an antibiotic to. I mean, because antibiotics misuse.
I know that.
Yeah.
The second thing is how many of your mitral repairs require concurrent tricuspids?
Very large percentage. In fact, my rule is I follow the Colombo criterion very strictly. every case, be it a mitral, aortic, any valve will have the tricuspid annulus measured. If it is on four chamber view, it is pre-decided. If it is more than 21 mm per meter square, somehow I did not end up highlighting it here. I'm sorry for that. But if it is more than 21 mm per meter square, they will get some fix in the absence of TR. I'm telling you, in the absence of TR, if it is more than 20. Usually in the absence of TR, it will be a case annuloplasty. Because we have got Lawrence Cohen's directed us that shows that the case annuloplasty will work, not a Divega. If it is a moderate or severe TR, I will fix it in whatever way it may include a range. But 100% any TR has to be fixed, any annulus more than 21. Because see, we have seen a significant thing. You all have in your practice, I think, patients with mitral valve okay and they're having right heart failure. We eliminated a significant percentage of that by fixing it the first time. In fact, most of the redo tricuspid valve work again is because of people who have not done it and they come to me.
That's interesting. If you go to own the house, I think the house will tell us that if you leave the tricuspid first time, and this patient comes back to you with a good mitral and a tricuspid, his prognosis is
very terrible.
Very bad prognosis.
Yeah, in fact, one of the students we showed that actually the dysfunction is related to the mid-papillary dilatation. I have my theories to do work, but don't want to publish. That is the problem. But we showed actually that with mitral valve replacement, see, that time we had no speckle tracking, we had to do manual speckle tracking. And one of my students we showed that ringing effect which we get, there is mid-papillary dilatation and loss of torsion. And that's what causes the septum to get displaced, the tricuspid mid-papillary. So exactly where the papillary muscle is missing. So it's very vital to fix your tricuspid valve in advance. And it's very important that you see, that is, people are, you can wonder, even though I have done bileaf flood preservation, once you do an MDR, the torsional loss is there when you do, we showed that the torsional loss is there and that was mid-papillary dilatation.
Two more observations. I don't know who's doing echocardiography. In practice, my anesthesiologist does it, but he's not perhaps as good. Number one. Number two is how are you giving intra-aortic nitroglycerin for patients?
Yeah, number one, I personally see all my transthoracic people, I can do my thing. When I started my nursing, I don't know, I mean, I'm not my cardiologists were busy. I had to beg somebody come. They are very, very busy. But now today they all come because I'm grown up. But you know, I was the butcher of the department and so I learned how to do it. So I do my own echocardiography. In fact, what happens is I think my routine is because I have a large repair practice. My rounds are with the echocardiography.
Who's doing transcatheter? You are doing it
And
yourself?
I'm lucky now. My wife is a cardiac anesthesiologist. She is the first DM. She was a teacher many years, and she was the first batch of DM cardiac anesthesiologist. She was a teacher and a student at that time.
It's all in the family.
It's all in the family. But my cardiac anesthesiologist is good. But at the end of the day, I do it. I can do my own. I think it's important. Today they're running echocardiography programs at the. In fact, now Indian Association of Cardiac Anesthesiology is offering for cardiac surgeons a TV program. If you want to do repair, better. Why I call a cardiologist is when I have a residual MR, there is a pitch to leave that MR. I don't want to go back in because I know that I may very likely end up with a replacement. Whether to now see, I am biased. I want my result to this. So then I call a fresh player. And then I ask them, you see. I just walk out and tell them, you see and you certify. Whether I leave it or not. That's the time when I do it.
The most important answer. How do you give intra-aortic?
Intra-arterial NPC is actually I share you the article. What we do is we place a pigtail into the femoral artery and we place it at a point between the xiphoid and the umbilicus above the celiac artery. We don't actually put it intra. Because the logistics of hooking it into the hepatic artery and keeping was too much. So I kept it, but I saw it was going through the IABP sheet and it was working. So I placed it just above the.
Basically, in the descending thoracic aorta, long pigtail.
Yes, a long pigtail is there, and then every day we switch off the nitroglycerin and do the hepatic arterial Doppler. And if you don't get a triphasic flow, you restart it. It's wonderful to see. You would have a triphasic flow with the LTG on, and then it becomes monophasic and sometimes stops. And then the longest we have seen is 72 hours. So I say that if you are unable to get a radiologist or you yourself to do it, keep it for 72 hours, or else, but then I don't like keeping a catheter of somebody's artery for 3 days, so I measure it. And the moment it comes back to a triphasic flow with nitroglycerin, we remove it.
No clinical thing, no clinical correlation. See patients clinically improving.
No. Because there was no correlation between the clinical status of the patient and the hepatic versus parallel. Because when you put it on, you realize nothing to, and you start getting that, if you put your settings away, it's beautiful to see this flame on the color Doppler coming back and then disappearing. I call it extinguishing candle sign when you switch off the battery.
Just one question. Do you have any cutoff of age? When you will not repair and replace the valve? So you replace the valve with a 20-year-old male, 25-year-old male, 45-year-old.
The default is can I repair them? Whether it is 80 years or less. In fact, I think the 80-year person benefits with the absence of anticoagulation, the 20-year-old person benefits with the lack of anticoagulation, the baby also. There's no such age. And as I was telling you, even if you do bi-reflex reservation, you are going to destroy the optional. My default is repair. Not repair, that God's given you the bad luck of the draw of the dice.
Thank you, Dr. Prasanna. Kindly give us the applause to me.
Next, I would like to invite Professor Vinayak Shukla. He is the professor at CMC Vellore, and he has been the head of the department over there as well. And he has been, in fact, he has been one of our favorite teacher, and he's a great trainer. Because I actually, I was fortunate to be trained under him. And so I would invite him to talk the next topic, which is transforming a surgeon into a successful cardiac surgeon. What is required and what else that we do. So over to you, sir.
A very good morning to all of you. And a big thank you to everybody in Sanjay Gandhi Institute for this opportunity. Shantanu Pandey, now no talking. Sit down, please. Otherwise, sit here. Everybody is, talking about it, but they're not giving any attention to this problem which we are facing today. We'll start our little talk with story by Acharya Rajneesh. I'm sure people know him. There was this circus in the town, and the circus manager had a great passion to collect peculiar things. अनोखी चीजें इकट्ठा करना उसका मतलब था. So one lady came with a basket and said, I have got a small dog which plays the piano. So he said, आइए अंदर आइए. He took her inside, made her sit there. Then she took out from the basket a dog and a small puppy, and the puppy started playing the piano. He was thrilled. The moment this puppy started playing music, another dog came from outside and took the puppy away in its mouth, along with the piano. Manager said, what is this? Ye kya ho raha hai? So the lady said, the one who had got the puppy, this is the dog's mother. She wants him to become a doctor. ये कुत्ते की माँ है, वो उसको डॉक्टर बनाना चाहती है. So I hope I have answered your question to some extent. I will not answer everything. I will leave some things for you to think. So the lady said, this is the dog's mother and wants the puppy to become a doctor. If we need to transform a surgeon into a successful cardiac surgeon, we have to have a surgeon first, and he should be willing for transformation. If you give time, the ugly duckling will become a swan, no doubt. But unfortunately, that is not the case with us. If you think, oh, with time, I'll grow up into a swan, you're mistaken. This topic is very ironical. If you see in the state of Uttar Pradesh, we have got very few MCH candidates. If you take my institute, nobody has joined. It is such a big crisis we are facing that we do not have takers for this particular seat, particular course, particular profession. What is the cause? Whom to blame? We'll gradually come to it. My apologies to anybody in the audience who may disagree with me. Feel free. I have got nothing against it. I am entitled to my opinion. You are entitled to your opinion. Now the talk becomes very interesting. I want your 100% concentration. I studied in a school in Bhopal, and the vice principal and the principal, half my knowledge is, my sarcasm is from them. So this vice principal went to the principal and said, Father, you know, Miss Rita Fernandez, whenever she enters the class stops breathing. So my principal said, oh my God, she's so strict. No, she wears such tight clothes. She wears such tight clothes that the entire class stops breathing. So this vice principal of ours gave us a book, What Kate Did at School. This was a book in 10th standard for us to read for rapid reading. You have to read it in a week's time and then you have to present it. And we were very naughty boys. So on the first page of the book, this is all what we wrote. Please read it. What did Kate do at school? Everything except study. School? She never went to school. Exactly opposite of what her mother told her to do. Spent all her time with the boys. She did not do a thing. Everything else did everything for her. These were the comments written on the first page of the book. And they all went to my vice principal. So he called us on Saturday afternoon and he said, no, what she did at school was study. And this is what is missing today. He said, I still remember clearly, she did everything, but she did everything after she did her study. And this study is what is missing after 50 years also. I have not forgotten my vice principal. He said, you do whatever you want, but your first job is to study. And he said, what Kate did at school was study. And this is what is missing. We are doing everything except studying, and everything else comes after that. He's so right. So the important corollary to this is what? The boys on the street who cannot read and the boys in the school who will not read. No difference. A very bitter statement. It's applicable to everybody, all of us. A boy in the street who cannot read and the boy who does not want to read. There is no difference. A very, very bitter statement. Now, study does not mean you open your book and read till midnight. You can download the entire Kirkland Perloff on your laptop and you think it will get into your head. No, study means it's another word for learning, understanding, growing, maturing, and ripening like the fruit. You have to imbibe everything possible. And that is what is study. It does not mean open your book and you read till midnight and you say, I have studied. No, study has to be taken in a sense that you imbibe everything possible to become a better student, a better citizen, a better teacher, a better surgeon. All of you must have read Alice in Wonderland. Alice is lost in the woods, and then she reaches crossroads. Chaurahe pe pahunchti hai, and she doesn't know where to go. So this Cheshire cat is there. So they asked, Alice will ask the Cheshire Cat, which road do I take? Which road do I take? So the Cheshire Cat says, where do you want to go? Where do you want to go? So Alice says, I don't know. Then the cat says, you can take any road, it doesn't matter. If you don't know where to go, any road will take you there. If you don't know which road to take, any road will take you there. But if you know which road to take, you have to take where to go, you have to take that specific road. This Alice in Wonderland, I have never forgotten this particular bit from Alice in Wonderland, a very, very important lesson. Which road if you don't know where to go, any road will take you there. So this one word, where to go, says it all. This where is very important in life, whether you're a teacher or you're a student. If you don't know where to go, any road will take you there. Please keep repeating that. Whatever progress you want to make, this where is very important in your life. If you don't know where to go, any road will take you there. Now, once you decided where to go, forget about the small things. Who will get the credit? Who will take the blame? Who will get the benefit? Who is the loser? These are all insignificant issues once you have decided where you want to go. The pot calling the kettle black. The pot calling the kettle black. This is the present concept. Oh, students padhna nahi chahte hain, they want to study. The students say the teachers don't want to teach. Both are equally black. Whom to point a finger at? This blaming game, the pot calling the kettle black, I'll come back to it in a few minutes. See, once we have decided where to go, then that should be the goal. We all get diverted by smaller goals, and this is what is written in the Bhagavad Gita. That what stands between us and our greatest goals are not obstacles, but clearer paths to lesser goals, shortcut. Kam chal jayega. Chalel, parvaile, all in every different language means we'll just do what comes without getting to the major goal. We take the lesser goals and the easier pathways rather than doing something which will last for a better, bigger goal. And we wander away from our goals, sway away from what we have to achieve. Now we'll have 1 second break. I'm going to show you the next slide, which is the gist of my topic. This is the father and the son flying a kite. And then the little boy wants a kite to fly higher and higher, nothing unusual. The father and the son have a fight. The son says, let the thread go, only then the kite will fly higher. You are holding the kite down, the child screamed. The father said, no, if I let the thread go, the kite, that is, the thread is keeping the kite up. The thread is keeping the kite up. And then the boy got very angry, like all the young blood, and he snapped the thread. Shantanu, what's the problem, Shantanu? So the little boy snaps the thread. And then you know what happened? This is what happened. They were flying a kite. The boy says, you're holding the kite down. The father says, no, I'm flying the kite. And the boy snaps the thread. And this is what happens with the kite. No matter what type of best manjas you have got from anywhere in Bombay, Gujarat, but still the kite lands upon a tree on an electric pole. This picture of flying a kite teaches us a lot. If all of you just concentrate on the picture, it will teach you a lot. The kite is your career flying high up in the sky. The spool that the thread is there is the entire CPU. The thread is your discipline and passion. The more the speed of the wind, the more the resistance, the higher you fly. It all depends on you. Your movement will decide how your kite climbs up in the sky. The entire training program can be oriented to the small basic technique of flying the kite. A lot of this, or a lot to learn from this. If you have understood this boy flying the kite, transforming a surgeon into a successful cardiac surgeon is given only in one picture. This is Anthony de Mello, one of the Society of Jesuits priests who has written wonderful books. He writes, wisdom tends to grow in proportion to one's awareness of one's ignorance. If you know where all you're lacking, you can improve. See, the story of the kite and the father is nothing new. If one understands, the thread which is holding the kite up is nothing but discipline. I repeat, the thread is nothing but discipline. What is discipline? The commander in the army shouts, attention, and the entire army falls in order. That is discipline. Agreed. All the children walking in a line to go to get food in the canteen is also discipline. You following a particular protocol in the theater, following a particular order is also discipline. Somebody wants to start round at 7 o'clock is also discipline. Discipline only means that a particular way of doing a thing which suits you and you follow it. That is what discipline means. Doesn't mean put your finger on your lips and sit in the class. If you want your kite to fly higher, you can't get the ISRO to launch the kite there. You have to assemble everything and climb meter by meter until you reach high up in the sky. I repeat, meter by meter. Every day you attend your class, every day you learn something, every day you operate, you're going a step higher, you're going a meter higher in the sky. The ISRO will not launch you there in the sky. You have to go up yourself. See, we are not discussing careers, but what I mean to say is that whatever you want to achieve in life, you have to gradually climb up, work hard, and achieve it. In 1988, when I was a trainee, I took 3 days leave and went to Nagpur to meet my father. And he took me to Dr. S.B. Joshi, who was the surgeon, those days FRCS. He said, Hare Vinayak, you're doing MCH cardiac surgery? You've taken 3 days leave? Who gave you leave? He said, as a registrar, don't take a single day's leave because you may never see those things again. I understood what he was saying. I felt very embarrassed, but that certain thing has changed with time. Those days, to get one potassium value, we had to ring up for 10 minutes, 15 minutes and get it from the lab. Now you get it in 2 seconds on the computer. Those days, the numbers of cases were 200 a year. Now the centers do 1,000 cases a year. Those days we had 1 registrar. Now we have 5 registrars. Everything has changed. So the registrars to say, oh, I worked for so many hours, my registrar should work that much is not correct. Is not correct. I fully say they should be given free time. They have got to work, but work means work. And when you finish your work, you go, because now all the gadgets are on the phone. You want a reference, you get it straight away. We had to go to the library to get a reference. You have everything accessible to you. So you make full use of your time and the rest of the time you relax. We have got no problem. But I still remember Dr. Joshi telling me as a registrar, don't take leave because you will never see those things again. So what he was telling me was the more I put in my CPU, the more thread I have, the higher I fly. After doing 500 cases, Dr. Prasanna says he can repair this valve. Somebody else says he cannot repair the valve. Why? Because he has been gathering that much experience. He has put in that much effort. He has taken that much pain to understand. That is why in his hands he can repair. In your hands, it will be a failure. So that much effort he has put in, and there is no substitute for this particular hard work. So what is lacking today is discipline and passion. We have to blame ourselves only for this. In this speciality, we get the last 2 students in the 3rd mop-up round. Just listening to that, I feel dizzy actually, that what a stage we have reached, that the students are not taking up this speciality. We have to blame ourselves for this. You go to the exam and you get a question, TA PVC 20 marks. And the fellow is writing for 20 minutes that answer. What all he has to write, God alone knows. He writes horizontally, the examiner reads vertically. Now, how to pass that fellow? A better question will be, discuss the levels of obstruction in TA PVC. That is relevant to his, what he can explain to you, rather than giving him such a broad question. And then during the exams, what happens? The candidate is passed because he's worked very hard, the internal examiner will say. Who said this is going to be easy? Super speciality means it's hard work. He has not done anybody a favor. It is expected of him. He needs to know the basics, especially when everything is online. He cannot say, no, the internal says, oh, he has worked very hard. And then the other side of the coin, the other candidate has hardly worked. The consultant of the unit wants to get rid of him. So what happens? Both the candidates pass. One who has worked very hard, and the other one who has hardly worked. So both have been passed. And what happens with them? Very similar to the kite which has no thread attached to it. Very similar to the kite which has got no thread attached to it. Other than the unit saying, oh, we have passed all 5 candidates, what else have we achieved? We have achieved nothing. I request all of you to find out what happens to these people when you leave them like this. Where do they go? What progress they make? What happens to the department? What happens to the particular specialty? I really don't know. And this is the cause of our present plight. The main goal is lost, and we are taking up lesser and easier goals. When we shift out our focus from what we have to achieve, we land up in this sort of a situation. The kite without the control on the thread is like the kati patang. Where it will land depends on its fate, on top of a tree, electric pole, or someone else's terrace. Wherever it lands, it is of no use. No effort. See, if we go around, you'll find many people like this, and we have got to make improvement in this particular aspect. The railway ticket joke. My registrar came early morning gasping for breath and said, sir, I want to go home. There's an emergency. I said, you need anything better? Your tickets and all that. Yes, sir, I've got my ticket. Show me the ticket. And when I see the ticket at the bottom, the date of booking is given there. If you see the railway ticket in small minuscule lines, when it was booked a month back. So what I'm trying to say is that honesty is required in this specialty, any specialty for that matter. You can't cheat. Discipline, and second comes honesty. I had another very sad experience. Somebody rang up and told me, this is the anatomy findings. The child is diagnosed to have TOF, and what have you done? I did a Glenn shunt for the child. Now you tell me, is this correct? We have to admit that we cannot know everything. Most important. It is better to send to somebody who does this regularly rather than opening the child and for a TOF or biventricular repair, you do a Glenn. Tell me, is this correct? And this fellow has spoken to me on the phone and said, "Arey, maine Glenn kar diya, sir. Main kya karta aur?" Very wrong. I felt very bad. Vijay, who's sitting here amongst us, I went to him. He's like a son to us. I went to him to learn the Ozaki procedure. If I had given him one phone call, he would come and say, "Sir, I will teach you." He's my student. But I said, no, I'll go there. I learned and I came back. And then when I at my stage can go and learn something, then I find no excuse from anybody else to say, "Ye meko nahi aata hai." If you're interested, go learn and come. Why don't you want to pick up something from someone else? Vijay taught me Ozaki. I've come and done 6 of them now. I'm very proud. So when I can learn at my stage, when I'm 64, 65, I'm sure all of you are younger to me. What needs this needs a lot of passion and discipline in order to scale higher and higher in the sky. Without passion and discipline, you can't scale higher. 100% effort gets 100% results. If you say I'll put 50% effort, 50% effort gives you 0 result, does not give you 50% result. Now, the other aspect is that the stress of the specialty, when you're operating, I've given all this thing, what goes on in the surgeon's mind. If he's standing on the right side, everything goes on in his mind. If he's standing on the left, he's worried about what time the cafeteria will serve hot dosa. The fellow who's operating, he has to go through this complete stress. So it is a stressful job. And what are we trying to make? We are trying to make leaders out of our trainees slowly, because they have got to lead the theater. Unlike other theaters, this thing is one person oriented theater, only one pilot, only one commander in the theater. And I'm very, very particular about this, that you stand there and you give commands and you take over the leadership. Like the seed, if the seed wants to become a tree, it has to give up its existence as a seed. You cannot be a seed and you cannot be a tree. Either you become a tree or you become a seed. Either you follow the sutures and push trolleys and take the patients, or you become the surgeon and start giving commands. You cannot have a dual existence. So my suggestion is, please grow into a tree. Give up the existence of a seed. Only then can you can be of some use to society and carry on the legacy that has been imparted to you by your mentors. I had one surgeon, and in that surgeon was the theater used to be called a shrine, because everybody in the theater is praying. So I said, oh, that's a very good thing. Why everybody is praying? So they told me, we are praying to Almighty so that he can finish the surgery fast. We are fed up. So we should not have this sort of a surgeon that everybody is praying for the surgery to get over. I hope you have got the message. Because why? He has never given time, never disciplined himself, never thought that he should do better, never has thought he has to do his best. And he has to, it has to come from inside, that I have to perform better. No wonder everybody prays for him. When this topic was assigned to me, I sent out my feelers to everybody. Everybody has contributed 2 to 3 slides. This was given by Ram Prasad from Madurai. He says technical skill is most important. You have to have years of training and practice. Then knowledge. He said you have to have a good grasp of the subject, and you should be willing to update from time to time. That is why these CMEs and workshops you must attend. It's not the question of me making fun of Shantanu or making fun of somebody or talking and laughing and eating and drinking, but you attend because you will learn something more. Even if mitral repair you have done, you go and attend Dr. Prasanna's class or somebody else's lecture, you will learn something more from his point of view, which you did not know. So it's very important that you have to constantly keep learning. Decision-making skills. This at the spur of the moment, you have to decide what is to be done. And this comes only with your experience. How much thread you have in your spool, how much memory you have in your CPU. Otherwise, you can't do this. Communication skill. This is a must. When you are standing on the right side as a leader, when you say something, the entire theater should fall in order. I'm assisting so many of these boys to operate, but I never open my mouth loudly. I prompt the surgeon to give a command. Come on, Roy, tell them to go on pump. He'll say, okay, on pump. But I never give a command. I make sure I train the person to grow. This is very important. Whenever I'm sure you'll land up into problems, complications, and you will be fed up. You're so tired, you don't know what to do. But you have to put all this at the back of your mind and proceed. Resilience is very important. You can't run away from. Sometimes you're just fed up. You say, okay, declare karo mara usko, meko ghar jaane do. No. That is the time when you should put in all your effort, call help, call somebody, speak to him. The other day I had a problem. I rang up one of my students. I said, this is the problem. He said, no, sir, you do it this way. I did, the patient went home. So you must always do this. You have to have, whatever complication, put it at the back of your mind and proceed. And the passion. You have to have a big passion for this. Mujhe ye karna hai. Till this passion is not there, whatever I say is all going to go waste. And a commitment to lifelong learning. Every day you should learn something. Every day you should teach. What happens with this? The day you think you know everything, your downfall has started. At one stage in CMC hospital, we had a very high mortality for aortic valve. Stanley John continued to operate. I always say we lost 22 patients in a row. For Stanley John, Vivek is laughing here. 22 patients in a row for aortic valve loss, but he never gave up. He kept looking, kept looking, kept looking. We had the bottle with the pressurized thing and the cardioplegia going by that. Then we changed to St. Thomas's solution. Until today, we don't have a problem for aortic valve. So what he did, not that I mean, hats off to the man. I've got great regard for him and Dr. Jayaraj. But those 22 deaths, he put at the back of his mind and he said, where is the problem? What is the problem? Then he started St. Thomas and our patients started going home. What a wonderful thing. This is Pankaj Kaul, one of my colleagues, classmates. And he sent this. He said, we have to be very methodical, logical, and not given to impulsive decision making. And when things go wrong, as they surely will do at times, you get progressively calmer and you think, he said. And this is the quality which Stanley John had. You get progressive calmer and think, you can then think better with all your vast experience and knowledge, and you can bail yourself out. A combination of technical skill, flawless surgical temperament, and inexhaustible endurance. If you think that you can do just 2-minute, 5-minute procedure, take the money and go home, no. You have to have an inexhaustible endurance. These are some other slides given by the other persons that, the institutes want to fill up seats. There's no scrutiny. I went for one exam and one candidate came and he's telling me, I said, what about the left to right shunts? He said, sir, my congenital heart surgeon is absconding. The student is telling me, I said, you cannot talk like this. You can say, sir, we don't have a department to run congenital heart, but don't say that my surgeon is absconding. I said, for that particular answer of yours, you will have to take the 3rd exam from today. So we don't want such things. We have to have a proper enrollment for these particular institutes. Then all these other points have been given. The 3rd point, unsure financial stability. This financial stability, in my days, I was getting a salary of 643, which was enough. But now the registrars need to be paid. They have got their wife, their child, their parents, their housing, the accommodation, everything to be looked after. For heaven's sake, don't say that I got this much salary, so they should be paid less. No, they should be paid more because they are the ones who are running the whole show. They, registrars, if you pay them well and treat them like registrars, treat them like proper persons, like young doctors going to become the surgeons for tomorrow, pay them. We cannot deprive them of small pleasures of life. We do not have a mobile, we work, but that fellow needs a mobile. You want him to come with the references tomorrow morning, he needs a mobile. Then why do you say you don't pay him? You have to pay him. The registrars should be paid nicely. So, Pandeyji, no talking. Huh? Now, the other thing are the system issues which are there, lack of opportunity and all these things will come. But, along with this, what I have been saying is the most important one. Now, this one, I want all of you to concentrate, though you are tired. So, Buddha, so many people are listening to you, but they are not enlightened. Somebody told Buddha. So Buddha said, oh, you go and ask my students what they want. So the man went to each one and asked, and they came back. Some was there, and the replies was, some wanted to serve him, some wanted to get married, some wanted to be celebrities. Then Buddha said, see, nobody wants to be enlightened. So why are you telling me that they're listening to me and not getting enlightened? They don't want to be enlightened. So if you want to be successful, you have to say, yes, I want to be successful. And then only the transformation will start. And now this is, we have to commit ourselves to being enlightened. And this is the story for being successful. And this is the last one. Everybody wants to go to heaven, but nobody wants to die. Everyone is smiling now. You want to go to heaven, you want to die, you have to die. If you have to be successful, put in your best effort. If you want your patient to go home, do your best. And then only you can achieve, you can be successful. Only then. I cannot transform you, you cannot transform, you cannot transform any. You have to transform yourself. The day you decide that I want to become better, I want to improve, then you have done your job. And I have done my job. Thank you very much. Thank you very much for your time and attention.
Thank you very much, Professor Shukla, for enlightening us on this subject, very important topic, one of my favorites. Any opinion, suggestion from the audience, or otherwise we will move on to the third talk of this last session, after first session.
So thank you very much.
Sir, I have one little question.
You never have a good person.
Sir, one of the slides was highlighting about the candidates issues in this training difficulties or issues. So, because I have seen that in various places there are different issues which really one of was the lesser training period and the longer learning curve. So I found that in UK they run a wet lab program, and US there are the boot camps for the surgical residents in training. And that I found that really helps because it's all about repeated practice. So in order to have a practice in a wet lab before they really go on the live patients, so that takes away that the issues related to the learning curve. And they can certainly make a better surgeon. So do you think that is something that we should consider in calculating our training curriculum for MCS candidates?
I don't know, Sanjay, how to answer your question, Dr. Prasanna.
I have a personal experience with this. I'm sorry to say, so, because you use that thing, I did exactly that. Can you imagine the problem with students today is the entrance exams where they're focused only on the qualifying, I mean, and MCQ. I give you an actual example that I did. I conducted a tricuspid valve and mitral valve wet lab. Made them. I have a very standard protocol. I call it a decomposition of hand movement. I tell them, you for the first 10 years do the way I do. After 10 years, if you are doing the same way that I do, I'm disappointed with you. Is what I tell. So first 10 years, do it my way. So I decompose. This has to be there in forehand. This is it. You repeat many steps. Sit and make them do tricuspid valve with that. Do everything. Now the problem is now I tell them do the tricuspid valve repair. I always start with tricuspid valve so that they get the feel of thing and then go to my. I ask them now, this is all after taking. This is the anterior view. The several stories in the chapter. Why? Because they have all been trained to eliminate and get the answer. I am not working. There are two questions I ask every student when they join. What is the pH of water and diet of heat now? pH means the percentage of people who tell that the pH of water is 0 is nearly 90%. It's very difficult to make shit shine. You have to burn the shit, compress it, and make it into a dye. But today we are not allowed to do that. I can't compress them to 10,000 atmosphere. I will be thrown out. Personally.
Thank you, Dr. Prasanna.
Thank you so much. So, no, I think we are running off the time. So we are moving to the last speaker of this session, Professor Gorango Madunga. He is going to speak on a very important topic, that's the recent trends in the tissue valve technology. Have we reached the conclusion? We all know Dr. Gorango Madunga. He was with us for many years, now being to the Vedanta. And over to Dr. Madunga.
Presentation.
Session one. Session one, session. Okay, thanks.
Very good morning, everybody. It is my proud privilege to be here, and heartfelt thanks to Professor Agarwal sir, Shantanu sir organizing to giving me this privilege. And after such a beautiful motivational talk by Professor Shukla, I am speechless. I think I should not take much time. And this topic is very relevant, and I'm not going to enlighten somebody something new, nothing new in this topic for me, my side. I can just share a little small experience of ours, how we proceed, how we are doing, and what about the guidelines. Whenever there is a single question and there is multiple answers, and we presume that there is no right answer. So with that perspective, I would share my thoughts about the recent trends in tissue bulbs. As you know, what I am going to say, everybody knows, nothing new. But to keep the perspective clear, I have to tell some things. So valve replacement surgery is the best thing for valvular heart diseases. We are not going for repair and replacement topic. Repair versus replacement, that is a different story. As you know, at present, there are more than 2 lakh valve replacement worldwide. And this number is going to increase phenomenally. And it is predicted by 2050, it should be around 8,50,000 per year. Replacement I'm talking about. So there are 2 types of processes we use: mechanical heart valves. All if you know, they are made of metal and polymers and metal alloys. And we have biological heart processes, which are of 3 types: xenograft, autograft, and allograft. Mechanical heart valves are durable, very highly thrombogenic, which necessitates lifelong anticoagulation. The problem with mechanical heart valves, though they are fantastic valves, this anticoagulation is a nightmare. Compliance and this INR management is very troublesome. And we say that the valve will last forever. The patient doesn't last forever, unfortunately. In contrast, bioprosthetic heart valves do not require anticoagulation therapy and demonstrate excellent hemodynamic properties similar to those of native valve, but they are not without cons. Their durability is limited because of the inevitable structural valve degeneration, a nightmare for tissue valve, which requires redo valve surgery, a major surgical intervention. So we have pros and cons on everything, and what should we do for our patients, which are gradually increasing in time. So these are the evolution of the different groups of valve. You can see bileaflet, monoleaflet, ball cage valves, stented porcine bioprosthetic valve, stented pericardial valves, and stentless porcine valve, balloon implantable these transcatheter valves, and self-extendable trans. These are the evaluation of different mechanical and tissue valves. And these are the complication. Complication not only happens with mechanical valve, it also happens equally with tissue valves also. So, but the complication rates with this anticoagulation related problem is quite significant. As we can see, this, everybody knows that both bleeding as well as thromboembolism are equally important. We are losing around 4 to 6% of patients per year with this complication. So this is significant when you consider the absolute number of mechanical processes implanted per year. This is a significant number of patients. When even 2% of patients succumb to this problem, there is huge number of patients succumbing to this anticoagulation related complications. So what is that worldwide trend in choosing this mechanical and tissue valve? You can see this is an old data actually. They have shown that, you can see that in 2000, the percentage of tissue valve and biological valve used in United States around 60% to 30-35%. But in 2011, it has rose to around 80% versus 13%. It is in 2011, and the percentages keep on increasing day by day. This is United States. Again, aortic valve, mitral valve, same scenario. The uses of bioprosthetic heart valves is increasing day by day. The same data they are showing in ESCTS portal cardiac surgical database. Even in combined surgical procedure, the uses of bioprosthetics is increasing. This is a trend in Japan, mechanical versus bioprosthetic. Again, you can see the percentage is gradually increasing over decades, significantly towards preference towards bioprosthetic valves. So everything is not good bioprosthetic valve. The deadliest problem with the bioprosthetic valves that certainly you will require a redo surgery if patient survives that 10 to 15 years of period. So what is structural valve degeneration? I would like to see a few slides on this, and then I will share my small experiences. It is an irreversible process manifested by gradual degenerative changes in the processes such as venous growth, leaflet fibrosis, calcification, delamination of connective tissue, and leading to emergence of rupture and perforation. So this is not one-way gate. There are multiple things responsible for this bioprosthetic valve degeneration. And we must consider that it is not an inert subject we are putting in the body. You can, if putting a homograft or autograft, they are living tissue. And these are treated living tissue we are putting. So there is multi-pronged attack on this valve. First and foremost is prosthesis related problem. Second is recipient related problem. And third portion is mechanical forces acting on this valve. So there is three-pronged attack on this tissue valve leading to their structural degeneration. So the rate of structural degeneration in this valves increases over time, particularly after 7 to 8 years of implantation. With conventional stented bioprosthesis, the freedom from structural valve will be around 70 to 90%. And after 15 years, it is 50 to 80%. So this is a good slide taken from circulation to show that how the degeneration occurs when bioprosthetic valve is implanted in our body. First and foremost is degenerative process. That is processes related problem. You see that the tissue valve has treated tissue valve has two components. Number one is the cell debris and remaining cells, treated cells, and another is matrix. The both components get attacked by circulating calcium metabolism. In normal circumstances, when living cells, the calcium is effluxed out by ATPase pump, protein pump. But when that mechanism is lost, so the influx of calcium is not there. So the concentration of calcium to be found in million times more when you compare it to natural cells. This calcium causes the problem in bioprosthetic valve. So this is the degenerative process related to processes related. Again, the second mechanism where the native valve get atherosclerosis, the same thing happens with the tissue valve also. That is body's mechanism, immune mechanism. They all get activated, and these three-pronged attacks can lead to degradation of your tissue valve, leading to bioprosthetic stenosis and regurgitation. So this is the most troublesome problem for biological. Otherwise, it is the fantastic valve because hemodynamics is good. There is freedom from anticoagulation. And once you put a tissue valve, the patient can remain happily for 10 to 15 years of life. So this is the freedom from complications, but certainly they will require redo surgery after a certain period of time. Again, the same thing, I'm not elaborating these things, this three-pronged attack foundation. This is another slide to show that when you put it valve in your any aortic and mitral position, how the mechanical forces acting leading to their shear stress, pressure and motion, they also leads to degeneration of the tissue valve. As mechanical valve are inert, they are not forcing to the stress, but these tissue valves, they are exposed to this mere shearing efforts of three-dimensional, leading to their degradation. So this is called cyclical loading. Once a cyclical loading of this valve, opening and closing valve cycles. In vivo, they may last billions of cycles, but when put in the vivo in human body, this multifactorial lesion do not allow them to last as they were in experimental lab. So this is also a significant factor in degradation of the tissue valve. So how can we improve this problem, this structural valve degeneration? There has to be the three mechanism destroying them should be taken care of. First and foremost is improved valve design and a novel class of linking agents to reduce the mechanical stress. Second portion, anti-calcific treatment to prevent dystrophic calcification. And third is how to decrease the immune rejection from our body. So these three way people have started thinking about this mechanical valve, this tissue valve, to giving them a more durable, more durability, so that it can become in sometimes an ideal valve, which is not exist at present time. So this is a brief how the bioprosthetic valves have grown to this present stage. It is a first generation valve. See, this first used to use intact porcine valves, which used to cause hemodynamic problem because septal muscle was there, which was not reduced. Then the problem was high pressure fixation leading to tissue damage. And there was no anti-calcification treatment earlier. So this valve used to last lesser. These are the valves with this first generation tissue valve. The second generation, this again intact porcine valves, but septal muscle bar was removed, and now started intact valves was gradually replaced by triple composite valves. 3 leaflet was procured separately, and they were integrated to give this valve. And low pressure fixation resulting to zero pressure fixation was achieved with innovation, but anti-calcification treatment was initial phase. It was not that good. So this valve comes under this category. This is second generation valve. Now, third generation with composite valves, triple composite leaflets, both porcine and pericardial design. The fixation pressure was nearly perfect at 2 millimeter to 4 millimeter mercury, universally accepted. This is the best fixation pressure, which will not degenerate the tissue valves. And there is improvement in the technology of anti-calcification things. So these valves started giving better results in terms of durability. Now, these fourth generation valves, they are mainly focused on better hemodynamics because their profile was lesser and implantability was good, and the anti-calcification treatment was further improved. Now we are having this latest fifth generation valves. They are lower profile. Their ventricular projections is lessened, and they can be used in minimal invasive surgery and sometimes transcatheter valves also. They all are becoming aldehyde-free storage because the glutaraldehyde was used to fix these valves as the main culprit found to be for calcification. And these valves also can be used in valve-in-valve technology. So these are the latest valves available till date, with all these three things in consideration to reduce their degradation and improve their survivability, durability. And one thing again, this with improvement technology, skills and perfusion technology, the risk of redo surgery has definitely decreased, but should not be encouraged. But this is another thing. Initially, it is carries 15 to 20% surgical morbidity mortality. Now it is less than 2%. So how to choose this is a very, everybody knows it from the residency, how to choose a ideal valve, everybody knows, but still, again, we should go through how we practice in our daily to daily life. We know that when to choose a mechanical valve and when to choose a prosthetic valve. They have told that the this is the, I think, how to choose a mechanical valve. The informed patients want a mechanical valve. This is the first and foremost indication now they have put. Age has gone a backside 2 days. The informed patient wants a mechanical valve and has no contraindication for long-term condition. This sentence, this word, the preference of the patient is a very manipulative sentence indication actually. And we have to be very honest what we are dealing with the patient, because Still date, there is two way of offering a processes to patient. Either we call it as cafeteria approach. You come to us, we offer everything, you choose your valve. And one other is parental approach. You guide the patient what to choose. So we have to take some balance, what to suggest, what not to suggest with our intention at right place. So this in our context, in our subcontinent, this context that preference of the patient should be taken very seriously, because most of the patient will come and say, Doctor Sahab, jo aapko acha lagta hai wo lagaiye. This is a very dangerous thing. Because you are then at a whole responsibility of taking your own decision. Your intention, everything should be on right track. Otherwise, it is a very, very dangerous thing. So I'm very particular about this indication, and this is the first indication nowadays: patient choice of the valve. The patient is already on anticoagulation, so there is no question of putting a tissue valve. The patient at risk of accelerated bioprocesses like this medical condition. Most of the patients, few patients comes to us with CKD. CKD patients are very common nowadays, requiring a valve. Better to repair mitral valve in these cases. And initially we thought bioprocesses will do good because they are on regular hemodialysis and there's a risk of bleeding, etc. But again, complications are right, but tissue degeneration is very fast in biological. If you put a bioprocesses, it doesn't last more than 5 to 6 years in CKD patients. So it is better to put a mechanical valve in CKD patients who require daily hemodialysis. And again, the age comes to last. The patient is 65 years age and long life expectancy. These are mechanical valve indication. Now, tissue valve, again, the informed patients wants a bioprocesses. Very dangerous sentence. A patient, he wants a bioprocess. Most of the patients in our setup are not up to the mark that they can choose, but they should be, concerned doctor should adequate time, explain them what is the pros and cons of the valve, and then take a guided, informed consent. Others are lesser. Age comes to third, and the fourth topic is also important. The patient is a woman of childbearing age. This is also everywhere this written that they should go for a bioprocesses. And when we used to practice here in SGPGI, we used to put a lots of patient mechanical valve, and they, when childbearing age, they delivered baby also. So it depends on your experience and institutional practice, but it is a guideline that childbearing patient, you should give them a tissue valve. Again, during childbearing, during pregnancy, there is accelerated calcium metabolism, and these valves will not last 7 to 8 years. This is for sure, and they will require another redo surgery very 7 to 8 years after their implantation. So this thing should be taken very seriously. So now come to the indication, how to choose a valve. Again, everything is told. You see, in both cases, they have written age, desire of the patient, and life expectancy. Indication and contraindication for warfarin therapy. These are the most important thing. Then falls after two category. Desire of the patient again comes first. I have already discussed how the desire of the patient can be manipulated by the concerned doctor. It is a very manipulative sentence. It should be taken care of. Everybody wants they should not take medication, and nobody wants again to do surgery. So you have to tell them properly what they want from this mechanical valve as well as tissue valve. The next thing, once decided, this is what kind of valve, mechanical or tissue valve. Then the second thing is which best valve is available for the patient, either mechanical or tissue valve. In mechanical, you don't have much choices. All valves are good because there is double lifted, there is tilting disc valves available. They are good. So there is not much choice. But in tissue valve, there are different generation of valves available. So once you decide that this patient requires bioprosthetic valve, which valve you should put? This is the important thing. The first consideration they have taken that the valve should be durable. It should last long. So this should be consideration. Second thing, hemodynamic consideration. That valve, this patient should not have PPM, patient process mismatch. In every patient, we should check effective orifice of the valve and take out the available valve, and it is its PPM. So the best available valve at that moment in the operation theater, you should put long duration and less hemodynamic, better hemodynamic profile. And of course, implantability issue, technical skill there should be there. So these are the things we should consider when choosing a bioprosthetic heart valve. these are different indications again. These are in vivo experiences of these bulbs. They are good, durable bulbs. So with this perspective, I should, this is a very small experience of ours. We have implanted 509 bulbs in last 3 years. Out of that, 340 were mechanical bulb. You see that 66% still were practicing mechanical bulbs. And we put around 35% bulbs bioprosthetic, 169 bulbs out of 509. I'm discussing only bioprosthetic bulbs. Out of 169 bulbs, these are the breakdown what we have put in these patients. And this aortic valve group, we have put 80 patients bioprosthesis in aortic valve group. Age more than 70 years, there are 19 patients. Age group 60 to 69, there are 48 patients. And 50 to 59, 5 patients. And less than 50, this is very, again, I am talking about the first topic, desire of the patient and informed consent. This comes here. Around 8 patients. I can tell one patient, he was very young. He was 38 years only, and he was desperate for a tissue valve because his lifestyle is like that. He's heavy. He consumes alcohol daily. He cannot keep medication. He was insistent, no way, I have to put this valve. And he has given written consent. We've taken written consent to tell this because it is a very dangerous thing. So we put this valve. Another patient, these groups is very tricky actually. Less than 50 years of putting a tissue valve, not indicated. Again, this first day comes in the first group, preference of the choice. 2 patients were in childbearing age around 20 to 25 years, so we have to put tissue valve. And another patient had malignancy, so he was on chemotherapy, so we put a tissue valve. Again, this is a very controversial topic. In chemotherapy, there is a higher degradation of tissue valve, but patient wanted because he had low platelets, around 45,000 on therapy, so we chose. Another patient is CKD and low platelets around 40,000. He denied a tissue valve, 39 years female. She went for a transcatheter valve, but cardiologist denied, they cannot do, so we have to put this tissue valve in this lady. So these are the aortic valve groups. Now coming to mitral valve, there is little difference between the age group in this group. We put bioprosthetic was 89 patients. See, you say 70 years group only 8%, 9% patients, 60 to 69 around 40%, but 50 to 59, this is a significant chunk of the patient. They do not fall in the standard category. Ideally, it should be 65, less than 65, we put a mechanical valve in mitral position. In mitral position, valve deteriorates faster. Despite that, the percentage of valve, you say less than 50 years, 50% of patients got a bioprosthetic valve in less than 50 years in mitral valve group. So again, patient choice group comes this group and some medical indication, contraindication. Out of this, I forget to mention one slide, we have done 27 redo surgeries. And this incidence is equal our last 3 years. Mechanical valve and tissue valve, most of the patient in mechanical group, there are I think 13, 14 patients, and all of them came in semi-emergency condition, stuck prosthesis. We have to do an emergency, semi-emergency replacement. But in the tissue group, all came relatively elective patients. They have put the valves 10 years younger patients, and we did elective surgeries on those groups. And this is the one thing very important in mechanical valves. If complications arises, they are rarely medical or surgical emergency. In tissue valve, they will give you some time. They can come to you, they can buy some time also. So this is another significant consideration one should think before putting a prosthesis in heart. Newer technologies, these are newer things, longer durable surgical valves, sutureless valves, and transcatheter valves. I'm not going to in details, but this I put only one valve till date because it is very costly, but this is very promising because the fixation technique they have changed and the preservation technique they have changed grossly. So there is free glutaraldehyde fixation. So there is no free aldehyde available in the solution, and there is no solution used. Actually, it is a dry valve, so there is chances of less calcification of this valve. They are claimed around 72% calcium content is less, and hemodynamic profilability is also improved. And the company claims that this valve will last more than 25 years. Hopefully, this lasts, and then we should, if cost comes under, then we can use this valve in our future practice. So, thank you very much. Have a nice day.
Thank you, Dr. Prabhu. for a lovely topic which you have shared. Being a cardiologist, I always felt that anti-coagulation is a big challenge. It's a challenge for cardiologists and it is a headache for surgeons as well. And surgery, and then you have to follow lifelong anticoagulation, INR, and all those things, different labs, different parameters, the dosing schedule, and all those things. So, my concern is that once the person is on anticoagulants, newer anticoagulants, and all those things, in spite of all this, we do a lot of patients every month coming back to us with some complication and all those things. So I want to have an opinion from my colleague chairperson, Dr. Shukla Singh, for comments over the role of tissue valve. And I'm sure down the line after 40 years, to understand the hemodynamics and the newer technology and the newer role of tissue valve, where you don't need to use anticoagulants lifelong. So comments from Dr. Singh.
Of course, the anticoagulation is the issue. Durability, of course, mechanicals are better, but the bioprocesses is now the trend, and there are much better valves available now, which has a life of around 18-20 years. So, of course, there is a limitation at this moment.
As Dr. Majumdar has already told, yeah, as you go, as the age advances and if you use a macrostatic valve, the degeneration rate is much lesser. So what my practice was that I used to use it beyond 60. And the anticoagulation regimen, what I was following, we used to give along with acetone for a period of 3 to 6 months. So if that part was taken care by the cardiologist in our place. So that was the regimen, and normally after 6 months, I think I would be stopped and they were continuing open. So that was the antiplatelet what we were using where I was in Turkey. So, of course, I think we will also go about that.
Yeah, ma'am. I would like to our esteemed panelists there, Dr. Shima and Dr. Shukla, please comment upon this topic. What
And comments from Dr. Vivek Kanari as well.
Can I make one comment? I have a one.
Dr. Majumdar,
Sir.
I have one question to you. This in the you mentioned about they all extended by process.
Yeah.
So there was a time when there were a lot of there was because quite a few papers that came up about the stentless by process. And some of the centers they were doing it. They showed all the advantages of bioprocesses, including the hemodynamics, which is the issue related to this stent. So, though it was technically challenging,
Yes.
challenging work, and that's why probably it did not pick up as it should have. So, where do you think is do you think it's going to come back, or do you think it has a future role? Because you have advantage now. The question, because there are only two issues. One is the your anticoagulation. And the other one is the longevity of the valve. None of the valves we think is going to last forever. So whatever technology happens, they are going to degenerate because of various reasons. We don't have a control on so many of them. So if there is a question of redo now with this newer technology that is available valve or TAVI, if you have a stentless, the TAVI will be much better way of doing it. And rather than having a standard valve which degenerates, standard bioprocess, and there. At the moment you put another one, which is going to be smaller than what it was before. So what do you think? Is there anything?
No, sir, definitely, definitely stentless blast is better in comparison to stented processes. But the question is, this handling and technical skill is much more in comparison to the stented valve. Even the hemodynamics in stentless is better in comparison to stented. Again, one can do, but it has to be practiced in mass. We repair lots of valve replacements. So if it is not reproducible with that's why the valve is not picked up actually.
Thank you. Dr. Prasanna, please. One small clarification about stentless valve. If you see all the stentless systems actually coming off market, the reason was not that the surgeons were not skilled and the Tyrone David was skilled. The problem is Tyrant David himself stopped it, because why? When they degenerated, he found that there was extensive cicatrization, the porcine and Berlin, there was extensive cicatrization around the coronary ostia, and the redo that was required was tremendous, such that the mortality was very high in this hand. Even when the Toronto SPV was specifically stopped, though he got it. The problem was not the stateless nature, but the later cicatrization that occurred with these plants. That is why they were withdrawn from the market. I think now the only centers where we have is the freestyle, and even that
It's not used.
significant. That is the real reason why the commercial centers were removed from the market.
Okay, Dr. Vivek, please.
Two things. Actually, this debate of
Take a mic, please.
I again, Prasanna would perhaps like to comment, homographs also behave dramatically in the same fashion. You have to revisit a homograph and replace a homograph. That could also be a
Nightmare.
pain in your posterior, if I may be politically correct.
That is why if I put a homograph, I don't put it as a phase of not. It will either be kept as an inclusion, or you have to go such carrots up. Otherwise, don't try to do it as a freestanding open rule. Because I mean, going back in is the definition of a nightmare. They had this was basically in Rocky Mountain. See, there was a lot of push for by O'Brien and others for homograph. We were also part of the homograph, and we do use it. But the important thing from there was that why this thing dipped afterwards was that the radios became extremely difficult. If you want to have it, be skilled enough to do a standard subcoronary where you can, then the excision becomes easy. But if you're putting it as a full route, put it as an inclusion route where you can get out. But don't do it as a freestanding route. You'll be sitting with the hammer and chisel.
Chisel and hammer. Anyway, lot of the surgeons here, so the opinion of the house is thought on how long do you anticoagulate after a virus? Dr. Abba said 6 months, I personally do it 3 months. There are people who don't anticoagulate at all.
Yes.
I don't anticoagulate. See, one of the important things that I do is I always try to put a mace. I always really to say explore the LA appendage. And you can put a water. See, there are arguments coming now that if you put shortly in the anticoagulation, then you get more
No, forget it. Michael, I'm saying for even isolated aortic aneurysm.
I put only aspirin and aspirin and someone questionable about the The major driver for this was actually the story to go behind why anticoagulation was pushed was a court case in Germany. And Frederick Moore was telling us we were forced to anticoagulate because a case was put where there was some thrombosis in one particular case, and because of that, and in Germany, the head of the department is always good. Even though that's a system there. So one particular unit got very badly sued, and that then so all of these people were forced to anticoagulate, and that's how the story of anticoagulation covered.
The point is, as
I don't bet.
he was pointing out that we don't publish. As surgeons collectively as a group, there is a lack of guidelines approaching coming out of Indian Association as to what should you do. You see, you don't anticoagulate and you get sued. You have nothing to fall back upon. The ISCTS guideline mein likha hai sir, and we are ISCTS members and we follow. I mean, correct me if I'm wrong.
No, that is because we are taking the AHA guidelines and every other guideline, but we don't have.
We don't have our own.
Every time it's about the hard data. We don't have hard
The
data.
second thing is, again,
We are short of time.
yeah, just one more, quick observation. This is from second generation aortic valves data coming out of Edwards themselves. Isolated second generation aortic valves degenerate faster than a patient who has had an AVR and a coronary combination with second generation. And the difference Edwards people and I work with Albert Starch, who Starch group pointed out, was giving statins. So as a rule, if I put in a bioprosthesis, my patients go home on a low dose of statins. And then again, in failure of any definitive guidelines by ISCTS, I would like to poll the house, how many of us put them on statins?
Yes. Steady.
So with this, we are already late by 45 minutes.
Oh, yes. Yeah.
So we are, so we are going to close the first session. Kindly give a big applause to all the speakers. Thank you, my colleagues.
Thank you, sir. This was a wonderful session and a very nice discussion. And Vivek, I think because Dr. Hiramat would be here, he is our secretary of the association. So we should put this point across to him. And as other societies are taking out their guidelines, we can also form small groups and then take out these guidelines for Indian patients. Because we have data with us now in some form or the other. We have published papers also from India. And so we should take out our guidelines. Now I would invite the chairpersons for the second session, that is also on valvular heart disease. Dr. Dharmen Srivastav, Dr. Vijayant, Dr. Sankalp, I would also request the panelists of the session to be on the front row so that they can participate in the discussion. Dr. Rajeshwar Yadav, Dr. Shashank Tripathi, Dr. Sanjeev Kumar. I think they are all outside. Outstanding panelists. And Dr. Amrish Kumar. So I think over to the chairpersons to start the session.
We are running about 1 hour back. Then I straightforward call the speaker to Dr. Vijay Kumar from Coimbatore. The topic is change and paradigm shift in Indian scenario. Bodaki aortic neo.
Yeah. I'll go to slideshow. Share slideshow. Morning, everyone. My talk is on paradigm shift in aortic valve replacement using this new technique called Osaki aortic valve reconstruction. From out of I would like to express my sincere gratitude and thanks to Dr. Agarwal for inviting me to give a talk on this 5th Founders Day meet. And I disclose Mr. Shankar is a distributor of Osaki for including me as one of the proctor in doing this Osaki in India. And I would say I have not included any recent changes which was made by Professor Osaki in my presentations. So surgical options for aortic valve disease, we all talked recently just now. There is no one-stop solutions. It is starting from cath lab to surgery. Surgery includes valve repair, replacement, and Ross procedure. And now things comes to a non-Ross options. So, I mean, we just a little bit of for a postgraduate or any training candidate. So percutaneous balloon it increases the effective orifice area by splitting the tissue in the area of least resistance. What does it mean? It not in the commissure. Usually, invariably the valve leaflet tears and thereby increases the valve area. But these children will come back to you with the aortic regurgitations. Whereas the surgical valvotomy definitely offers a direct visualization and thereby
very meticulous commissurectomy can be done, but of course, it needs a open wound and a heart lung machine. So coming to the atypical repair, it is compared to the mitral repair, it's actually difficult to reproduce. Numerous techniques, the lack of standardizations, what Dr. Elquery and Schaffers can do, not everybody can do it, so it's difficult to reproduce. So atypical replacement, yes, it's easily done, but it has its challenges, especially in a smaller aortic canal diameters. Just now we talked about anticoagulations and well-rated complications, including early degeneration. Coming to the mechanical AVR, yes, it's easy to implant, definitely is most durable, but it's not, there's no growth potential, especially in younger individuals, and high chance of PPM in a children, or I would say in a young adolescent, about 20 to 30% by the end of 10 years. The recent paper from Annals of Thoracic Surgery talked about younger age of surgery and smaller processes are risk factors for death during a follow-up after mechanical AVR. Biological, yes, they are very high profile. They're not frequently used in younger individuals. And again, the durability is questioned. I mean, 50% only durable by 10 years. And aortic homograft has a limited availability in our country. And we talked about homograft calcification. Obviously, somebody has seen a homograft. It's very bad when you do a redo on them. Coming to the RAS AVR, yes, definitely it's advantages of having a growing autologous tissue. The RAS, it restores the survival curve. That's what we talked even yesterday. And previously, the aortic valve nearly match the survival curve is a RAS operation in an aortic position. It also eliminates the lifelong disadvantages of mechanical and xenograft valves. But remember, it's technically more demanding, a very high steep learning curve, and you are converting a potentially one problem into a two-valve problem compared to a single valve problem. And again, in our country like us, we don't have a freely available homographs, and it's very expensive overall for the patients. And again, RAS is not possible for everybody, especially those who has a post-balloon pulmonary valvotomy or a leaky pulmonary regurgitations and patients with truncus. Again, we have to be very cautious in doing a RAS procedure and dilated aortic route because the RAS failure is very high in this kind of patients. So that is how the paradigm shift happens. So the shift actually has happened in 2008 in Japan, but we are slowly starting to pick up on that shift. What are the paradigm shift happened? So thanks to Professor Iwasaki. Actually, even though this is kind of modified and everything, but the original description even given by Dr. Durant in early 1950s and 60s. So, but the new identity is given by Professor Iwasaki based on his standardization, his techniques. He started doing the procedure since 2008. So what he did essentially he replaced the damaged aortic valve using either native pericardium or a bovine pericardium. It's a 3-leaflet reconstruction using the native tissue or a bovine pericardium. So this is what the results came out in Journal of Thoracic Cardiovascular Surgery in 2018, where he published his 10 years results. His average age of patients around 68.9 years, and the total number of patients were around 850 patients. So 850 patients, median adult, mean age of around 68 years. He concluded saying that freedom from regurgitation was 10 years close to 86%. So what are the advantages we talked about? This previous session, we all talked about anticoagulations. Yes, definitely the Iwasaki avoids anticoagulations. It's very much reproducible because standardized set, everything is marked. It's very less expensive, and this gives excellent hemodynamics. The gradient at the end of Iwasaki AVR, it will be around 10 to 15 at the most. So I have few slides. I'll just go through the few slides about my operative steps. So the basic sets are the leaflet sizer and the cusp sizer, and you have a plate to fix the pericardium. What you see in the right hand and the left hand corner is a leaflet sizer. I mean cusp sizer. In the right hand corner you have a pericardial leaflet sizer, and the size varies from 13 millimeter all the way up to 35 millimeter. So you can do this Iwasaki reconstruction as small as a 13 millimeter root up to 35 millimeter root. So this is what I talked about. One in the middle is a leaflet sizer. One on my right hand is a cusp sizer. So how do you? So you do a sternotomy, prepare the pericardium, harvest the pericardium, and treat in children or young adolescents, if you treat it for 2 minutes, it's more than enough. Whereas in anybody above 65 or 70, you would see the pericardium is very thin, where we treat it for about 8 minutes. So glutarate head treatment for about 2 minutes in young individuals, adults are above 60, we treat for 8 minutes. After treating it for 2 minutes, then we just wash the basically get rid of all the glutarate head with a 3 separate saline wash, and each saline wash lasts for about 6 minutes. So essentially within 20 minutes, you get your pericardium ready. By the time somebody opens and harvests a pericardium, when you're trying to go on pump, your pericardium is already ready, and you can do one of your assistant or PA, whoever is helping in the theater, they can do this. Just a few small videos just for this is a plate where we fix a pericardium. Remove all those adventitious over the pericardium. So once you prepare, okay, once you prepare, okay. So you do iototomy, go on pump, do iototomy. So usually I tend to transect the aorta and make an oblique cut along the non-coronary. So it's like open book, anybody can see, and even with a lowermost assistant in your unit can assist you with this procedure. So yeah, aorta is transected. So just, mainly if you have a big aorta in an adult, you don't need to do it, but generally I do this. This gives a better exposure, and also you can do a root enlargement for a small root with the same incision, Nix or Menageon, whatever you want to do, you can do this. So the exposure is very key. So once you exposed it, excise it, you respect the native commissures. That is where your reference point, and mark appropriate. In the case of bicuspid or unicuspid, you may have to move your commissure in order to accommodate tricuspid Osaki. So this is nothing. This is I just show you. And actually, ideally, when you start doing this Osaki, you start off with a rheumatic. You can see this. It's a tricuspid. You thickened and retractor leaflets in a rheumatic patients with the severe AR. And this is the ideal case to start off doing your procedure. Even if you have a calcified valve, just excise it. You don't need to have much tissue because you'll be able to suture it. Because after all, you're suturing the pericardium to the annulus. There's no rigid material you're trying to suture. So once you excised it, just measure. This is what I talked about, the cusp sizer you use from commissure to commissure. The sizes available from 13 to 35. This basically the preoperative echo annulus diameter of the particular patient will give a rough idea. So annulus is about say 19 millimeter, 21 millimeter. You can go either 1 or 2 sizes above or at the same size. So 23 millimeter annulus, either you take 23 and size it, or 21 or 25, you will get there. So I just want to show you how you size it. So you can see this pretty much exposed nicely. You can see an automatic cut very beautifully. And then you take the sizer and just size from commissure to commissure. This is very important point of, step of the operation. We tend to use the same size for all 3 sinuses, but you can use different sizes. Professor Osaki initially did that, then finally he changed his technique recently. That's what he said in Bangalore meet last month. So, but you can do either way, I suppose, both will give the good result. So we have taken a 25 here. So the exposure is essential, measuring is very essential. Then obviously the pericardium. Take the pericardium, have a good marking pen because these marks has to be seen when you're suturing it. 3 important marks. One is in the central central mark, then followed by the big bite or the last one. Last one we call it as a big bite or a double dot, and the third one is a wing extension, which is not very clear in this thing. I'll show you this. You can see here. So the pericardium is prepared, and this is the leaflet sizer which we talked, and this marking has been done. That's a central mark. You can even count how many dots. It varies from size 19 to 35. And invariably start from 6 on either side, 7 and 8, and you have a wing extension, nothing but for a commercial fixations. The double dot is basically tells you it's the last but one dot or a big bite that it's going to close your subcommercial area, so that bite has to be done a little bit perpendicular to the annulus. The similar way you mark 3 leaflets and then cut them all. Okay, this is how it looks once you mark it. This is based on your annulus measurement. So then once you've done it, then you just cut the leaflets. You can use a different scissor. For the bottom, people use a straight scissor and curved scissor. Doesn't matter. Whichever way you do it, you do it. Maybe for the lack of time, I'll just skip this video. So once you have a leaf pericardium cut out, then you need to mark it onto the annulus, which basically the midpoint and the commissural. I'll just show you this. Now, initially we measured 25, and I'm going to mark the important markings on the native annulus. So that is a center point or nadir of the annulus and the 2 commissures. Right. You can do the same with all the 3 annulus. Basically, this center point has to go, your center point of the leaflet has to reach into the center point of the annulus. Maybe I'll skip. So and then comes the suturing. So you measured, you've taken the pericardium, you marked appropriately on both sides. Now you have to suture it. So when you suture on the belly, it initially is a very close suturing. So this is called 3:1, where from the midpoint on either side of the three sutures, we go very close. So 3:1 ratio. As we move towards the periphery, you can space out, you can widen it out. So that will become 1:1 as we move along to the commissure. This is what 3:1. You can see here that the initials are a little closer because that is the belly of the leaflet that is going to withstand the stress of the entire pressure. So that's why it needs to be given a nice important at the level of the middle part of the annulus. So when you start a suturing, we always suture in the right because it's difficult to do it. So better to do the difficult part first. So the first suture has been taken, and you move along to either commissure and once you're done with one, go to the other one. So usually we'll do the right is the first because that's a difficult. Again, a lot of people asked me yesterday which side. So usually the smooth side go to the LV side. The rough side comes to the aortic side. That's the explanation which what we heard from Dr. Wasaki initially when he did it. Initially, he put the rough side on the LV side and smooth side on the aortic side. So he said he found a couple of patients has a platelet damage because of the flow turbulence. So he started reversing it. But as what have we learned that we've been doing the smooth side always go to the LV side. So I'll just go to the next. So you suture on either side. See the dot. This is what the marking is very essential. The dot is there. That's going to tell you where your bites are going to go. Then it's very easily reproducible. When you come to the left is easy to suture. Maybe you can. So the right is already been sutured. And the left is easy to suture. Sometimes what you see, the coronary's position may get buried. Instead of from the middle, it can go to the close to the commissure, where you can even shift your commissure to one side in order to avoid the coronaries. So once you suture, once you've done all the 3 leaflets, this is how it looks actually. The final look comes to like a nice 3 coordination, like the Namaste or Mercedes-Benz sign, whatever you want to call it. So this is how it comes. By looking at itself, this valve is going to work. For sure. So once you're done like this, so we are not doing anything, no stretch, anything. If you just with a little bit of suction on it, it's all the 3 leaflet comes like a cup into the cup and then just stays like that. So once you're done all the leaflet suturing, the second part of the important suture is a commissural fixation, which you can support with a pledget, usually the Teflon pledget, which is outside the aorta. How it, I just want to show you this. Yes, yesterday we demonstrated how you fix it. So it starts from the wing extension mark and the last bite, closes the both the leaflets at the level of commissure, just above the commissure, and come outside little bit above and lateral and fix it with the same at the front. Osaki straighten the needle, but we don't do it. We can do either way, whichever works for you. So you basically you have a 4 thread lying outside the each commissure, tie it onto the different. Okay, so this is what I talked about the commercial fixation. This is the last bite which came out. The second the big extension which comes outside and being tied with the felt. You can do additional commercial fixation if you like to, you don't need to do it. So this is how it looks. All the 3 pericardia meeting in the center with the good cooperations. So I just want to share our experience. So overall, we have done 65 patients, out of which aortic Osaki was in 40, or conduit was in 20, pulmonary valve Osaki in 5, mean age and weight pretty much like a young adolescent group, sex predominantly male. And we have done on adult patients more than 40 kilo as well. High distribution, BSA, I'm just skipping for the lack of time. And rheumatic is still almost equal. I would say 40% of the patients are rheumatic, and congenital is about 52%. Osaki leaflets pretty much we do for a 3 cusp for everybody's. And sometimes we have done a monocusp Osaki. I'll talk about it. Leaflet material by choice. It's a pericardium, but 1 or 2 cases where we didn't get a good pericardium in a redo situation, so we used to bind pericardium. Leaflet size, pretty much 23. Look at the timing here. So it's a time consuming procedure compared to a standard AVR. So it takes at least 1.5 hours to 2 hours to do it. Initially, timing was 1:30. Now we have brought down our timing to about 90 minutes as we gain more and more experience. So somebody with a sick LV and sick patients, you have to have better myocardial strategy if you're going to do this, and be prepared. If the valve doesn't work, you still have to go back. So it's not like a quick operation. Somebody who's going to begin doing the procedures. Follow up, they do very well. Look at the post-op mean gradients, only 10 on average. At the max, we'll get 15. No heart block. When you size it, sizing, suturing is all at the annulus are just below the annulus. So you don't need to be so aggressive in taking the sutures. So the heart block is almost nil in our series. The 2 patients we had to reoperate. One was a moderate AR. So we don't accept anything more than mild plus at the max. It should be trivial to mild. If anything more than that, this valve is going to come back. You need to figure out where it's leaking and try to fix it. Freedom from reoperations at 33 months, about 95%. And Osaki valve regurgitation is about 95%. But it's only a short period of time, 3 years. So this is a couple of papers from across the globe. So 57 patients from Boston, they had about 88% at 2 years freedom from aortic regurgitations. This is from Great Ormond Street, they're about 80%. What are the modification? Use the same technique for preparing the conduit. That conduit can be done either it can be used either as a Bental or as a RV2PA conduit. Also used monocusp Osaki in patients with VSD with the severe aortic regurgitations, more than moderate aortic regurgitations. Our choice is monocusp Osaki, and in a pulmonary valve replacement in adult patients or a TOF with absent pulmonary valve, we use these techniques. I won't go too much about it. Maybe these are the standard which we have seen already. This is what our pericardium. So how do you choose a conduit? So we always size whichever. If you think that the aortic side or pulmonary side, you go with the Z-score of the particular vessels and then choose a graft. The Osaki leaflet, invariably one size larger than the graft. For example, if you're going to use a 24 millimeter graft, we go with a 25 millimeter leaflet size. That is pretty much works well. So what important is we always use the Dacron graft, the Marshall Dacron graft, stabilize the graft, and then use a marking pen and mark one particular ring as your annulus. So you mark it, you create an annulus. Basically, you're suturing the three cusp inside a cylinder. That's all it's all about. So mark it, then use a sizer based on our graft and one size rather than it, and then mark 3 commissures and then start suturing it. So you can see a marking center point of the 23 millimeter. So suturing similar to aortic Osaki procedure. Once you start suturing, it's actually comes up very well. This is how it looks. It's very competent. I'm 100% sure that the left side, if somebody knows how to make a conduit, it works very well. We have used it in only one patient. It's working well. So this is how it looks from inside. So this is in some other patients where I used as RV2PA conduit. See the height, if somebody is doing it properly, then all the height, everything comes in the same plane. It does not leak much. So I have a video, but lack of time, I'll just skip it. So our experience about 20 patients. So median age is 14. Age distribution is there. Here is predominantly RV2PA conduit, only one Bental. Redo in 11 patients. So positions pulmonary was 18 and our congenital. Autologous pericardium is our choice, 60%. Graft sizes we are using all. If you're going to go smaller graft, it's actually technically difficult to suture 3 leaflet inside, say 50 millimeter, 60 millimeter. In that scenario, what we've been doing, we started doing it now, we create a more bicuspid Osaki. You can use a bigger size and your preparation time also will come down. It works very well. There's nothing to complain. This is nothing to do with the graft, but this is all complex. So one patient we lost and 1 renal functions. No infiltrate endocarditis. Out of my 60 patients, no patient has come back with the infiltrate endocarditis, at least so far. So this gradient works well. The follow-up, they are doing fine, actually. So this is a couple of, just to show you how the conduit leaflets works. So this is how it looks. This is a follow-up echo, 3D echo. So this is on the ventricular side, how it works. It works beautifully, actually, so far, at least. So advantages is easily reproducible. The commercially available conduit as congenital surgeon, we know it's Kandagara is about 2 lakhs. It only takes the cost of the graft around 25,000. The only thing is it takes a lot of operating times and you cannot change it. Once you check in one size, you cannot change it. We don't have a long-term durability. It's very useful in a bioventricular repair. This is a couple of work being published in our journals. We have video on the CTS net as well. Osaki modification, as I talked, monocusp AVR in 5. All of them BSD with severe AR. It works. Other one is for an adult patient who needs a pulmonary valve replacement, we go with the same techniques. And even infants, out of the staff with absent pulmonary, 2 of them are 2 months and 3 months. I don't have access to homograft, and my patient cannot afford for a Kandagara. This is very cheaper alternatives, and it works beautifully. So in summary, when do you recommend Osaki AVR? Definitely in a replacement in children, young adolescents, and female in the reproductive age group. Certainly, yes. And early adult who's going to have a mechanical valve and he's going to be on anticoagulations. This definitely is very useful. And whoever is contraindicated, have a contraindication for anticoagulations. And obviously, surgeons working from low resource settings, obviously, I would say majority of us, surgeon who has no access to homograft, definitely Osaki AVR is a good tool to have in the surgical armamentarium. So if you ask me personally, where do you place? Obviously, if you can repair anybody's valve, that's the best. But it's not easily done by everybody's. AVR is there, ROS is there. So I feel Osaki Neo AVR falls in the middle. This is my personal view, but if you can repair, that's best. So in the era of TAVI, because the TAVI, the surgeon cardiologist is taking over from surgeon. So if you do a mechanical valve for 5 to 10 years of age, you're going to reoperate some point in time, say 2025. Then after that, what? You're left with no other options rather than going for a third redo. If I have to do Osaki in a small age, at least I can buy some time. It may be 5 years, maybe 10 years. We don't know the results yet. Then I still have option of doing an AVR, either with a biological or a mechanical or a ROS, and then the TAVI, and then valve and valve. So at least with the Osaki, we can buy some time before converting into a full aortic valve replacement. Yes, definitely. I feel it's a paradigm shift in the developing worlds, but are we ready to accept this shift? That we have to answer, each one of us has to answer to ourselves. It's very economical surgical option developing field, especially in very young populations. There's no additional valve cost, no foreign material, no anticoagulation. They were talking about the last session, how do you avoid anticoagulation? The problem, yes. And especially country like us, we don't have good follow-up. So no anticoagulation, very good hemodynamics. Stainless valve, talking about stainless valve, yes, it has got a very good hemodynamics, and so far we don't have to operate. I don't think the calcification is going to be as bad as the stainless valve, which we talked in the last session. What are the limitations? Yes, we don't have the long-term results. So we don't have long-term results. Doesn't mean like we cannot use it. No, I still feel the Osaki is going to fail at some point in time because we know it's a pericardium, but accept it. It should have in place in our surgical armamentarium. And again, giving a teenager or young patients for 5 to 10 years of somatic growth with anticoagulation-free time, I think is very valuable. Very importantly, doing an Osaki AV does not take away your further option of doing a AV or ROS. So this is like an additional boost which is available in the surgeon hands. Thank you.
Okay, for a wonderful presentation. Any questions from the audience?
Can you recommend Osaki, what you are recommending in young adolescents is fair and accepted, very well accepted.
Yes, sir.
But how comfortable are you in placing this operation at a 60-year-old patient when we are giving him tissue valve?
Right.
New generation tissue valve, which are claiming that no reoperations are there in that they're 7 years ago.
So yeah, so answer to your questions, certainly. I'll give all the option to the patients. As in the talk he said, the patient has to be included in the decision making. Whatever we have currently available results, yes, it is very promising. And Osaki himself, his results are about 85%, 88 years in 10-year time. So we will give them all the option, mechanical tissue, Osaki procedure, and we don't have a 10-year results yet. So if patient is willing, I'll be more than comfortable to do a Osaki in a 60-year-old guy. Yes, sir, please.
We start now, we cross 200.
Yes.
And we've done it in a wide spectrum. For us, between a Ferrari and a Maruti, I have to be Maruti. So many of my patients who are elderly are getting this. They are the most stable. We've been having this, and I presented the rod at some time back for the first 196. We were jumping around, but that is what it is. That is the truth. We're not, but if you exclude the initial wrong decision making, then we started taking football arts and other things, so we shouldn't be having doing it. We are getting very stable results in those. The point about endocarditis, I'm sorry, we've encountered endocarditis. In fact, one of the patients, just to tell you, I stopped using the PEG legend. Osaki is one of our locations, Osaki operated in our workshop, came back to them. It did come back to endocarditis, and unfortunately, it was different to died. But the thing that I'm very much against is using the PEG. All our using has happened around PEG. The CT again showed this thing, we were preparing and giving an antibiotic, suddenly ruptured and
so unfortunately, we don't have similar experience. And coming to what Sir is talking about, I feel, my adult patients maybe about 7 or 8. I feel procedure should be much more stable in an adult patient compared to a children who's in a growing stage.
The important thing about it again is we learned it. When I started doing that, it was all totally self-taught and just started doing it. It doesn't grow. It's very obvious it doesn't grow. But when one of our major reasons for redo of our solution for her has been, and we've done redo of that in those donor pericardium, is that the child gets a growth spurt and the valve becomes restricted. So now we are in any child, we are widening the route to be able to give a longer distance.
One more question. Did you ever encounter gradient across this?
Not in the
Rising in.
no, that's what I'm saying. No, it always falls. The gradient actually falls. Whatever you get, the gradient you get on the OT is the higher gradient than what you get. Over a period of time, you may get a rising gradient.
Yes.
As it degenerates, because now
Yes.
patients are 7-8 years down the
Yeah.
line.
You're going to see the gradient. You are going to see.
It will degenerate. In
Yes.
fact, I've done redo.
Yes.
And I've done redo exactly same. But most of the issues is that you have to be careful with children. See that if you cannot pass a 19 or a 20 agar, religiously widen the route and
Yes. So I think one more, okay, sure, yes, right. Is there anything, yeah?
I just have one comment and a question.
Yes.
This is very interesting how things go around because when I was in John Radcliffe Hospital in Oxford, 2005, we had presented a small series which was by Ravi Pillai. So he was a surgeon. He had done exactly the same procedure using the autologous valve or autologous pericardium, which we presented in Asian meeting in Singapore. And that was a series of 9 cases or so. And now it's nice to see it as a name, Kozaki as well. The question is, when you measure for this bicuspid aortic valve, so which is your reference point? How do you design your other defects?
So two things I think, at least from in my mind, the position of coronary comes in. Second thing is your native commissure. So you keep one commissure as your reference point and the coronary where the coronary is. Then you move around because we are converting this bicuspid valve into a tricuspid valve, right? So you have one commissure as your stationary and the coronary. Look at the coronaries and then keep rotating it. You may have to change one commissure into another position. Then that's how you create a space for another commissure. I mean, yesterday the same question was asked in the dry lab. We demonstrated it. Maybe, I mean, it may be difficult for me to explain, but maybe others maybe can explain. Happy to.
The same thing. What I usually start off with, usually I keep it at the apex of the membranous septum, see that and put the size. I mean, see, I don't have the geographic size, but I made my own. Mine is on the marking. I'm not the right. So then what you do is you put it and then see. Now see where the coronary is lying. If this doesn't work, you take the 2 coronaries and put bang in there. The 2 coronaries and go this side and that side. And see, you can make some match.
Yes. Sure. Thank you, sir.
It's more conceptual than yeah.
Thank you. Like to invite Dr. M. Yusuf from Chennai, and will be presenting his talk on mental invasive aortic valve.
Good morning, everyone. I'm grateful to the faculty, Shantanu Pandey and Dr. Agarwal, for inviting me. I think most of you are either alumni or somewhere related to SGPGI. I am indebted as well to the faculty, Dr. Shantanu Pandey, who really taught me to do total arterial minimal invasive, which helped me move on to now robotic total arterials. Thank you. So it's always currently, if you look anywhere, comparison is either you have this big cut or the tiny hole and get the aortic valve done. But we have to understand there's something in between. The reason it's not popular is we are practicing it less. So I think we have to adopt this technique. It's not about being competitive, it's about giving the best to the patients. End of the day, there is still a group of patients who need surgery. So the best way to adopt and start for the younger generation is minimally invasive mini sternotomy AVR, and then move on to right anterior thoracotomy. Now the new surgical armamentarium is robotic assist AVR as well. So the upper hemisternotomy is nothing different. It's just getting used to looking through what we need to do, and rather than just feeling and looking at the whole heart. So it's easy to start, same as the normal traditional procedure, just getting used to working with a small field. And patient is happy because he goes with a small cut, and it's usually the lower half of the sternum that's troublesome. See the infections, pain, movement starts at the lower half. So when just the upper half, most of them get back to normal activity within a month, including driving and heavy work. The other really moving on to minimal invasive approach is the right anterior thoracotomy. I would suggest that best to be comfortable with upper hemisternotomy, at least 10 to 20 patients, then move on to this. And it is always better to do a CT, not necessarily contrast, it can be non-contrast chest CT to assess the aortic valve. So it should be less than 10 centimeters or preferably less than 8 centimeters from the lower border of the sternum and at least 50% to the right. It's a good way to start, at least for the first 20 cases. Because here the learning curve is a little more than the upper hemisternotomy. to get comfortable, it needs to be 20-25 patients. So apart from this lung function test, if there is any, we routinely do lung function test in any smokers and make sure the FEV1 is at least more than 50%. And best to avoid poor LV in the early phase. More than 45% is not a bad option. Of course, angio as usual. Femoral cannulation, I won't go into much of that. Then right anterior thoracotomy, the space depends. It's second or third space. I go with the Mark-Ruel rule, which is the first space below the clavicle is not for us. Leave out the second space and then the third, which usually corresponds to the second or the third space. And once we open, with the instrumentation, it's better to use all traditional instruments for this, except flexible aortic clamps can be helpful. It gives us more room to work with because it stays away. So what we do, once we open the pericardium, just feel the root. If the root is below the space, then I cut the costochondral junction below my space. I always divide the mammary, but it's not necessary. Most surgeons don't divide mammary nowadays. And if the root is felt at the space or above, then we cut the costochondral junction above the space where I've made the incision. That gives us a lot of room, and the exposure is important. The most important procedure or step to make this procedure easy is to hitching the pericardium. We hitch at least 6 or if necessary even 8. That's the corners and 2 in between, maybe even the upper and lower part as well. And I always insert a right superior pulmonary vein vent before hitching the pericardium on the surgeon side. Then it's pretty much standard procedure. So this is the cross clamp, flexible clamp, which keeps it away. And the common problem might be if we keep the aortotomy a little higher, we have to go really low. So 1.5 centimeters or so from the annulus makes it easier to use the right coronary cusp sutures. But if we are using sutureless valves, we can go slightly higher, which will be a good option to use in these procedures. Myocardial protection, it's personal preference. We use cold blood, and there's no standard way of doing it. We don't use retrograde. It's too expensive. And that's what the patient goes home at the end of the procedure. And when they come down in 2 weeks' time, they hardly see a scar and they're pretty much back to normal. It is really beneficial, and it gives way for future redo if required, which I will talk about in a minute. The next is robotic assist. I'll talk about this in my next talk on robotics. So slightly lateral incision, 4 ports. And I believe, we haven't started yet. We are moving towards it. So it gives us better exposure, but there are certain technical steps which we need to work around. 2 aspects we need to consider in this day and age, because we are doing more younger patients. So we need to develop the appropriate procedure, probably minimal invasive, and the appropriate valve for the patients as well. With the new bovine pericardial valves that are longer lasting, it is an option to provide to a lot of young adults. Yes, as Dr. Vijay spoke, for the teenagers, there are other procedures, but for the young adults, this may be a good option to work with. There are the 2 common bovine pericardial valves are Avelis and Inspiris. Both have their advantages. Avelis has a bigger opening, effective orifice area, and Inspiris has a resilient tissue in younger individuals. Sutureless valve is a good alternative in minimal invasive procedures. So this was a very recent study published just about a month ago, where you can see of all these valves with a 27 millimeter label size, the older tissue valves have much smaller effective orifice areas. Of all the Medtronic, Avelis has the biggest. Edwards Inspiris the next. And we also need to make sure they are TAVI compatible, because that's what we are moving towards in lifetime management of these young patients. So this is an Avelis valve, where you can see it's a non-metallic stent now, so it can break in with the tissue valves. The valve geometry fits in for a future valve in valve, and also their interior mounted leaflets. So there's less risk of coronary obstruction for future valve and valves. Indications have been evolving as well. The recent European and American guidelines, which has already been quoted in the morning, does not give us age limit anymore. Yes, it is 60, 65 cutoff, but it is vital for us to discuss the options with the patients. And it clearly says 2A indication, bioprosthesis should be considered in patients for whom there is a low likelihood or low operative risk in future redo valve surgery. So that's something we have to consider. Excuse me. So the lifetime management of aortic valve disease is a new concept where in young patients, we discuss options, and if it's a biological valve, there is an option of minimal invasive. When even in young 30, 40-year-old, we give the options. If it is minimal invasive, then the first time redo is as simple as a primary operation. So that's where we are moving towards. In our practice, primary standalone single valve, almost 99% of them are minimal invasive, whether it be mitral or aortic. Then open surgery and then valve in valve. So this way we can avoid anticoagulation, which just not only is it the cost, but availability is a big factor in our country. Availability and reliability on the procedures. We all come across the day-to-day problems. And again, we have to always keep in mind the TAVI procedures. Multiple studies have been done, and of which Notion is one which looked at young, low-risk patients. Again, they have come up with 7 years data as well. There's no big difference in mortality or stroke. Yes, there is a difference. So in SAVR, there is bleeding and atrial fibrillation. In TAVR with aortic regurgitation and PPI, but this was with first generation valves. So second generation, the newer studies are showing less risk of pacemaker implantation and less aortic regurgitation as well, or paravalvular leaks. So it is about, again, working together and also adopting TAVI techniques to work with as a heart team. So we don't need to be worried that we'll be losing the surgical valves. There's still a big role. Like the stents, when it came, we are not losing our jobs. It's about working together and giving the right for the patients. Patients with aortic insufficiency, bicuspid, not all bicuspids can be done through TAVI. Most of them still need surgical valves. And young, low-risk patients, concomitant procedures, patients who want to have mechanical valves, and high-risk anatomy or horizontal planes. So that's where SAVR still will hold a role always. If you look at all the literature, we have noticed it's often the comparison between open and the TAVI, but there's very little cohort studies comparing minimal invasive with TAVI, where there's advantage of both mortality risk as well as less risk of other TAVI-related complications. So I would like to conclude saying, please consider this middle option. And I think we should move towards more on this option for younger patients. And yes, for high-risk patients and slightly older, we offer TAVI, but not necessarily always open procedures. So we all know the advantages of minimal invasive, apart from low risk of infection, quick recovery. It needs to be addressed in lifetime management of aortic valve replacement in younger patients as well. Thank you.
Thank you, Dr. Yusuf. Any questions from the audience?
Can you tell me, one of the challenges in the right angle is giving the RCA, in some cases it can be difficult to give cardiac failure to the RCA. What are your strategies for giving that?
Opening lower, that's the key. So once if we open higher, we are in trouble. So getting the sutures, giving cardioplegia is all difficult. But if we open just at the ST junction or slightly more, 1.5 centimeters from the annulus. So you have to really feel the annulus and then open. So that is key. So far by doing that, then we just have to give it to the left and pray. That's the reason I suggest don't take poor LVs. So our cutoff, even now our cutoff is 45%. We don't have very huge numbers. We are just in our double digits, 20-25 patients. The right anterior thoracic.
You have a specific case selection, like good animals and everything for such cases, or it can be done for any aortic?
Yeah, say the first 20 be selected. So now we are moving towards, yes, most patients can be done this way. If you ask Mark Ruel, he says all the aortic valves are done through his right anterior thoracic. It's about experience and getting comfortable. So initially, yes, be selective. So I still tell all the patients either upper or right, but most of them now we are moving towards saying yes, it is going to be right anterior.
This is open sternotomy also many times is struggle, especially with aortic root. We don't know what we're going to end up with, maybe requiring either coronary anatomy.
In all these patients, it's best to do a CT.
So when is the time when you say that, okay, no, I don't think this, after opening also go for sternotomy?
I think it's best to avoid that situation. If not comfortable, just go for sternotomy.
So your CT is telling you your coronary anatomy as well. You don't have an enormously high placed coronary in this case.
That is not a problem. So higher placed coronary is easier,
It's still lower, right?
but it's not going to be 2 centimeters or more.
See, presentation of the user. Two things I'd like to add here. Obviously, always choose ARs when you are doing initially, then move towards aortic stenosis. And what looks the aorta looks before going on center bypass is absolutely different, because the moment you open, and very honestly, he said you have to divide the IMA. If you don't divide the IMA, you will never be comfortable, because you will get at least 1.5 centimeters more.
And the costochondral junction division also.
And
That gives
another point is those pericardial stays which you took note. So you have to tighten on the skin. What we can do is we can always make 11 incisions and pull it out in the snuggers and pull it out. So your skin and your pericardial stays will be out. So it is a little more space. And as far as people who are very, very apt and they feel confident with retrograde cardioplegia, and especially it can also be done in these patients. But you have to go on bypass, put a posting on the right atrial appendage, and it is always, you have to just guide it through a transesophageal dependent.
we are very worried about that because you don't feel.
I agree.
Yeah, so I don't use that.
I agree. We have tried 2-3 times. Initially, skeptical, but then it happens.
And regarding AR may be difficult as well initially.
Yeah.
So choose the tricuspid or bicuspid, doesn't matter, but not heavily calcified. Another tip is you can use diathermy to cut, which is what we learned from robotic. Moving on to this. With robotic scissors, we have low diathermy, it cuts very easily on calcium. So you can use that. Now we are trying to use it for regular calcific cases as well.
50% rule which he told on that CT scan is very important.
Regarding the CT planning before surgery, what I on a conference in Greece. So I think you can elaborate it. There is a center point of the ascending aorta that has to be matched with the right edge of the sternum. If it's lying on the medial side,
Yeah.
then for me it's going to be very.
So that angulation was talked about more,
Right.
but now even in our early phase, the angulation didn't really matter. That's the reason I've taken that off. If you look at the standard slide, it shows 3 things. Angulation of the root. If it's a totally right-sided aorta, it can be difficult. So, and these 2 other measurements I said, but angulation really doesn't matter because we make slightly bigger space by cutting so these are things we shouldn't compromise on, giving enough space to work with.
And another issue, when you're planning for a sutureless valve, because we got stuck once, and if you have planned that you're going to put a sutureless valve, what would be the intercostal space, and would you go with a vertical incision or horizontal?
I haven't done sutureless valve this way, but Ajit Bana, who I spoke to, and he suggests he always goes higher, 1 space higher, second space, but I'm not still comfortable doing sutureless valves this way.
Very different.
One suggestion about giving cardioplegia to right primary and seeing valve better. We can just mid-table reverse pendulum group. So that makes things slightly more visible in EV and the aortic valve comes inside.
Sir, how do you weigh elevate or root vent or single root vent?
No, 11, the superior pulmonary vein went, right superior pulmonary vein.
Root vent also.
Root vent is only to DR later. The same plegia line, we use it for root vent. No, normal one. Here, once we get the pericardial stays up, it's like a normal AVR. And it's standard instruments, no minimal invasives.
Very interesting discussion. We have to move on.
Thank you.
Thank you, Dr. Yusuf. I would like to invite Dr. Agarwal for a talk on transcatheter awareness.
Good afternoon, everyone. Thank you, SK sir and Dr. Pandey for giving me this opportunity. It's more than just a program or a foundation day for me. I mean, it's really nostalgic being in SGPGI, where I've been trained and 13 साल पहले 14 साल पहले इन्हीं गलियों में घुमा करते थे. So, I mean, thank you, sir. So, I mean, coming to the topic, it's a very vast topic. So, what I have planned is, in a way, to squeeze it. Like we crimp a valve, we have to try to crimp the whole topic in a couple of slides. So that gives an idea to the young surgeons who are aspiring to get into structural heart or who have just started or those who intend to start it. So how to plan a case, if any surgeon wants to plan. Basically, every surgeon has a comfort zone. We too have, for that matter of fact, but we have to come out of it because we are used to big incisions. We see everything. We have time-tested techniques. We can manage everything when we have everything in front of us, open in front of us. Complications can be managed very easily. But obviously, we have to come out of the comfort zone and, getting into a new arena. We have to readjust. We have to relearn. We have to unlearn some things. And here we have some wiring techniques. We have visualization on the screen, doing things on the groin or on the radial or whatever is our access point. Indications are basically standard, very high probability risks, high and intermediate risk patients with high ST score, frailty index, patients who are quite frail, low risk patients. The trial is underway. Time will tell, and probably they will start doing it in low risk patient as well very soon. Obviously, age 70 to 75 years or more, but at times it's patient's choice. I have put in TAVR in a 52-year-old lady because she never wanted any cut. So obviously, we have to offer. ST score less than 4. Certainly, you have to consider SAVR or suggest SAVR. Why planning is important? Because it is 90% of the job done well. Echo is very crucial in overall planning. Good echo is very important. And it is usually very important when you have a patient in whom you have to avoid contrast, especially with CKD patients. TEE may be required in these patients as well, but rarely it is needed in routine patients. But it can never replace CT scan in planning. So these are just a list to complete about aortic valve indications and 3 basic categories, which what we all know. Low flow, low gradient, normal flow, low gradient, and high gradient. And so coming to the assessment on echo. Basically, annulus is a dynamic structure which is more elliptical during systole, and any linear measurement of the annulus is bound to undersize or oversize. So perimeter is something which remains more or less constant during the cycle. So the measurement of the valve is more or less based on calculation of the perimeter. That too can change. That too usually changes 10 to 15%. So we tend to oversize the valve at the tune of 15 to 20% when we choose the right valve for the annulus. Also, when we are going to put the valve, we are actually creating a new geometry, which is more circular. Now coming to CT, CT is the gold standard and contrast CT. It's operator independent, rapidity of acquisition as well as remote analysis makes it a very good tool. There are 3 basic softwares, of which 3Mensure is the most commonly used one. DICOM is also used, but then we have never used anything else except this 3Mensure. And the newer machines, with newer machine, you can have very small amount of dye, as less as 50 ml, with these kind of dual source CTs, which have very high spatial and temporal resolutions. And they have practically eliminated the need for angiography of excess vessels. Now, as we discussed, the measurements are done in systole, and there are 2 techniques which are used during CT. It's basically retrospective ECG gated and prospective ECG triggered to avoid motion artifacts. As I've already told, there is increase in 10% to 15% of area in perimeter as well. And there is something which is called aortic valve complex. It is the structures which are between left ventricle outflow and the aortic tube. Everything lies there. You have to analyze the whole aortic valve complex, which all consists of morphology. Is it tricuspid or bicuspid? Single raphe, double raphe, or there is no raphe at all? Size the annulus, sinus room, STJ heights, coronary heights, calcification on the leaflets, LVOT. Is there any spur on the LVOT that might, increase the risk of PVL, PPI, root injury, sometimes pop out? Quantity and distribution of calcium is also very important, especially in the landing zone. The idea of deploying the valve is as shallow as possible. It has to be 3 to 4 mm, best is 3 mm. Now, the problem is if you implant higher, there are chances of PVL. If you go down, there are chances of PPI. So you have to keep a balanced approach, and it depends on patient to patient and the CT analysis. You have to know the aortic angle, because strategy can change according to the angle. If aortic angle is more than 60 degrees, it's more of a horizontal aorta. Then your approach going inside, taking a different valve delivery system might change your whole strategy. Coronary heights are important because you have to plan your coronary protection strategy in advance, whether to do it preoperatively or to do at the time of procedure, what strategy you have to do. This is actually the aortic angle, which is basically the annular plane from the horizontal plane. Now, imaging can help you decide the valve platform, depth of deployment, angulation if required, and to avoid contra-coup injury wherever there are calcium spurs in the LV outflow, or to consider alternative approaches like transapical, transaortic, sometimes axillary, carotid, or transcaval. You need to know a little bit about your valve as well. Basically, these are tri-leaflet valves, can be bovine, porcine, or at times under research, some polymeric material as well. They are mounted on radio-opaque metallic scaffolds. It may be stainless steel, nitinol, or cobalt chromium alloy. There is basically an inner sheath and outer sheath. Outer sheath is something which anchors the valve into the annulus. And there are changes and the research going on in designing different sheets with some gels also. Newer valves are coming with better and better anchoring mechanism that lead to low chances of PPI and less chances of PVL. These are two commonly used valve platforms. These are self-expandable valves and balloon expandable platforms. Others are mechanically expandable, which have a separate mechanically deploying system, which can go from top, bottom. And there are some valves which have got active fixation mechanism. These are especially being developed or are being used for aortic regurgitation or the valves where there is no calcium at all. Now coming to self-expandable platform, majority of them are supraannular. They give higher effective orifice area because the actual valve is above the annulus. It is flared and they are better for small annulus, valve in valve. And usually they don't require rapid ventricular pacing, which is normally required during deployment of the balloon expandable systems. Most of them are recapturable, repositionable. Actually, you can implant the 80% of valve and take your time and decide or recapture it again and deploy it again. You want to go shallow, you want to go deep. So they are particularly indicated in patients with small annulus, as I told, severely calcific annulus, valve in valve, or a very small bioprosthetic valve. Like we did one patient, this patient had a trifecta 12 years back, and that too 19 size. And trifecta is a valve which cannot be fractured very easily, but it can be fractured with a non-compliant balloon, that is Atlas balloon only. This is the only balloon which can fracture this valve, but that too can be disastrous at times. It can lead to root injury. So in this patient, we had this self-expandable valve, and we got area of 23. Now, these valves are bigger profile. They have higher frame height, so that comes with a disadvantage. They may have high rate of PPI because they work on the radial force of expansion over time. And because of the big cage, which comes in front of the coronaries, future coronary access may be challenging as compared to the balloon expandable valve systems. The available systems are Medtronic's core valve, Accurate Neo, which comes from Boston Scientific, Allegra, Hydra, which is being developed by an Indian company, Engager, and Centra. Now come to balloon expandable valves. This is another major, Edwards comes with it. And in US, they have 70% of the market. They were the first valve implanted. And they are intraannular. They are not repositionable. Deployment requires rapid ventricular pacing. They have a smaller profile, stent frame, and coronary access is definitely easier as compared to self-expandable valve. Furthermore, they have a very big advantage that their delivery system has got steerability that can negotiate the acute curves of aorta when we go from arch to the ascending aorta. So they are particularly advantageous in situations where the aortic angle is more than 60 degrees. But there are some disadvantages that many patients with poor LV function, impaired renal function, these patients may not tolerate rapid ventricular pacing very well. So Sapiens is the most common valve, my valve, Merrill, which comes from India and company. Mechanically expandable valves are there. And as I told that there are some valves which have got active anchoring mechanism. They are metallic spurs which come out and they anchor actively into the annulus. They are basically made for aortic regurgitation. Like Jena valve is there, JC valve is there. So these are a couple of valves just to show you. Now the delivery system basically a sheath. Initially they started with 24 French. Now the usual size of these sheaths is around 14 to 16 French. And with the Edwards, they have a flexion mechanism at the distal end. In the balloon expandable valve. Now, what valve to select for your patient? For most type of patients, I think Evolute and Sapiens can be chosen. But they may not still cover the full range of requirement of the anatomy or the annular size. So there are many issues which can influence the choice of valve, like if there is high risk for annular rupture, patients who are very small, annulus is very calcified, a self-expandable rather than a balloon expandable valve may be chosen, as annular rupture has been observed most commonly with balloon expandable valves as compared to self-expandable platforms. Also, if there are concerned about coronary obstruction, if coronary heights are low, you have to rely more on self-expandable platforms, because once you deploy, you have still got chance to recapture again and redeploy it again. Patients who are at high risk of block, like those who have RBBB, so you can go for balloon expandable platform because the chances of PPI are less. Or when you are choosing valve in valve, because valve in valve is something which is going to come to surgeons back again in future. So this is going to be our territory. So we have to be very particular about patients who have got bioprosthetic valve, and we are following them in future. Also, there is very important thing. There are at times there are spurs of calcium in the LV outflow that can affect your deployment. Sometimes you have to deploy a little valve at a little angulation to avoid counter coup injury or to avoid major PVL. See, the whole idea doing first case or initial cases is that patient should go home without any complication, good clinical results. So what valve you have to choose, what anesthesia you have to give, what access you have to choose. So these are the common questions which will come in everybody's mind. Heart team is very important. Probably as a surgeon, I believe heart team is very important for cardiologists, but not for surgeon, because surgeon in itself is a heart team. So it involves clinical assessment, echo. You have to decide about the coronary artery disease, what you have to do. You have to get it corrected beforehand or at the time of procedure or later on. And nonetheless, CT scan planning. Now, hardware is very important. Everything is hardware in the cath lab. You need to have all the hardwares, plan A, plan B, plan C. If this goes wrong, what will you take next? If this goes wrong, what will you take after that? So you have to have all the wires. You have to have knowledge of all basic wires, basic catheters, balloons, closure devices. You need to have peripheral cannulation set in the cath lab. We have a patient on which we had to go on ECMO for a short period of time because patient, even after CPR, she didn't came. So we have to initiate an ECMO and manage her for 15-20 minutes, but then patient was revived and luckily she was saved. Nowadays, it's all minimalistic approach, percutaneous. Since the device profile is very small, 14 French, sometimes even one single proglide and angioceal is enough. That will suffice. But it's always safe to use 2 proglides. That gives absolutely good sealing, no bleeding at all. And nowadays, there is trend towards not using the other groin rather than going through radial for secondary access. Secondary access means doing shoots, marker pigtails, and anything in adjunct you have to do along with TAVR, or you have to do angioplasty also at the same time. And normally we use conscious sedation only. Now, coming to excess vessels, it's very important. Normally, right groin is our index groin. And the minimum size, what is acceptable is with core valve systems, it is 5 mm. With Edwards Sapiens system, it is minimum 5.5 mm. Below this, you have to consider alternate access, or you have to open it and dilate it. We have done that also. So that works, but only with surgeons. Ultrasound is it's always a good idea to use ultrasound as an adjunct to taking an access. In fact, it's always better to take left sheath, wire from the left side, do a DSA, do an angio, and find the best spot just below inguinal ligament in front of femoral head, and then take the right access, because device is bigger, so you need a good soft spot to enter. This is just a picture to show you the stretched out aorta with iliac. Given all the access are good, right is usually the index groin. Left groin is usually used for marker pigtail and at times radial, as I've already told. At times you can use brachial as well. And for initial cases, you use general anesthesia and cut down at the groin. Now, I mean, how we proceed? I mean, first step is to take left femoral access, whichever way you want. Then take right access under vision under the fluoro, doing a DSA. There are different catheters, different choices of catheter for different people. What we use is usually JR and Lima. That is always best to give you the curve to get into other side. First is to dilate and put 2 proglides. Then take a marker pigtail from the left groin and you go all the way into the aorta and house it into the non-coronary cusp. That is the standard technique to start with. And take a shoot over there. And there are, again, different choices. Commonest is, and the easiest is to take a multi-purpose with a soft tip Terumo catheter. That has to be exchange length, because exchange length is 260 centimeter, so that any catheter can be exchanged on that. Root angio is done. Coronary angio is done, if not done previously. Coronary protection strategy is to be defined at this time. There is a software which can tell you VTC, virtual transcatheter valve to coronary distance, which can actually predict the coronary obstruction or impingement. So you can always plan all these things in advance. It is not to decide on the table, but sometimes it can happen there as well. So, I mean, where to do all these things? You know that coronary heights are low, sinuses are not roomy, or they are deficient or sequestered sinus. You need to have, this is must, balloon tip TPI. This is to be put from the right groin, from the femoral vein. We have one patient in whom we had RV ruptured because of we didn't have balloon tip TPI. We said, okay, chalo, let's do it. So this is must. And before doing anything, check the pacemaker. Now, if coronary has to be protected, now you have to decide what you have to do. Chimney or snorkel or leaflet laceration. These are rare. Leaflet laceration actually very rare. We don't do that often. But yes, chimney is a common strategy. Now, a very important, or I must say, unpredictable step initially is crossing the valve. How you cross the valve. You know, that sometimes may take very long time, sometimes even 40 minutes, 45 minutes as well. That is something which we have to learn over time, and that comes with experience, expertise. And there are different techniques. They have been advised by the experts. Commonest is usually we take Amplards with straight tip Terumo. Try and move LAO, RAO, AP, and somehow you understand that where is the orifice and you negotiate through the orifice. There was a recent study where they have used pigtail with J wire in 30-degree RAO and turning it in a particular direction, and then that tip of the pigtail opens in front of the valve. So they say that has got the shortest possible time of crossing through the valve. All the wire have to be exchanged. Take a pigtail, cross through the LV and do the shoot again and do the gradients. Check the gradients. Decide whether you have to pre-dilate the valve or not, or you have to go straight with the delivery system. Now, when you need to pre-dilate, if the gradients are very high, there has been very difficult, or you have faced a lot of difficulties crossing the valve. It took time, probably then it needs pre-dilatation. Or sometimes when you have taken the device and you are not able to cross the valve, you don't push so much so as to injure. It's better to take out the device and pre-dilate and then go ahead. In these patients, self-expandable platform may be preferable. And while pre-dilating, if the coronary heights are borderline, it can give you idea of any coronary impingement as well. Or you can see ST changes on the screen. So this is actually with with time constraint. I don't think we need to go into detail of these algorithms. So basically, when we have crossed the valve, the next step is to take the stiff wire, because a stiff wire is very important because the whole delivery system has to travel on this wire. There are two common stiff wires which we use, is either one is Safari and one is Confida. Safari comes from Boston and Confida is from Medtronic. Now, implantation angle is pre-decided on CT planning. So you have to put the patient into implantation angle, fix the table. What projection you have to use? It depends on the kind of platform you're going to use. There are two basic projections used for deployment. 3-cusp coplanar view, that is usually best for balloon expandable valve, and cuspal overlap. I'll show, this is, if you look at this carefully, this blue thing, do I have a pointer? That blue is basically the II, image intensifier. If you look at that, when you put all 3 cusps in one projection, that's actually the 3-cusp coplanar view. You can see all the 3 cusps in line. RCC in the middle, LCC on the right side, left side, and NCC on this side. This is 3-cusp coplanar view. It is usually used. Now, cerebral projection, which is actually not very common, but at times when we have a lot of calcium, when the aorta is horizontal, or you have done, you expect that you are going to pre-dilate or post-dilate the valve multiple times, then it is probably a good idea to go with it. So I'll just go across the new devices. Sentinel CPT device is basically the commonest one, which is used nowadays. This is how this device is put. You go all the way from subclavian, and there are 2 funnel-shaped filters. One deploys in the common carotid and one in the innominate. Now, take-home message, basically. Every day, there is something new coming up in transcatheter techniques and the valves and the design. Now, newer skirts are being developed to minimize the chances of PVL. Newer closure devices are coming, which can, a single device can work for whatever large profile of device you have. You have to go through excess vessel. Intravascular lithotripsy, what cardiologists can always help you with. If you have bad calcium on the excess vessel, still it can be done. It can be used. Now, for all the surgeons, I must say, have you missed the bus? No, never. And it's never late to start it. And sooner or later, tricuspid device is also coming. Cable valves are already here. So all the valves are going to be done by catheter techniques. So we have to get on this bus as soon as possible, whether we like it or not. Thank you.
For the want of time, because we have already exceeded almost the time for the next session also. And one of the speakers for the next session, Dr. Sudhir Srivastav, actually is on the way to airport. So he has to give his lecture online. He had his bilateral knee replacement only 2 weeks ago, so he could not travel. So I would invite Dr. Sudhir Srivastav online to present his lecture. That is about the Make in India robot.
So can you hear me? Can you hear me?
Yes.
Okay, great. So let me share my screen here. And hopefully you can see that. And I'll get onto full screen. So firstly, my thanks to Dr. S.K. Agarwal, and I've got to know him, wonderful person, and really looking forward to work with them on various fronts. And again, thanks for this invitation to speak at this SGPGI meeting. So I'm going to talk about mainly the focus on our SSI mantra that we have created in India, and also with that share some of the opportunities that exist to really revive the cardiac surgery field with the robotic assistance. So this is my disclosure. I'm the founder, chairman, and CEO of SS Innovations. So if you look at the landscape today of the robotics, it is a very uneven global penetration, including within the United States. And it remains country and economy centric. And almost 93% penetration is between those three jurisdictions, US, Europe, and Japan. And that means rest of the world, over 7 billion population, has only 7% penetration. When we look at India with a very large population, we have approximately 1% actually of the robotic systems. And cost and learning curve remain really the main factors for this process. And I show this slide mainly to point out, particularly from the Indian context. Back in 2002, I did the first ever case at Escorts Heart Institute. Dr. Trehan is there and President Abdul Kalam was there. So when we look at 20 plus years now, since then, we have only roughly 140 robotic systems. And again, not all are fully functional or utilized because of the cost, or again, the abilities of the surgeons in relation to the learning curves. So when you look at the volumes in India, they are again less than 1% of the global volumes across the spectrum. Mostly are non-cardiac procedures. Only a few centers are trying to do cardiac in a very limited way. And the cost again remains a major factor, including the capital, the running cost, as well as the maintenance agreements, etc. And there is no organized teaching and training program, particularly when it comes to cardiac. So the vision was to really create a technologically different system that hopefully will be not only different, but better features and be cost effective. So over the years, I had done over 1,400 or so robotic cardiothoracic cases, or roughly 800 TCAPs, and really wanted to utilize my personal experience to see what are the opportunities to create a system that will be more user-friendly, be easier, not just for the surgeons, but also the entire surgical team, and have certain enabling technologies that will help, especially on the cardiac side, because I think, as you all know, there is not much support left now on the cardiac front by the industry. So we have created an open-face console, which is ergonomic. Surgeon gets to sit straight. There's a large 32-inch 4K monitor, and there's a head tracking camera for safety. So if you look away from the monitor, system will not respond even if though your hands move. And there's a large 2D monitor which has all the controls, but also it is you can bring meaningful images of full size CT, MRI, angio, echo, etc. And it also gives you a virtual image of the entire system right in front of you. And also we have developed certain techniques whereby we can take these DICOM images and convert them into 3D model. And literally you can slice, dice it, match the surgical view, and entire anatomy will be right there in front of you. The hand controls are very ergonomic. They come in front of you, and there are typical foot paddles. And the console is prepared right from the beginning up to 5 arms. So I will say in a little bit, we have developed certain technologies whereby we will use 5 arms. And currently, to my knowledge, nobody has ability to be able to use 5 arms and control them from the console. Hand controls are very ergonomic. So we have 2 versions. One is a palm held, which really does not produce any tension at all. And the other one is typical ringed gripper that people are familiar with. Modular design. So all robotic arms are mounted on separate cars. So one have an option of 3, 4, or 5 arms. And we can place them wherever required based on the target anatomy, body habitus. And these cars are motorized. And so essentially, there is a parking process there, which makes it very stable. And one of our future vision is that based on the procedure, we will literally on a touch panel push the button and these guys will move on their own after nurses have draped them. So the idea is to make it really as efficient as possible. It has typical features, goes right up to 7.5 feet. So there is plenty of human space. And because of, somebody is taking IMA down, only 3 arms are needed. Or for certain thoracic procedures, we don't only 3 arms. So it just gives you flexibility for whatever you need. Vision cart, also right from the beginning, we have given large 32-inch 4K monitor. And this is one of the things that I felt really a tremendous need. Currently, to my knowledge, nobody has 3D because it's very crucial. Since surgeon sees 3D, we can do things very precisely. So same thing should be available for the table side team to avoid accidents, make it more efficient, reduce the learning curve, and ultimately better quality outcomes. I was operating in South Korea, launching a program, and nurse put the knife right through the heart. I asked her what happened. She said, I couldn't tell how deep I was going. So I think this really offers a very safer approach. And also for teaching and training, we are really seeing. And also you really never need a dual console because if you are training a surgeon and you're standing behind and watching the same 3D vision, it will literally take 10 seconds to change the seat. And you don't have to toggle out and give controls, etc. It has built-in recording playback capabilities and also for live telementoring. So one of the goal is really that we can provide telementoring wherever from wherever. And we have already partnered with the telecom companies in India, and the high-speed connectivity will allow us to do this thing in real time. We are using Olympus articulating camera, which has also 4K resolution. And this gets rid of 2 endoscope, 30 and 0. And literally you have a complete circumferential view. And it is very helpful, without having to move the robotic arm, the camera. Pre-op guidance is there for all different procedures. So based on our system, we have prepared this. So whatever procedure you choose from the menu, the target anatomy will be shown, table position, placement of cards based on our system, and docking of the arm. So the whole idea is to, again, take the guesswork out and make these procedures very efficient for the surgical teams. Over 30 different types of instrument, and for all multi-specialty, we do have harmonic as well. And also with my interest and really trying to revive the whole cardiac field, we have developed cardiac stabilizer, atrial retractor. There are 2 sizes, one for the left and one for the right atrium, and Rezano forceps that are used quite a bit for valve surgeries. And this is really our crown jewel, what we call NADI. We have used all Sanskrit name, as you can see. NADI, of course, stands for Novel Anastomotic Device Instrument. And this is an automated connector. And I have a little clip of this thing.
Introducing NADI, a miniature automated coronary anastomotic connector that revolutionizes the treatment of coronary artery disease. With its advanced technology, NADI enables a completely automated anastomosis that can be operated by the surgeon remotely or by the patient-side assistant. The NADI procedure involves the use of robotic instruments that are inserted into trocars placed through fingertip-sized holes through the left thoracic cavity. Once the robotic instruments are in place, the automated coronary connector or NADI is inserted through one of the holes. Through a previously completed IMA takedown procedure, a graft is created and inserted between the cartridges of the NADI. The graft is then secured firmly with the help of other robotic instruments. To provide a stable surface for the anastomosis, a cardiac stabilizer is introduced to hold the coronary artery distal to the diseased part. A small incision is made on the coronary artery to insert the anvil of the nadi. With the press of a button, the cartridge comes down on the coronary artery with the IMA graft, and multiple staples are fired around the graft for a successful anastomosis. After the anvil is removed, the incision for its entry is closed with previously placed sutures. The nadi has two major components within its structure that facilitate such anastomosis. The knife performs an arteriotomy from inside the coronary artery, and the staples secure the IMA graft for a complete automated anastomosis. This restores blood flow to the coronary artery. Nadi is also available as a handheld device that can be manually operated by surgeons for open procedures. Precise, rapid, and efficiently reproducible anastomosis by nadi. Connecting life.
And so this the nadi, it will be, I think will take us about a year to actually make it clinically available to most places, because we do have to firstly complete the manufacturing right now. It's a very, very precise, fine manufacturing. And also we will do 100 cases of clinical trial, do 6 months post of angio to make sure that the grafts are, showing acceptable patencies, and then come out to the market. But I think this will absolutely revolutionize, and we will use the fifth arm for the robotic part or another port for bringing this, even the other flexible device. We also have multi-fire clip applier. So taking IMA down, you don't have to take the clip applier out each time and bring it in. So one can have this in one arm and then just use it as needed. We are very focused on what we call Maya, virtual reality, augmented reality, and mixed reality. And people who have been in our lab, I think they could appreciate, this is really a wonderful way of teaching, training, practicing simulation. And also, our goal is to, at some point, literally get rid of the whole surgeon command center. And with the use of AR glasses and some small thing handheld, one can literally operate from wherever. I'm just going to take a few minutes based on my own experience in the past, and I'm sure we are all familiar with various incision approaches, full sternotomy, thoracotomy, and total endoscopy. So this was actually my first patient. 6 months later, you can't even tell where his incisions were. I don't show it for cosmetic reasons, but mainly to show there was absolutely no disruption of skeletal structure. And this is really what translates into a very rapid recovery, less pain, etc. So just a few videos just to kind of give you what is feasible. I think once we all get going, this is my earlier videos whereby U-clips were actually available. And I developed this technique and in fact helped with the development of the U-clips. And we could do interrupted anastomosis. 5 U-clips were placed ahead of time while the IMA was still attached to the chest wall. And then we just bring it down and pass it through. And this really translated into very rapid anastomosis on a beating heart. Our average times were 6 to 8 minutes. And basically you put those 5 U-clips away from you and additional 3 U-clips go in. And since these U-clips don't, you just break it up, and because of the nitronol, it curls up with the memory, and you're done. Since this company was acquired by Medtronic, and they shut down the whole U-clip thing, so we basically used the 7.0 Pronova double-ended suture, and I used to place a suture through the heel, and then bring it down, put few knots to keep it tied down there, and then essentially just run the suture start out in the opposite side and come to the toe, and one more suture on the surgeon side of the toe. And this technique actually avoided any purse stringing that one may encounter because of the lack of tactile feedback. So we actually continue to advance, and I did a lot of early development of these cases back in 2002 and 3 timeframes. So this is a double graft from the right-sided pores, whereby the lima was going to be attached to the LAD. And firstly, I did not know that it will work, but then we place a deep pericardial suture, pull the heart over to the right side, and with the stabilizer, pulled it over. So we, in fact, were able to do Lima to LAD from right side. And this is the right coronary where the Lima was used. And in the right coronary, we routinely will use shunt unless it is totally occluded, because it really does not tolerate ischemia well, and various hemodynamic or arrhythmia issues occur. And this is a wonderful technique actually of way. So you can see a lot of blood was going through and gave us the comfort to continue to do this thing. And so you see this completed the right to right coronary and left Lima to LAD from the right ports. And then also we have done an optis marginal as well. So we do pericardiotomy posterior to the phrenic nerve. And again, the same technique which allows us to do these anastomosis. So I did a quadruple graft actually with the cardiac anastomosis, which of course, again, is no longer available. And this was a pretty big actually device. And so we harvested both the IMAs here. And I'm measuring because we were going to use the Lima for a sequential OM1 and 2, and then use the Lima for LAD. And then we took a small piece of vein. So this patient had congenital anomaly where both hands were missing, and also had Hodgkin's radiation. So nobody wanted to touch the sternum. So with this technique, we were able to do 4 grafts using this connecting device that time. Unfortunately, this again got acquired by another large company, and this decided not to pursue. But now I think what we have developed, this coronary connector, will absolutely change. And it is 1/8 size of this current or this cardiac device. So basically we place a ato-vortex triangular suture there and a single silastic to occlude transiently. And these things are done very fast, literally in 6 seconds, you are done with anastomosis. And this will really reduce our operative times, even in open cases with the connector. So this one has a previously loaded Lima. This is the OM2 graft. And as you can see, we don't displace the heart at all. With the robotics, you bring the camera and instruments to the vessel. And so literally you can reach, except the PDA from the right side, because you don't have the space at all. But, these posterolateral vessels, ramus, LED diagonal, all can be achieved through this technique. So we did a sequential, the previously placed U-clips, and this went to OM1. And then Rima was loaded onto the device, and we did the Rima to LAD here. And again, and then we took a small piece of vein and attached that to the diagonal artery. So if you look at it too, there is obviously, we all recognize there is very low adoption, and unfortunately, no stabilizer is available today commercially. And one is that there's a steep learning curve. I think there are anastomotic challenges on a beating heart without tactile feedback, and one must commit. It is, of course, doable, but really it requires a lot of practice, etc. I think the graft compromise can have serious consequences. Arrested heart, nobody actually will do, because again, it adds to additional learning curve and expense. And then there are there's a serious lack of mentors, because not many people actually are doing TCAB. Even right now, literally globally, a very small number of surgeons. And again, because of the lack of availability of the stabilizer, the field literally is dying down. This is my experience. And as you can see, we've done, I would say, almost 40% for multi-vessel cases. And then we combined with hybrid. And I think that is a great way of doing. We also, including cardiologists, recognize there is nothing better than memories. And 2 memories are better than 1. And Lima really to LAD, that makes a difference. And so we did these cases whereby, the certain right and circumflex were stented. And then we also combined this with some of these valve cases in the younger patients. These are results which are very acceptable, and these were all early our cases from, I reported this back in 2004. Very acceptable mortality, conversions, reintervention, all of them are quite low. So what is really needed? I think we need, first of all, experience in the minimally invasive approaches. I think we all recognize the benefits, and it really needs a lot of commitment, patience, practice, and persistence. It is a team approach. Everybody must know, and one must do it as a program and not to dabble, occasionally, because it will not succeed. And the technology side, of course, affordability factor has been a major thing. And also enabling technologies are really necessary. Stabilizer, connector will be very helpful because not everybody feels comfortable suturing. And the 7.0 Prolene, again, there are questions about whether they're available or not everywhere. So I reported actually back in 2011 at our STS meeting, and it's published in Annals in 2012, 164 consecutive beating heart TCAP cases without conversion. So we really looked at all different things as to what can potentially cause, and looked at our own history and really figured out a way that we can avoid conversion. And I must say this was a great accomplishment. It was a total teamwork at every level. If you do have a chance, please look it up. On the intracardiac side, everything literally can be done today in relation to various intracardiac approaches, typical port placement for the mitrals, groin cannulation for peripheral CPB, replacements can be done, and they're great for young people for cosmetic reasons. And this is a patient post-op 4 weeks with repair and ASD. Again, all these procedures can be carried out. I think robot allows a higher rate of repairs because of beautiful vision that you get. So we did also ablation in over 50 plus cases using cryoprobe, and with excellent results actually. You can do all the lesion. So where we are today in terms of the regulatory, in India, we are approved by CDSCO. ISO 13485 is an international standard required for medical devices. And we are part of Make in India and on the government portal. We are initiating already the process. So we have hired consultants both for the FDA and CE. But I think there are 122 countries globally that either will accept Indian approval or minimal registration requirements. And so where we are today, we have installed 11 systems, over 255 various multi-specialty procedures have been done, mostly, of course, have been non-cardiac. And I have done personally few cardiac cases just to kind of get started as a stepping stone. We are also placing our system at Johns Hopkins in Baltimore. In fact, in August, it is going there, and they really want to participate in some of these developments, teaching, training, etc. These are all different types of procedures. I know it's a long list, I'll skip it. So we are also working towards various single-arm applications, whereby a lot of the diagnostic and therapeutic things in various areas, literally using everything can be done. And we are developing telesurgery. We are very focused on the whole virtual procedure that you can literally operate on patient ahead of time. And the goal is to really what I call decentralized excellence, whereby through various mobile units and including placing our mantra system on a truck and offer services wherever needed. I show this picture as 82-year-old farmer. This is what really keeps me motivated. I did 2 bypasses back in 2012, of course, using Da Vinci at the time. And he went home in 2 days. A week later, he was back on his farm. And this is really, I think we can revive this cardiac field, and knowing, the volumes in India and the enthusiasm among surgeons, there will be a learning curve, I think, but we can absolutely do it. And this is our team of very young engineers, average age of 26, 27. So we are very proud of Make in India. Intuitive never filed a single patent thinking that it will not happen. And we have done it. And Dr. Fred Moll here in the middle, he has joined forces. He was the founder of Intuitive Surgical back then. So thank you very much, and Jai Hind. And I'll take any questions if the time permits here. Thank you.
Thank you, Dr. Srivastav. It was a very enlightening presentation for all of us. And we are all happy and congratulate you for making such a high-end device in this country. So thank you very much, and please take care of yourself, sir. Get well soon, and then we see you in person very soon.
Thank you very much.
Right, sir. Thank you,
Bye.
sir.
Bye.
The SSI Maya that sir was talking about, is being demonstrated at the SSI stall. So anybody who is interested can go and have a look at that. And then now I would request the chairpersons to continue with the session. Thank you.
I would like to request Dr. to stand. Tissue well and everything.
This one.
Good afternoon. At the outset, let me thank the organizers from SGPGI, Dr. Agarwal and his team for inviting me to deliver this talk. This next 10 minutes, I'll be just taking through the first Make in India bioprosthetic valve. Today, the Indian narrative, it mainly focuses on from where this tissue is made and how it is processed, what are the new strategies utilized to prevent early degeneration of this bioprosthetic valve, to prevent early calcification of this bioprosthetic valve. And overall, how many patients have been implemented across India and also abroad. I'll be going to this in the next few minutes. It was developed by the India's well-known industry, that's Merrill, and the pericardium is harvested from reputed abattoirs, that is the slaughterhouses in Australia and New Zealand, to create a fully functional bioprosthetic valve, that's the heart valve, which has been made in India. Well, mainly it undergoes deep anti-calcification process, reduction of the bioburden part, advanced methods to handle the bioprosthetic tissue valve, and establishing predictive preclinical in vitro and in vivo models to establish biofunctionality of the heart valves, which can postulate long-term durability. Till date, it's almost crossed 7 years. In fact, the transcatheter valve came into picture first. Subsequently, after that, after 2 years, we started using the surgical valves. I'll come to that in detail in the next few slides. And also to establish the long-term durability via human clinical trials, and thus longevity of the artificial bioprosthetic valve to be noted. The clinical trial is almost completed. It's already into the market. As I mentioned, it is a valve which is got from the cows, and they are derived from processed biological tissues to be implemented into the humans. The development of such devices originated in an attempt to circumvent some of the clinical complications associated with early development of mechanical heart valve, and also has resulted in a rapid proliferation of bioprosthetic valves for a variety of applications. We can use either valves, vascular grafts, biohybrid vascular grafts, ligament substitutes, pericardial patches, and many more can be utilized from these bioprocesses. As I mentioned, it is sourced from Australia and has undergone a lot of required scrutiny before implementing into the human systems. They are all well certified. This is the standard international certification before you use a bioprosthetic valve. And one has to be familiar that where it is procured in Australia, starting from the birth of the like a calf is born, and as it grows till the time of slaughter, it has been monitored very closely. All vaccinations been done. Any disease process has to be looked into very clearly. And it is very specific that I think most of them are familiar with this mad cow disease, that is bovine spongiform encephalopathy. which is free from these pericardium which is procured at these places. Well, these are the different techniques of how the valve is fixed. But I would like to just put that the most widely used polyfunctional molecule is the 5-carbon molecule of glutaldehyde. And this technique in turn inhibits, I'll come to that next, it inhibits early calcification in these valves. Well, development of anti-calcification process is a new entity which has been brought into picture in these bioprosthetic valves. That is, ethanol pretreatment of glutathione cross-linked tissue significantly alters the material, rendering it unfavorable for lipid absorption. And lipid abstraction by combination of ethanol and surfactant would mitigate calcification of glutathione-treated bioprocesses. As I mentioned, glutaldehyde cross-linked tissues with mainly a denaturant, a surfactant, and a cross-linking agent, which in turn will reduce in vivo calcification. It's a process which has been conducted in their main branch at Vapi in Gujarat. The leaflets are washed with 0.625% of glutathione to make it free from the treatment solution. Then they are fixed on the bioprocesses frame and undergoes various tests. And after that, each valve undergoes a revolution, which is finally fit to be implanted into the human system. The durability testing and the dynamic failure are checked according to the Indian standards guidelines of 8403-3. This is a coding of that guideline. And they undergo the testing in these machineries. An animal implementation was done in sheep to study the challenges faced, and which turned out to be quite fine in the follow-up of even about 3 to 4 years in the animal models also. Coming to the current valve, which is come to picture, it has been modified almost, designed and redesigned almost 3 times. And now they have come up with the daffodil neo valve. I was one of the part of the investigators of this valve when the clinical trial was ongoing process 5 years back. It's a tri-leaflet valve, and the frame is composed of acetyl copolymer, and the commissures are with the PET film structures, and the frame is made of alloy in a wire form. And we have a polyester fabric, a sewing ring, and suture markers on that valve. The neo valve, which has been just introduced last year itself, has improved profile. It has reduced dimensions, especially the mitral protrusion. If you see the previous valve which has come up, which even I had implanted, I used to observe a gradient across the LVOT after replacing the mitral valve. In fact, all the cases I had preserved the chordae. A gradient of at least 8-10 was coming. And that time we gave feedback to the manufacturers, and over a period of time they have modified it. And in the present neo valve, even that point has been addressed. I have follow-up of all those patients, and the gradient remains same, doesn't increase, and there are no as such symptoms. But on echocardiography, we do get that gradient across the LVOT. Of course, improves the stent to tissue annulus diameter ratio. And the new one which they have introduced in IoT position is even 17 size valve has been come into the market, and it has been available only on request. As I mentioned, it's the 3 tri-leaflet valve. And before we implement it, it undergoes testing. In each valve undergoes a testing of almost around 200 million cycles proven in vitro durability. After that only it is packed and sealed off into the market. And as I told, how it can be an anti-calcification property, what exactly they do, they treat it in the nitrogen gas atmosphere, which eliminates air oxidation of aldehyde to acids, and which in turn prevents attraction of calcium ions. A denaturing agent is used. In fact, they don't declare what is the agent they are using. That in turn reduces the bioburden and phospholipids load from the residual biological debris. And a surface active agent removes phospholipids from deep intracellular compounds. All these things help in preventing calcification at the earliest. I think people who are used will be familiar with this valve. These are different components of the valve, whether it's a polymer support ring or in an alloy form, the frame which is formed, the tri-leaflet valve, sewing rings, And of course, we have both the aortic and the mitral processes of various sizes. These are the holders with ease of expanded. Once we implant and cut down those sutures, it can be easily, the holder can be easily expanded. Should not be a problem. This slide depicts the same, that is the type of materials used and the sewing ring, about the sewing ring and the ease of implantability. This is how it comes in a packed stage, wherein we do take a sterile holder and try to hold it with this holder, and has been expanded from the container which is available. Normally, after expanding, we normally wash. I normally use it in the 3 separate bowls of saline up there, wherein we wash it with saline. And even though the cultures are negative and it is in sterile format, we as a protocol always follow to send 3 cultures of all the 3 saline bowl washers. I wash it for a minute on each bowl, and each minute, and that is sent for culture, and subsequently a follow-up is done on the culture report. Still now we have not grown any culture, any issues of that kind. Well, last 5 years, as I mentioned, the surgical exposure with the 5 years follow-up what we have. So we do have replaced with the 19 mm sizes valve with a gradient of around 12 to plus 5, and even a 21 size valve with a gradient of around 9 to 6. These are the various specifications of the valve which will be depicted on the valve per se itself. Whenever we use, all this information data will be available with us. Valve sizes vary between 17 to 29, both in aortic and in aortic, and in mitral from 23 to 33. 23 and 25. I have not used 23, I used 25. 23 and 17 valve sizes I have not used. Well, the average age group, what we had done, the clinical trial and subsequent last 5 years, the average age group of mitral valve was around 49 plus or minus 14 years. And the aortic was 60 years plus or minus 8 years. The clinical trial was conducted in 19 centers, and 136 patients were followed up. And in fact, I ended up doing the maximum valves in the country, around 46 valves during the clinical trial itself, that is during a 1 year period. Subsequently, a DCJ approval was called for, wherein the DCJ, they had raised some issues, and after that, even that was clarified and DCJ approval has been given. It is not FDA approved valve. Of course, even our TTK Chitra is not FDA approved. We have implanted almost in the country and abroad around more than 1.9 lakhs of TTK Chitra till date today. So for the current Indian population, if you ask me, yes, definitely it makes a huge difference. And we have been using this valve, and many other centers have been using it. And today it's already in the market. Other than USA, UK, Germany, Japan, I think the rest all countries have started using daffodil valve. It's been published in the European Journal about 4 years back, and we have 6 years follow-up of these cases. And overall trial size performed in this follow-up of the cases, the mean pressure gradient as well as the effective RFS improved significantly. And in the last almost the full follow-up, what we have of completed follow-up of 3 years. Most of the aortic valves, what we implement or across the country, what people see, especially in India, is of annulus of around 19 to 21. That's the common valve. I ended up using 25 valve also. I ended up doing root enlargement procedures have been done. 2 cases I have done root enlargement procedures. A follow-up of one is of 4 years, another is just around 18 months follow-up is there. They're doing well in age group of around 60s and 70s. Even aortic ascending aorta replacement has been done using this bioprosthetic valve. And all mitral valves, as I mentioned, always end up preserving the chordae almost completely, or try to debulk as much as possible, and always go ahead with the preservation of chordae. Double valve replacement in our institute I have not done, but there are institutes who have done 1 or 2 double valve replacements using the same valve. Thank you. I'm happy to take any questions on this valve. Yes.
Thank you. So the changeover from the design in 5 years' time, what was the reason for them to come up so frequently with
the first design what I implanted the mitral valve, we had a challenge while parachuting the mitral valve into the LA. So the sutures were getting getting stuck in those struts, long struts. So immediately they changed. Within, I think within 3 months, they came out with a new design. That was one. Subsequently, what happened, those struts in the material were a little long. And that follow-up patients, even after implementing also around 7, 8, LUT gradient I was getting. In fact, but not clinically much significance. I accepted, and even the follow-up also, last 4, 5 years follow-up I have patients. The gradient remains same, 8, 9 gradient is there. So with that, when we gave a feedback, they looked into that and tried to reduce the strut. That has come as a new valve now. Profile was a little bit, yes.
But I realized that the stress is moving out.
Oh.
When you are really nearing the, because there was always a chance of damage.
Yeah. That has been looked into and everything. Yes.
So I have a question about manufacturing, implementation. Just want to have information about, is there everything about TAVI compliant?
Yes, it is TAVI compliant. They have mentioned it. Yes.
Have you any experience of doing TAVI?
No, sir. In fact, our institute does not perform TAVI, but definitely TAVI, sir, they have crossed almost around 11,000 numbers till date. TAVI, my valve, what they have come up, they have crossed 11,000 in the country.
No, I'm talking about valve.
Valve in, I have not done. No. Anybody at the industry can answer this question, if anywhere the valve has been utilized for, because it's just 5 years old, sir. I think till now we have not got that degeneration or not required it. Maybe the coming years may help us to answer this question.
But when by designing the valve, you kept that.
Yes, that has been kept. It is compatible for valve and valve, yes. In fact, they can replace their own valve with this. The first valve only came as my valve was the TAVI valve only they came. Then subsequently after that, after 2 years of the good success of that, then surgical valve we started implementing.
Thank you, Dr. I have one question about your manufacturing. The process you described that you procure the pericardium.
Yes.
Or where you procure the pericardium from Australian cows. So what is so special about Australian cow? If it is acquired locally, I believe the manufacturing cost would be a lot less.
Yeah, that's very good, sir. But unfortunately, the government doesn't allow. We don't have any certified slaughterhouses in the country. We have slaughterhouses certified only to eat.
Because
certifiable cows in India.
It's not in India. It's not that law is not there. Slaughterhouses, certified slaughterhouses for meat only to eat. It is available as of now in the country, but we don't have. We don't have
the process of
making it not
specific pinned out pericardium. The thickness has to be very much durable for wall making, which is not available. The technology is still not in our country. I was just
they are the suppliers even for US also, sir. The Australian government, they get the raw material from there itself.
Including Edwards.
Edwards also, all they got from there itself.
I just tell because we were trying to get jugular vein from Al-Kabir. And unfortunately, the legal thing was so big, we had to give up because we were thinking of using the thing from Al-Kabir. Because they were saying that fellow is actually telling, so we are throwing all that. So we thought we'll try to procure it.
Even
we get said that
Dr. Chandian tried to procure a lot of pericardium.
I think even procuring any bovine tissue now in our country.
It's not permissible now.
It's very difficult.
It's
Once
difficult.
you add bovine tissue for anything.
Even animal studies have been banned, sir. We can't do animal studies also.
Wet labs were conducted by J&J on bovine hearts all the time. They have been given up. It's getting more and more difficult to get bovine tissue. It's a practical problem.
But if there are legalized slaughterhouses, then I'm sure that.
There are none, that is the issue.
They are not there, so definitely can make a return.
There are, but they were not able to do it. Pig also is a problem.
Thank you, sir.
Even pig is a problem.
Yes.
We are running already 1 hour late. So we move on next topic.
Thank you.
Asked by Dr. Yusuf. We talk on robotic cardiac surgery and them. This is not session before that.
Good afternoon, everyone. I won't take much of your time before lunch. So I was asked to give an overview of robotic cardiac surgery. So we all know robotic was introduced for cardiac surgery, but there were no takers. So went off, and now with urology, general surgery, gynecology leading the field, now we are back on. Increasingly in the West, mitral valve surgery is pretty much established. And recently, there is an interest in CABG overall, where India is also a big player. And as I mentioned in the morning, aortic valve replacement is also being started over the last 2 to 3 years. It is very useful for excision of right and left atrial tumors. So why robotic assist when we are already performing minimal invasive, although it's not in big numbers? It is much better for the patient and the surgeon as well. It's easier, visibility is better with better outcomes. So of course, quicker recovery, even shorter than minimal invasive. But the drawback is the cost, longer learning curve. Still, we are learning. So there is a lot more progress to make in this field. So just run through the common procedures. The robotic assist mitral valve surgery, it's pretty much like minimal invasive. So we actually combine both. Unless we have 2 surgeons, it is difficult to do it all from the console. I'll show you how we do it with a short video. So the patient is placed as minimal invasive mitral. Peripheral cannulation is standard as in the minimal invasive. And these are the placement of ports. The port is placed similarly like the minimal invasive, but much smaller incision. I'll show you how we have moved on from that. And 2 ports above and below the incision. Forearm space below, slightly above. And the one more medial, this is for the LA retractor. It is a 4-port technique. The camera goes through the incision port. This is a much more elegant or improvised version. This is from Hassam Balki's team. It's not my slide, it's his slide. You can see they've made the port really small. This is where we are working towards. The surgeon sits comfortably and then performs the procedure. This was a P2 prolapse, which we did a few months ago. And cannulation is pretty standard like the minimal invasive. I usually go around both artery and vein because later on when we close, if there's any problems, we have control. And I use a hexagon stitch, which is 1 per string for this, more for juniors, for the vein, and a pentagon for the aorta. So these are the marking ports. So we mark with 4 fingers and 2 or 3 fingers at the top. So this is a speed video. Then Seldinger technique with TE guidance for peripheral cannulation. I tend to do the aortic first, but most surgeons do venous, that's the preference. The bicaval view is good to place the venous lines. And now we have moved from single to bicaval from the internal jugular and the femoral, because it gives better drainage and you can work with even less experienced perfusionist. So that is always a problem. We don't need to always use vacuum. And there are these newer cannulas. So this is how we do it. I do all this minimal invasive, placing the sutures, opening the pericardium, up to clamping. But with another surgeon trained, we can get them to do this all. We can straight away open the pericardium from the console. Placing this root cannula stitch is not easy with the robotic and controlling it. So we do this minimal invasive. And without endo clamp, it is also difficult to place the. So you need a good assistant who can place the cross clamp on the aorta, which I'm still not comfortable. Once all this is done, go sit comfortably in the console. And the advantage is this LA retractor can be moved as we place the sutures. Then you can see it's very excellent for repairs, not so much beneficial for replacement, but for repairs, it is extremely useful. We can literally see everything. That's the left atrial bulge, which we place and pull out. And the whole valve is seen nicely, that large P2 prolapse. I tend to use neocords. I do rarely resect. If it's very bulky, then we do triangular resection. It's individual preference. Some robotic surgeons do still resections as well. Quadrangular resection may be difficult, but triangular resection is very simple. So you sit comfortably, the arms are moving, 4 arms, as I showed you earlier. The suture placements are extremely good. It's very efficient and exactly where you want it to be, because the movement of the arms and the vision makes it very useful. So once the sutures are placed, we check, and the neocords can easily be placed. You can really look this patient. We place 2 neocords and then test it. Once the ring is there, then I go down again and put the core knots and get out. So again, all this with a trained assistant can be done by sitting in the console. So the surgeon can just sit in the console and get out. So that's how it can be. And this is well established now in the West. This was Mark Gillenau's early 1,000 cases, which he published in 2018. Very low conversion rate, and most of them are converted to thoracotomy, even in that 4%. Mortality, stroke rate have been similar to open procedures. So there's no doubt they've come off, most surgeons have come off the learning curve, and all these procedures can be done now. Atrial septal defects, especially primum sinus venosus defects, it's beautiful because you can literally see every part where you want to put the switches when compared to minimal invasive. And for mitral repairs, we don't have to tilt the heart as an open, so you do it as the anatomy where you want it to be. So whichever procedure, as we already discussed, we use neocords. So end of the day, the idea is to repair with these 3 facts in mind. Restore full mobility of the leaflets, increase coaptation to not less than 0.75 centimeters, and stabilize the annulus. Now moving on to robotic assist CABG, which is more commonly done in India than the valve procedures. So Da Vinci assist is what we still do. You're moving towards totally endoscopic. You've seen SSI Mantra presentation. They are more working towards cardiac surgery instruments, which may be helpful in the future. So this was a presentation published last year from work in Europe. So just before COVID, over the 4 years period, there's been a significant growth of CABG, robotic assist CABG in Europe. So the 2/3 of the procedures are now CABGs. But if you look at the breakdown, only 5% of those procedures are bilateral mammaries. So most of them are single mammaries. It's different in our country. So there's been exponential growth of centers that adopted and numbers. And when they looked at observed mortality compared to the control mortality with Euroscore, it was significantly less in the group that had robotic assist CABG. Because in patients who had more comorbidities, elderly, doing just the Lima LID and getting hybrid is much better, immediate and long-term, in reducing mortality and morbidity. So this review article published in Journal of American College of Cardiology showed not only did the robotic assist procedures, both CABG and mitral, reduced hospital stay and quicker recovery within 2 to 3 weeks, but with surgeons coming off learning curve, there is less complications and less mortality compared to open procedures. So this is how we do our CABG procedures. I have a short video to show as well. So 3-port technique for robotic assist mammary harvest. The mid port is where the incision would go more laterally. I'll show it more on the video. And then 2 ports, 4 centimeters, 4 finger breadths apart. So about 6 to 7 centimeters. And then we do with the mid port extended to 5 centimeters. The biggest advantage is we don't have to retract with the ribs as we do in minimal invasive. That's what the patient goes home with, multi-vessel, 3, 4. Commonly we perform 2 or 3 and 4 rarely. Single now it's coming less and less. And 2 drains on both sides. We use intercostal blocks and they're extubated usually by the evening or 6 to 8 hours if it's night case. And first day we get rid of all the lines and get them mobilized. Usually by day 2 or day 3, they go home. Single vessel, following day they go home. Because single vessel, we don't need retraction at all, just soft tissue. So the biggest advantage over minimal invasive, no rib retraction, and we are able to perform total arterial because we get good length. We'll show you the video, and all 3 or 4 grafts can be covered. One thing we have noticed from the patients is their anxiety or anxious about having a cut in the leg. That is a big factor to avoid in especially old patients and ladies as well. When we say there's no cut in the legs, a lot of patients turn towards robotic. Shorter incision, and of course, quick recovery and kinder to the surgeon as well. So this is a typical post-robotic CABG X-ray where you hardly see any collapse. This is not the case with minimal invasive and not so even with sternotomies. So there are certain contraindications. Previous lung surgery with adhesions because we need to put 3 ports with the lung fully down. So it is a contraindication because minimal invasive we may be able to get away but not with robotic. Poor lung capacity, less than 50% FiO2, we are cautious, less than 40 FEV1, we don't. Unstable patients, no, because it takes slightly longer to harvest the mammaries. For 2 mammaries, our average time is around 1.5 hours. I'll show you our times. And relative contraindications are really relative with experience. It is teamwork. I'm thankful to my mentor, Frank Van Pratt, who started our program 4 years ago. This meta-analysis published a few years ago, comparing open towards robotic assistant TCAP, showed reduced incidence of MACE, but half the incidence compared to open procedures. But there was slightly more restenotomy for bleeding in the TCAP group, but not the robotic assist. So they concluded there was reduced incidence of MACE, much reduced infection rates. In our series, we had no infection and no increase in graft occlusion or reintervention. We came over or grew up over our learning curve and convinced a cardiologist and the team by doing more hybrids, which is a good way to move. So let me show you the short video. So we mark the anterior axillary line as a landmark and go with the middle incision just slightly above that. Because in small patients, it can be very tricky, be very close to the mammary. So 4 finger breadths below for the lower port, which on the left side is the microforceps, and it's exactly opposite on the other side. I dock individually on both sides. So that's a technique we developed. So the upper port can be a problem hitting the shoulder. That's where we have to be very careful. That's where we mark with the marking pen. Then once we dock, we go sit comfortably. And I do systematically as we do as juniors in open technique. First, I take down the fascia. Then I do my side, then the other side. This way we can avoid damage because lower down, it's very easy to damage the artery, which we have done in the initial phase. So then there is panic. So this muscular area, it's very important to take down the fascia, go down to see the bifurcation, and then come up and do it. And you can see we're comfortably sitting, no back breaking. So we need one assistant. I usually keep my physician assistant. It's best to keep the same team for the first 25 or even 50 cases. Scrub nurse, the robotic nurse, and the assistant, who can be a physician assistant or your trainee. And the big vessels, I'm a bit more cautious. I clip any medium-sized vessel as well. But with experience, you may buzz it. I don't do that. Clips cost. So you have to be careful on the clips as well. So each clip costs about 2,000 rupees because it's 100 clips that we can employ. So we tend to use about 30 clips for bilateral mammaries. Single mammary, less than 10 clips. So once we take down this side, then we go on to the other side and make sure it comes down well. I do pedicled often because there is no problem of sternal wound healing. In this case, I'll show you a skeletonized on the right. Whichever way, it doesn't make much difference, but I tend to keep the pedicle because it's easier to hold and do the mammary, do sequential anastomosis. Then we open the posterior pericardium much below the phrenic. Then they go scrub again and dock the other side. Again, same anatomical landmarks. Again, the right shoulder has to be very careful. Once we dock, then the first thing I do here is open the pleura to come in, because later on we can't see from this side. If there's any bleeding, we can easily assess from the other side. And I clip the vein as we do in open. This is an important step for me. Once we clip, we get another 3 centimeters beyond proximally, which we were not able to do by docking on the left side. So this gives us extra length to cover comfortably. And we do this with the scissors. So for the double mammary, we need an extra instrument, which is the scissors, and extra clips. So that adds a little more cost. But we have made packages to make it easier and tell the patients as well to prepare beforehand. So similar, but here the vein on the other side is usually pretty big. So if it's too troublesome, we can avoid it by taking skeletonized, which we did in this case. Otherwise, we can take it with the vein. Advantage of taking with the vein is it makes handling easier during the anastomosis. So it's all about making it easier and adaptable for more surgeons. By docking on the other side, it's exactly the same as left mammary. Once we learn to take one mammary, then taking bilateral is not difficult at all. So then you can see we go beyond bifurcation, we can utilize that extra length. And then we clip proximally and cut it. Then we take it out. Beyond this, it's very similar to the minimal invasive, just that we make a slightly smaller cut. So this is taken out through the lower port. See, usually 15 to 18 centimeters, but not less than 13 most of the time. And then the anastomosis is done as usual. So this is our console time. Start about just over 175 cases now of bilateral mammaries. So we have one of the biggest series in the world on this, which we're publishing now. So it's about 90 minutes total console time from the time you dock, undock, move around, scrub, all that. But actual working time will be about 75 minutes or so. This is a short video, which is again courtesy Dr. Hazam Balki, which when I was there last month, look, it is very much doable with stabilizer, but that is a problem now. We don't have it with SSI mantra that may be made feasible for us. So the 7-0 proline, 7-0 proline sutures with 7 centimeters. So that it's very much doable, but it's a longer learning curve. But we are working on making it more adaptable by less invasive or less cumbersome techniques. We need to find an anastomotic device, which is where I think we have to work as surgeons to make it more adaptable. And as I already mentioned, hybrid coronary revascularization is a way forward, and to start as well, to get our cardiology colleagues on the armamentarium. It's good for multivessel elderly patients, patients with diffuse coronary diabetics for the right side can be stented, and patients with higher Euroscore. Gives best of both worlds. We use a 2-stage approach. Day 0, we operate, and day 1, patients mobilized. Then day 2, we get them to do the stenting, and we always check the anastomosis, the patency of the internal mammaries. That gives more reassurance, and again, we have learned from that, but it's better for the patients. So all the advantages, we don't need a hybrid theater, no touch technique, and better long-term outcomes. So I'll briefly present our series. So 320 CABGs, as you know, others were only 22 patients, 1 thymectomy and 2 left atrial, 1 left atrial, 1 right atrial mass excisions. So mortality, 4 patients, 2 had an arrest, One was an intramyocardial, which I think we bled later. One was a moderate LV, which arrested. The other two delayed. They were very sick patients to start. We did Lima LAD, they didn't make it. Re-operations were 8, of which 3 we had to go back open and redo the anastomosis following hybrid. The remaining 5 were for bleeding, of which we had to do sternotomy in some of them. 3 we had to do sternotomies. So oldest we operated was a 93-year-old, which is the oldest patient who had cardiac surgery in our country. CKD, 5 of them, 25% had lung disease, 25 had poor LV function, and quite a few of them had more than 9 HbA1c. Infection is not a problem. So multi-vessels, more than 60%, and bilateral memories, the same. So a third of our patients had hybrid. It's suitable for most patients with good LV multi-vessel. The group that we tend to avoid are poor LV with diffuse disease. I don't touch them. In my clinic now, it is more difficult for me to convince patients to have open procedures. Because when they come to me now, they come with a fixed mind of having robotic. So that would change in most units, I think here as well. There's an increasing trend towards robotic assist procedures. It's very useful for elderly, and commonly in our country, unfortunately, a lot of them are under 60, where getting them back to work yearly will be very useful. Within 2 weeks, they can get back to normal activity, including manual labor within 3 weeks, driving. Just to finish off, robotic assist aortic valve replacement. It's a 4-port technique, similar to mitral. Way would be to start off with ASDs, mitral, CABG, yes, because it's more technical handling the tissues. And then once we are comfortable with mitral, we can move on to aortic procedures. And again, we have to be comfortable, at least now, comfortable with right anterior thoracotomy, minimal invasive, before moving on to robotic assist. So I showed the slide in the morning, 4-port technique. Currently, we use the camera through the incision port. And this was a publication about 2 years ago from the Vinay Bhardwaj group. So they looked at their first 20 patients, 5 were in aortic insufficiency, others were aortic stenosis. They used all stented valves. So after 5 patients, their timings were very similar. Valvectomy took about 8 to 10 minutes, and suture placement about 20 minutes. Aortic closure takes longer. So that's it technically. In the ranked difficulty comparing mitral to aortic, leaflet repair techniques were more difficult in mitral, but here the aortotomy closure, because it's very close and you have a good surgeon to follow the sutures while closing. Annular suture placements, yes. Valvectomy may be more difficult in some very calcified bicuspid, but as I mentioned earlier, cutting with the scissors with diathermy at 2 will be easier. And just to finish off, I looked at what AI says, ChatGPT, Google, which patients look at. So ChatGPT shows this, clearly identifies all the benefits as we have mentioned, shorter hospital stay, less pain, reduced risks and complications. Procedures also have been mentioned. The limitations are also very clearly mentioned, cost as one of the limitations, and to choose the right surgeon. Thank you. Yes, currently the robotic assist is harvesting, opening the pericardium, getting rid of pericardial fat, and then doing it anastomosis under direct vision.
And the Western data always says that it's pump assist also when they're doing making heart surgery.
Pump assist, not, I mean, if you look at surgeons doing robotic assist CABGs, very few are pump assist. Very few, but there are surgeons who do pump assist.
How much does it cost?
The procedures, in our center, we have a package which is twice as open. Our center open is 3.5. This is 7.
So how much do you charge for MICS CABG?
Between the two, 5. 5 to 5.5.
That's how it has great features. So we still have a long way to go with our.
Yes, we are This probably in the next 5 to 10 years, we'll get to a state where we say this is to be done. But we are growing, yes, we are learning from each other and growing.
So is it okay right now you see that invest into a robotic system to get on with this?
Yes, I think this will be future because I was talking minimal invasive to patients, not many agreed. But now robotic is a buzzword in every specialty. Patients come asking, sir, can you do robotic? They don't even understand what we do. I have to explain this is what we do too, but nothing of that. They just come asking, sir, can you do robotic? That's it. So they apply it or sync it with technology and least invasion. That's in the now people's mindset. Thank you.
Thank you. This concludes the first 3 sessions of the morning of today. Now I would invite everyone for lunch, and we would like to reassemble by 2:15 in the hall, because that's going to be a very interesting session. And it is very dear to our heart because it's about our department.
Thank you so much. So sorry for
उधर वो कुर्सियां ठीक करो।
जी सर
इधर वाली कुर्सियों को रखा हुआ है।
Yes. No, no, but you are saying that name is subject listing. That is it. I think.
लोड किया क्या
सर कर रहे हैं
अभी प्रोजेक्ट में करिएगा
प्रोजेक्ट नहीं कर रहे हैं
बाद में कर देगा क्या है ठीक है वही आपके उसमें देख लेंगे
सर सेशन 2 में है ना आपका सेशन 2 है ठीक है वो चल रहा आपका कर दिया सर
ठीक है उसमें कुछ चेंजेस करने के बाद छोड़ दीजिए उसको ऑपरेट कैसे करते हैं यहाँ से
सर हम आके बताएंगे आपको उस टाइम पे जस्ट आपको स्लाइड यहाँ से चेंज करना होगा सर काउंटर पे रिसेप्शन काउंटर पे
Sir, welcome back, everyone. I hope all of us have had a good lunch and now ready for the next session. This is a very important session for us. And this is inauguration of this meeting plus some memories of the Department of CVTS. So I will request our director, Professor Dhiman, to come on the dais, sir. And I will request Dean Dr. Ambesh to come on the dais. And I will request Dr. Shantanu Pandey to come on the dais.
लोड कर दीजिए,
अच्छा प्रेजेंट करें, एक और है,
हम इसी से कर दीजिए।
चलो ये वाला कर देते हैं बाद में, तो दूसरा एक और एसी नहीं। इसको कर दूंगा मिनिमाइज।
The Department of CVTS at SGPGI started properly on 15th of July 1987. That is when Professor Mittal, who ultimately retired as professor but joined as assistant professor, joined this department. And that is why I have chosen 15 July to be the foundation day for our department. And this is going to be first proper foundation day, but otherwise 5th foundation day of the department. And on the occasion of this day, I have requested most of the people who have retired from the department to be also present with us so that we can honor them. Now I would request our director, Dr. Dhiman sir, to say a few words.
Professor S.K. Agarwal, head of the department, acting head today of the department, CVTS, and Professor S.P. Ambesh, Dean of the PGI, Dr. Pandey. और मैं देख रहा हूँ कि काफी लोग जो हैं यहाँ के एलुमनाई हैं जो आए हैं, और सीनियर प्रोफेसर्स भी देख रहा हूँ आए हैं। आप सबको का बहुत बहुत अभिनंदन है आज। And my dear colleagues, ladies and gentlemen, ये परंपरा जो है हमने फाउंडेशन डे मनाने की अभी बहुत ज्यादा समय नहीं हुआ, शुरू की है। लगभग हर डिपार्टमेंट जो है अपना एक फाउंडेशन डे मनाता है। इसका मेन पर्पस हमारा ये था कि जैसे जन्मदिन मनाया जाता है वैसे ही जो है हम अपना फाउंडेशन डे मनाते हैं, और उस दिन हम इवैल्यूएट करते हैं कि हमने अचीव क्या किया है और हमारा क्या विजन है फॉर द नेक्स्ट 5 to 10 years। ये बहुत जरूरी है देखना हर डिपार्टमेंट के लिए, if the department has to progress. Vision is very, very important. Aim is very important. Objectives to achieve is very, very important. अब जहां तक CVTS की बात है, मैं एक्चुअली में मेंबर ऑफ NMC भी रहा हूं, तो there used to be a lot of discussion about this branch. कभी ये खाली कार्डियोवैस्कुलर एंड थोरेसिक सर्जरी, कभी ये थोरेसिक सर्जरी, कभी ये only the cardiovascular surgery or the vascular surgery, so many things. लेकिन what I have seen over here in past few years also, कि हमारे पास स्टूडेंट ही नहीं आते हैं। अब what is the confusion, I don't know. CVTS या थोरेसिक सर्जरी या वेस्कुलर सर्जरी, तो मेरे ख्याल में जब आप ये कॉन्फ्रेंस करते हैं तो इस पे भी थोड़ा सा मंथन होना चाहिए कि हमारी ब्रांच चले कैसे आगे। We have to train, we should have the students also. अगर हम स्टूडेंट्स ही नहीं आएंगे तो what is the future of the branch? तो आप कहाँ से लेके आएंगे? I have come to know कि all over India last year only the 7 students have joined through the NEET test. I hope I am right. तो ये तो बहुत ही चीज है। तो आप यहाँ पे कर रहे हैं अपनी
कॉन्फ्रेंस कर रहे हैं, मेरे ख्याल में एक छोटा सा मंथन इस बारे में भी होना चाहिए कि हाउ टू increase the participation of the students towards this branch also. That's one. And the number two is whether you really want a division. That is another thing that has to be discussed at the national level and be communicated to the NMC also. मेरी तरफ से being a director, what I am seeing for last over few years, that's my comments on this thing. And my sincere request to all of the people, I am seeing senior professors also, senior faculty over here also. So some kind of the discussion has to be on this thing and some output has to be there to be communicated to the NMC also. This is very, very important. बाकी तो सब ठीक है. Whenever you are short of the manpower, be it the students or the MCH students जो आप होते हैं and other things, then the output is not that good as you have in the private sector also. The second issue that we are facing at SGPGI is that there is a long waiting list. I am amazed to see that if you are giving a waiting period of the 1 year and the 2 years for the ischemic heart disease surgeries, I don't know what to do actually. For the valve disease also, I don't know, you are the best person. Although I have the medical background, but I don't have much of the cardiac or background. So I think this needs to be addressed in the public hospitals or the government institutes and the medical colleges also. That if we can, how can we decrease the waiting time also? These are my two concerns as far as in कि आप उस पे थोड़ा बहुत देखिए, एड्रेस करिए जितना भी कर सकते हैं. और I want that this branch should grow. NMC has done 2 divisions, but we have to do over here. So you making 2 departments from 1 department is very difficult. So it's a challenge for me also how to do it. NMC has done it, but there is a problem here. So these are the issues that I see in relation to the CVTS. And whatever you think about it, let me know also, because I have to take it on an administrative side also, how to do the things in a right perspective also. And with these words, I stop over here and I congratulate once again Dr. Professor S.K. Agarwal and his team for arranging or organizing this outstanding conference also. In addition, also bringing the, I would say, the best senior most professors over here, stalwarts over here in this conference also. Thank you so much.
Thank you, sir. Actually, in the morning only, we have discussed certain aspects of the topics that you have mentioned. And we have also decided that in the national forum, we are going to discuss these things and we should come out with some concrete results soon. Now I would request Dr. Ambesh to say a few words about us.
Professor R.K. Dhiman, Director of this institute. Professor S.K. Agarwal, Head of the Department of Cardiothoracic and Vascular Surgery. Professor Shantanu Pandey, Organizing Chairperson, Organizing Secretary. हमारी first MCH student, Professor Abha Chandra. Other alumni of this institute, experts, and esteemed speakers, nursing and technical officers of this institute, ladies and gentlemen. काफी हर्ष की बात है जब भी हम फाउंडेशन डे मनाते हैं. फाउंडेशन डे जैसे कहते हैं ना, बर्थ इट्स लाइक ए बर्थडे ऑफ योर बेबी. उसी तरह से किसी भी डिपार्टमेंट का फाउंडेशन डे, वो उसका बर्थ डेट हम एक तरह से उसको मनाते हैं. और मैं कहूँगा आई एम वेरी हैप्पी कि आज आई थिंक 36th हम बर्थडे डिपार्टमेंट ऑफ कार्डियोथोरेसिक एंड वेस्कुलर सर्जरी का मना रहे हैं SGPGI में. SGPGI, as you all know, it's a super specialty tertiary care medical institute. और इसने अपने समय में, मैं कहूँगा कि बहुत ही कम समय में जो स्थान पा लिया है, वो बहुत कम इंस्टीट्यूट पा पाए. मैं जब PGI से आया था 1991 में, तो मुझे लोगों ने कहा कि डॉक्टर साहब आप फैकल्टी पोजीशन छोड़ के यहाँ से जा रहे हो, यूपी में जा रहे हो, यार क्या तुम्हें हो गया है. सो मैनी माई कोलीग्स, सीनियर कोलीग्स काउंसिल्ड मी कि यार मत जाओ यार यूपी में. बट मैंने कहा नहीं यार, मुझे जाना है, और वो मेरा होम टाउन है. होम टाउन क्या, मेरी होम स्टेट है. आई हैव टू गो देयर. और लोगों ने कहा कि यार तुम तो 1-2 साल बाद वापस आ जाओगे छोड़ के. तो मेरे हेड थे, उन्होंने यही कहा कि प्रोफेसर हरवीर सिंह, तो बोले बेटा जा रहे हो, बट मैं तुम्हारे लिए 1 साल का वेट करूंगा. आई विल नॉट फिल अप दिस सीट एंड यू कम बैक. और मैं वापस नहीं लौटा. फिर वो जब भी मिले, मैंने कहा सर प्रोग्रेस जिस तरह से चल रही है SGPGI की is beyond expectation. I never imagined that, honestly. तो मैं ये कहूँगा कि जिस तरह से SGPGI ने ग्रोथ की है, और डिपार्टमेंट ऑफ कार्डियोथोरेसिक एंड वेस्कुलर सर्जरी को मैंने शुरू से देखा है. शुरू में आई यूज्ड टू डू कार्डियक एनेस्थीसिया. तो किस तरह से डेवलप हुआ है डिपार्टमेंट, और आज हम जो चीजें कर पा रहे हैं, वी आर डूइंग फंटास्टिक जॉब इन रोबोटिक कार्डियक सर्जरी, मिनिमली इन्वेजिव सर्जरी. तो ये तारीफ काबिल है. ये सारी चीजें मैं ज्यादा वक्त नहीं लूंगा. बाकी रही बात डिसिमेशन ऑफ नॉलेज बेसिकली, तो जैसा हमारा, अगर आप लोगों ने उपनिषद वगैरह का ज्ञान है, तो उपनिषद तैत्तिरीय में चैप्टर 2 में जब हम बात करते हैं, तो हमारा शरीर 5 कोशा में डिवाइड है. तो उसमें से जो 3rd कोशा है, दैट इज मनोमाया कोश. और मनोमाया कोश इज बेसिकली योर इंटेलेक्ट. और आपकी जो पर्सनैलिटी होती है, वो दैट इज नोन बिकॉज ऑफ योर इंटेलेक्ट. दैट इज बिकॉज ऑफ मनोमाया कोश, नॉट बिकॉज ऑफ आनंद माया कोश और अन्नमाया कोश और मनोमाया कोश. तो वो इंटेलेक्ट जो है, वो हम जब एक दूसरे से इंटरेक्ट करते हैं, जैसे कहते हैं सर्वद्रव्येषु विद्येय द्रव्यमाहुर्नुत्तमम् आहारत्वाद अनर्घत्वाद अक्षयत्वाद च सर्वदा. यानी कि हम जो नॉलेज गेन करते हैं, उसको बांटने में वो नॉलेज से बढ़ती है. वो नॉलेज जब हम बांटते हैं, तो हमारी भी नॉलेज बढ़ती है. सो दैट इज द, ये हमारा जो ज्ञान है, वो ऐसी प्रॉपर्टी है जिसको न कोई चुरा सकता है, न कोई उसको जला सकता है. बट आप उसे बांटते हो तो आपका भी ज्ञान बढ़ता है, ये कम नहीं होता. तो मैं कहूँगा SGPGI इस क्षेत्र में बहुत बढ़िया काम कर रही है. ढेर सारे ऑर्गेनाइजेशन, ये सिंपोजियम, अपडेट्स, कॉन्फ्रेंसेस आगे आने वाले समय में भी आएंगी. और प्रोफेसर धीमन सर जब से आए हैं, तब से मैंने देखा है कि फाउंडेशन डे जो है ऑलमोस्ट हर डिपार्टमेंट में मनाया जा रहा है. और उस फाउंडेशन डे को हम एक अपडेट में या एक कॉन्फ्रेंस में, मिनी कॉन्फ्रेंस में हम कन्वर्ट करके ये बहुत बढ़िया काम कर रहे हैं. तो मैं ज्यादा वक्त नहीं लूंगा. मैं ढेर सारी शुभकामनाएं, ढेर सारी बधाइयां दूंगा ऑर्गेनाइजिंग टीम को और सारे एक्सपर्ट्स को, कि वो जब यहाँ आए हैं और वो ज्ञान अपना बांटेंगे, और ज्ञान बांटने के साथ साथ वो ज्ञान अपना अर्जित भी करेंगे, बढ़ाएंगे भी. थैंक यू वेरी मच.
Our head of the department and organizing chairperson of this Foundation Day cum CME, Professor Gupta, could not be with us today because of his personal commitments in some court-related matter, but he has sent his words to be conveyed to the audience. Honorable Director, Professor Dhiman Sahab, honorable colleagues on and off the dais, and my loving students, please accept my heartiest gratitude to be present on the occasion. I know that during my absence, Professor Agarwal and Professor Pandey, along with all the members in the department, have worked tirelessly for putting up a very relevant scientific program for everyone. I only wish that you all take away excellent gems from here and put it to the best use for healing the needy at your places of work with all the compassion and skills that you have all. I hope to join you in tomorrow's program and hope you will all forgive me for today's absence. Aap sabhi ka mangal ho. As written by Dr. Gupta. Now I would request Professor Abha Chandra to introduce. We are starting the first P.K. Ghosh Memorial Oration. Professor Ghosh was the first professor and head of the department of this department. 2 years ago, he passed away. And after that, this is the first occasion that we have been able to do something in the department. So we have decided to start an oration in his memory. And so first Professor Ghosh Memorial Oration is to be given today by Professor R.S. Verma, who is a senior professor and from IIT Chennai and worked a lot in the field of cardiovascular surgery research. Now I would request Professor Abha Chandra, who was the first student of the department, to introduce Dr. Ghosh, and then Dr. Pandey will introduce this orator for the oration today.
Good afternoon to all of you. Professor Dhiman, Director of Sanjay Gandhi Institute, Dr. Ambesh, the Dean of Sanjay Gandhi Institute, Dr. S.K. Agarwal, and Dr. Shantanu from the Department of Cardiovascular Thoracic Surgery, and my dear friends and colleagues and delegates who have come for this Foundation Day today. It has been a proud moment for me, and it's a privilege, and I'm honored to have been asked to give tributes to Professor Prabal Ghosh, who had been my mentor and my teacher. So, Professor Prabal Ghosh was born on 20th of August, 1945 in Calcutta, and he was born to Binay and Sifali Ghosh. He was later married in 1986 to Shoshana, who was from Israel. And he had a educational background. He did his MBBS in 1968 from Calcutta Medical College, Kolkata. And he did his MS in 1972 from AIIMS, New Delhi, and MCH in 1975 from AIIMS, New Delhi. Later, he did his fellow of Royal College of Surgeons of England in 1976, and he became the diplomate of Israeli board in 1986. He was fellow of the American College of Cardiology in 1996, and he was also awarded the fellow of the European Board of Thoracic and Cardiovascular Surgeons in 1998. He had been a consultant in various institutes in India and abroad. He was in Salzburg after his MCH from 1987 to 1989, and thereafter he joined in 1989. He joined as professor head of the Department of Cardiovascular Thoracic Surgery at Sanjay Gandhi Institute here in Lucknow. And later, in his later part, he was also the dean for a period of, I think, 3 years. I'm not very sure. And he had been co-editor for Cord Europeum, and he had been advisor to the European Heart Institute. So in addition to this, he had been co-editor and members to various journals, the European journal basically. Further, as you go down his career, he was fellow of Texas Heart Institute. He was also the fellow of the Cleveland Clinic Foundation, St. Francis Hospital, Houston, and Cleveland, New York City from 1980 to 1982 in Cleveland. He was a pool scientist at the Medical College, Calcutta from 1982 to 1983. And he was the vice chairman cardiothoracic surgery at Tel Aviv in Iklova Hospital from 1983 to 1984. Back in India, he had joined National Heart Institution in New Delhi. From 1984 to 1986, he worked there for 2 years. And then he moved again back to Austria in Salzburg, where he served for a period from 1987 to 1989. And that was the time when he was coordinating the upcoming of this cardiovascular and thoracic surgery department at Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow. So he later joined in 1989. As far as I remember, it was the month of September when he came and when I saw him for the first time. And he stayed here till 1995. Thereafter, he left and he went to Israel in Tel Aviv, where he was working in the same hospital where he was working earlier as dean and as also a visiting professor there, and where he spent his rest of his life. He had been member of the Fellow of the Royal College of Surgeons. He was also a member of the American College of Cardiology, European Association of Cardiac Surgeons, Indian Association of Cardiac Surgeons. He was also on the editorial board in the year 1989, and he was member of the International Society of Cardiac Surgeons. He had a number of international and national publications, out of which there was one from the Texas Heart Institute Journal in 1987, which was basically on intravalvular implantation of mitral valve prosthesis. And later, he had another very another elaborative and a descriptive article which he had written for the Annals of Thoracic Surgery, which was on coronary osteal reconstruction. He published, this was a book which was compiled, and there were various authors from different sectors from Europe, basically from Europe, and this was on cardiac reconstruction. And this book also has a chapter on coronary reconstruction also. And as an academician, he was a very good researcher. He was a very good teacher. He had illustrious career and he had traveled widely. So he had a remarkable memory, and he was a voracious reader and was very creative, intelligent, insightful, and eloquent writer. As a teacher, I remember whenever a new journal will come into the library, he will take the journal because he was a member of the library. He will take the journal that particular day, finish it overnight, and next day he will be bombarding us with a lot of questions from that journal. And invariably, I will tell him always that I think a new journal has come in the library. So he always used to laugh on that. And his other interests have been, he would write poetries in Bengali, and he was also a dramatist. If you go on to his health side, he had suffered a non-Hodgkin's lymphoma in 2008, for which he was treated. He had received chemotherapy, and during which time he had developed alopecia. Then he recovered, and he was seen later at the World Congress, which was organized by Dr. K.M. Cherian in Chennai in 2000, I think it was 2010. So he had come for that conference. And later, like I had seen him here in Sanjay Gandhi when he came for the ISCTS conference, which was organized in 2015. He was not in a very good health that time also, because he was not able to walk, but he still came to India because he was a true Indian. And he used to keep telling me, I want to come back to India. And it was on 19 January 2020 at Tel Aviv, Israel, when he left for his heavenly abode. So this was his whole profile and his entire career. He was like a very good mentor and teacher to me. That's what I could say. Thank you so much. So this was one of the pictures which was taken in 2015 here in the campus in Sanjay Gandhi.
Good afternoon, and thank you very much, madam, for introducing Professor Ghosh to us. I have honor of presenting you Dr. R.S. Verma. He is professor he was professor at Chennai in biotechnology, and he is now currently director of NIIT Allahabad. So he did his graduation and post-graduation from Allahabad University, and he did his PhD from Jawaharlal Nehru University in 1984. Following this, he went to US as postdoctorate fellow and in School of Medicine, Indiana University Medical Center, Indianapolis, stayed 5 years there and subsequently joined as research scientist at National Institute of Health, Bethesda. Following completing his assignment, he was appointed assistant professor in Department of Medicine at University of Pennsylvania. He served 11 years in there, and then he came back to India to be general manager and vice president in pharmaceutical industry before joining IIT Madras in 2004. He has several areas where he has contributed to in stem cell regeneration and tissue engineering, and he has achieved grant from almost all this major supporting grant awarding agencies in India. His areas of research are trans differentiation study of stem cells into cardiac tissue and elucidation and mechanism and genetics at epigenetic level. So this is very interesting, and I have read few of his articles and they could give you goosebumps. Study on 3D culture of stem cells and cancer cells under microgravity, construction of novel cytolytic fusion protein against cancer, development of drug delivery system against leukemia, liver and heart valve tissue engineering. This is what he is going to talk about today. Pathway in study of Fanconi anemia. He has been fellow of National Academy of Science, FEMI, Biotechnology Research Society of India, fellow of Applied Biotechnology, Madras Research Foundation, and has been awarded at many occasions. He has 206 publications. He has filed 23 patents, 10 have been granted, and 1 has been transferred to industry. So that is the profile of Professor R.S. Verma, which I call him now to please give the first P.K. Ghosh Memorial Oration.
Somebody has to help me. Where is my presentation? This is the one. No, not this one. It should be that one. My name is there. Where is that one? अच्छा ओके इसमें होगा ना क्या कहते हैं वो पेन ड्राइव लगी हुई है लगी नहीं वो लगी हुई है इसको जरा वो लगाओ कॉन्फ्रेंस का होगा ना कॉन्फ्रेंस डे वन का फोल्डर है इसमें डे वन में जाइए सेशन वन हाँ रमेश्वर वन Thank you very much. I am really honored that I have been given first oration talk for the great, person, researcher, teacher, and cardiovascular and thoracic surgeon. And I'm thankful to Shantanu. I met few months back in Varanasi in a meeting, and we started discussing about, because my idea was that I should translate something to whatever I have developed into the at least clinical trial, human trials. So that was my aim. So once again, thank you very much. In audience, Director Sanjay Gandhi PG SPGI Medical College and other dignitaries. I would like to share some of my research. I have listened in the morning so many great, talks, robotics, and I was impressed. One more talk, which is Dr. Shukla's talk. I think he has widened the whole things, and I can share with my work that I have developed passion for a research in my early age also, and since I'm continuing right now, whenever I get the opportunity, I do that. This work is done by one of the niece of one of the President of India, Sarvapalli Radhakrishnan. So she came to me, and I can tell you a story. When she got that mission in PhD in IT Madras, he came to walking to me, says, I want to work with you. I said, why did you choose to me? He said, no, you work on stem cell and work. And you know that she was a nurse for 5 years. And then she did MTech, and then she joined the PhD program. So I really admire her because her passion was because she was helping some of the cardiac surgeons during the surgery. So she has developed the passion to do something research on cardiovascular things. That's what she came to me. And I said, what do you want to do? She told me, I want to develop a heart wall using stem cell technology. I said, okay. So I said, I have the knowledge only stem cell, but I don't have knowledge of heart wall. That was my clear answer was there at that time. So we discussed a lot, and they started those telling them, okay, let me do that something. So this is basically her work, which I am presenting right now. And we file a patent also. Patent has been granted now. And this is the time that we should able to do some clinical studies in this regard. So my topic will improvement of the biomechanical properties of decellularized bovine pericardium towards development of the heart wall. So my table of content will be introduction, heart wall heart disorders, treatment option, hypothesis, objectives. And objectives are three, basically design and fabrication of bihybrid. I'll go one by one, and then conclusion, I'll come to that. So there are two major types of heart walls are there. I think everybody knows in the audience. I don't have to speak on too much on those things, but let me see that there are something here is that here in these things, there every heart wall contains the three layers. Basically, it's a collagen, elastin, and gag, and then collagen, elastin again. So it's a sandwich kind of things. So develop any tissues, we need to stack all those things one by one. Then only we can do that. In this source, heart wall ensure unidirectional flow. That is the quality of the tissue that it has to go only unidirectional. Maintain cardiac dynamics. Has three-layer architecture, as I told you. Fibrosa, mainly towards collagen, towards outflow. Spongiola, mainly toward the gag. Ventricular, mainly elastin, below the inflow. And valvular, endothelial, and interstitial cells also among that one. So the valve disorder, so valve stenosis, valve fail to open fully, and flaps become rigid, thicken, or fuse together. And valve regurgitation is the valve do not close properly, and backflow comes out of that. There are the treatments are, I think everybody knows, medication and surgery, two of the options. And surgery contains the balloon, valvuloplasty, and valve repair and valve replacement. These three things options are available. And so heart valve has two things, is the mechanical properties and the biological properties. So motivation comes in by understanding the both properties first. Good mechanical strength, durability. This is mechanical valves I'm talking about. And suitable for replacement of the young patients, need lifelong anticoagulation. But in the morning I said people don't use also anticoagulation. So that's one thing which I learned now in this meeting. And biological properties, heart valves said the poor mechanical strength. That's the best things. Fatigue, regurgitation, leaflet tears, and calcium deposition is one of the things which everybody talks about that. And leaflet tears occasionally happens basically. Calcium deposition and pernicious overgrowth. Not suitable for young patients and high cost. So we thought that we can have a tissue engineering approach. This is our approach. So what we did, basically we need a 3 layers things. So we get native extracellular matrix, which is ECM based decellularized tissue with cross-linking agents. So cross-linking is very important because it gives stability of the tissues. We can use cross-linking agents on synthetic and natural polymers. We can imbibe in that one, impregnate basically, and hybrid scaffold with and without cells. Both we can make it. We have used the mesenchymal stem cell for cells. So what we need basically decellularized tissue with conventional cross-linking agent, but with polymer surface coating and also impregnation. So this is the problem statement, and the hypothesis that deposition of the synthetic polymer into decellularized bovine we have used basic bovine pericardium. Tissue will provide a 3D matrix with adequate mechanical properties required for fabrication of the heart valve. So now onwards, I am going to do basically the biochemistry and mechanical engineering part. So there's nothing in that one. So our 3 objectives were there. One, design and fabrication of the biohybrid scaffold using decellularized bovine pericardium and a slow degradation polymer suitable for heart valve tissue engineering. So whatever we are putting on top of the bovine pericardium has to be degraded slowly so it can maintain the native things. Detailed biochemical evaluation, I'll talk about that more, and assessment of the silver infiltration into the tissues. So fabrication, this is objective 1. So these are the few things are there. The first thing is the decellularization is very important things. Confirmation of decellularization, characterization of ECM, extracellular matrix, selection of polymer and characterization of nanofiber, and fabrication and characterization of biohybrid scaffold, mechanical properties and biological characterization. So decellularization, 3 ways we can do it. We can do physical or do chemicals, enzymatic, and combination of all. This causes disruption of ECM, removal of the glycosamine glycans is very important in growth factors because we don't want to reduce the immune response of the person because these are the one who develop the immune response when you are there in the bodies. We are using a deoxycholate for decellularization process, and decellularization means there is no cell, only the matrix left. That's a very important thing. So we have to characterize. Confirmation of characterization, we do histology, DNA estimation, histology, GAG. It's all biochemistry basically. So you can see A and B. A is basically where a lot of blue colors are there, blue dots are there. These are nuclei basically. When you do the decellularization, there is no nuclei present. So that's one issue, that there is no cell attachment there after decellularization. We do lot of characterization. Gel electrophoresis also shows decellularized bovine pericardium doesn't have any DNA, whereas the bovine pericardium has a lot of DNA in this lane basically. And we also characterize this DNA in this one also. These are all way to characterize. ECM characterization, because there are 3 layers are there, different tissues are there. So we do trichome, Asian blue, and BVG staining. After staining, we do some test to prove that this is correct. So we do DMF assays, we do colorimetry, bovine cardium, and you can see them that both have the quality, but there is a reduced quality and strengthening is there in both cases. So our cellularization works in this one. And then we select the polymer, what we want to do. So we have selected clinical trial studies, PCL and PLA, these are known, and chitosan. These are very slow degrading synthetic polymer. There's a natural hydrophilic polymers are there, which can be soluble in water also. Selection of the fabrication techniques, basically we can dip coating also, we can make a solution and dip into the tissue in that one. Second thing, electrospinning. Electrospinning is a really better one because we can coat the any tissues, any polymer into the surface of the membrane uniformly. So this is a machine is there which can coat them under the electric current. So optimization parameter, fabrication and characterization of the biohybrid scaffold. This collection by the electron microscopy, FTIR, and mechanical strength in that one. So you can see this is the first experiment when we try to align the fibers and see which combination of the fighter, which is PCL and chitosan. So finally, after so many ways doing all this combination, we found out 10% PCL, polycarbolactone, and 1% chitosan is a mixture which is giving the good fiber on the top of the bovine cardium in this one. And this is surface characterization of the biohybrid scaffold. This is A and B, basically you can see them. These are the bovine pericardium, and this is the decellularized bovine pericardium where the cellulars are there, and this is basically a high resolution C and D biohybrids are the images are there, which clearly shows there is a groups are there, the matrix are stained, and if they are connected on the tissue, we have to do FTIR in this one. So this is the hydrophilicity we check with the contact angle basically measurement, and you can see the fresh bovine pericardium and the biohybrid more or less the same one active. And this is the angle test we do with the measurement in this one. We also do FTIR. In this when we see whether the bonding attached or not, because attachment is very much, because it should not, with the blood flow, it should not go out of the, when there is a flow of the blood, it should not go out of the thing. And then we also see the mechanical strength also in this one. You can see here the mechanical strength of this biohybrid, and the control is more or less same or higher than this one in this case also. So you can see this is all properties. What we have done is, so it stabilizer and give more mechanical strength to those pericardium when we attach the polymer into those things. And this then biocompatibility also, this see that they should do that. So here is very direct contact, SAV is there, and then text on extract of scaffold on the cells. What we take this tissue and see whether this is mixing with the cellular X-ray, it is not destroying the other things. Then cell adhesion also we check, the cells are giving a adhesion through ECM. This is a electron microscopy and fluorescence imaging, and also DNA quantification. These are technique we and gate quantification we do that. So here is basically all this characterization is there, basically done. You can see that what is a hybrid, biohybrid does very nicely. They are attached to the cell membrane, and the fluorescent microscope shows that, ensure that there is a adhesion is there in this one. So MTTSA basically shows there is a no cell, degradation of the cells happen in those cases in this program. And these are different ways that we have done the different cells, stem cell also we can do other things, and we see that there is very compatible on those things. Compatibility means the cells grow on top of that scaffold basically. That's compatibility. So overview, if you see them, we have taken this clue from the native cells, and we have put a cells on top of that. Polymer ECM cell we make it, and after making them, what we do, we take a pericardium, decellularize them, and then we can, with electrospinning, we put on the polymer and then grow the cell after the top of that, and then see that native heart valve and made heart valve is characterized the same thickness and biological activity and also mechanical strength. In those three we have checked basically. So this eliminating the cross-linking agent that are known to be cause calcification is not there. Polymer impregation and pericardium without processing. That we have done. So we have developed a scaffold which is better than the other one in this one. Sorry. So conclusion of objective one was that optimize cellularized bovine pericardium with 1% DCA. We found the retention of the ECM, means the architect of the extracellular matrix is retained after the decellularization. Synthesized nanofibers, which are impregnated into the top of the pericardium, is also has a solvent system. Optimized fabrication, mimicked tri-layered heart valve structure, that is also equivalent. And uniaxial and properties, I'll talk about more about that isn't promising the wall, and biological analysis, so biocompatibility and hemocompatibility are there. So involvement of the evaluation of the biohybrid scaffold for tissue engineering. So we'll do the fabrication and then uniaxial mechanical strength characterization, and we have the isolation of human wall intestinal cells basically. So VIC cells, we isolate them and put on top of them and see how they are behaving there, and the biaxial testing. So basically it's a mechanical part. And if you see correctly, this is a collagen fiber orientation happens in the this pericardium and versus the heart valve. It's so different. This is so if you align any tissues on top of those things, you need to see this orientation have the maximum functioning also. So first you have to understand the architect and then go for functionality in this one. So the biaxial fabrication was there in this one. Mechanical strength of bovine pericardium is different in axial and circumferential direction. So that's a clue we have it. Alignment of the polymeric nanofiber increases the uniaxial mechanical strength along with the nanofiber, and anisotropy is required for the heart valve fabrication. So you can see here that this is the same images of these things decellularized. This is the PCL only. This is the bios hybrid scaffold, PCM and chitosan, and this is by aligned fibers. Aligned means you can see the fibers are almost in unidirectional in this one. You don't find 100% unidirectional, but I'll show you, you have to do the laser ablation for that, and then you can get those kind of things in this regard. So unisexual testing, we have done it, and you can see here that after tensile strength formation, the native versus this one, increase strength basically. Unidirectional, I'm talking about, not bidirectional yet in this one. And you can see time of electrospinning, how much we do that. As soon, if you increase the electrospin fiber coating timing, the number of the fiber whose strength and one by one on top of each other is increased. The strength is increased in one as you increase, but you can't increase too much because the fiber has to be stick to the ECM. That is very important also. So you can't have a too much layer, too much less layer also in that. So the pore size is also important when you do that, because the cell has to go inside the cell. You can't have a stack of the polymer so that it will block the entry of the cells. That is also very important. So we need to take care of that, and these are experiment also. And we have also the degradation, that how much time it takes that polymer to degrade so it can be take the natural shape. So you can see within 30 days, most of the things are degraded in this one. So this is a very important step that we have to do it in this regarding this. This is a basically experimental setup. I think this, we don't have this instrument. So mechanical engineering in the IT department, they help me in doing those things. And this is the one thing which I learned a lot, that if you make any tissue, how do you know how do you measure the strength of that thing? That's very important. How much weight you can put it so that it cannot break, but it can take it. As the heart valve takes the flow of the blood, so there is a strength and pressure is there. That pressure we have to do it. So that's the main thing is there. So there's a alignment is that these are all the cameras basically, and I'll show you next slide that this is the sample. Sample size is this much. This is the base, but where the sample is very small in that one. And then what happened basically, you can't measure it. You have to put a spot on those things and see microscopes, how much movement happened. So everything done under the microscope in a nanometer range, which is pressed, can be measured in that one. So we'll do this direction, and upward direction. So that is a very important thing we do. It took us basically 1 year to do this experiment because we were new, we didn't know how to do that. And they do a very hard stuff, mechanical engineering. Suppose this, they make a fabricate anything metal, they do in that one. So there is a big object is there, they can do better. But this much objective, when they started doing things, then they have to redesign the whole thing and try to do it. So this is the basically, you can see this, this is the pressure they put on top of that and measure it, how much weight they are going to put on that particular tissue and see that one. So the load cell is there in that one. And these are protocols were there, how much we are doing that. So there are 3 protocols are there. I'm not going to show you. And this is the basically final thing comes in this one. And when this comes, the results are amazing. This is the result, unisexual properties, that you do unidirectional pressure, how much change happened basically. So you can see here, this is the axials here in this one, how much we are putting those things and what happened to the tissue, how much weight they can. So you can see the stress is produced in megapascal and you stretch is how much. This is in millimeter. So if you put this much Pascal, 0.1, 0.5, I think 20 megapascal everybody, but 0.1, 0.05 megapascal is very difficult to measure. And that's what we did it. And then there is how much stress they can mean. So you can see 1.5 nanometer, the stress happen on those things. So this is a very important to understand how tissue behave in a system. We do a lot of work, I think, robotic surgery and everything, but the weight and pressure they take the tissue and has to respond, not to get degraded, something like that. So that's a wonderful thing to study in that one. And here is that. This paper, we try to publish it, but we got at least 6 times revision in this one. They were not happy that you are doing a pressure experiment only 1, 2, 3 times. They at least they say 1,000 times to do experiment, then only we'll know. Because what happened in the valve, how many times it goes and closes. So need to mimic the similar kind of things. So we really say that below 1,000 experiment will not accept the paper. So we did 1 year, I think I took this one, and you can see that the normal stress were this real axial and the biaxial, how much difference is there? Very close, nearby. And you can see these are all experimental details and how to plot it in this one and prove your point that yes, they can sustain it. And so many ways we did it. See, you can see here, so many things ways try to do that and convince the reviewer that our experiment is working. And they also helped me actually. They suggested how to do the experiment also, because they also were learning from us, those reviewer in that process. So finally, you can see the slope, what is coming. Now you can see here what I showed in the beginning, that how these stress collided each other. Similar kind of graph, you can measure it in those biohybrid things in this one. So stretch ratio versus stress. That's where this is the basically variation of stress. So you can see the variation. The biohybrid takes linear these things compared to the native pericardium. And here in this one, along to this is a axial direction and this is a circumstantial direction. Both directions they are able to equilibrate, means there is not much difference in the native pericardium and the hybrid cone. That's the main things in the degradation also. And this is all, these are basically testing of different antibodies that yes, our biohybrid contain all those material which has in this one, heart valve in this one. So we have corrected a lot of things in this one. This is a biological evaluation of bihybrid scaffold. These are all basically all collagen, collagen 1, collagen 2, memantine, fibrin, and lignin, all present there. So in decellularized bovine carrier and bihybrid also, which contain the cells, you can see here also in this one. They're much better bihybrid one compared to the decellularized bovine pericardium in this one. And this is also same scaffold, different ways of doing those things. You can see a stain of the different antibodies along with to characterize what is present in the cells. And you can see the quantification of total GAG, total DNA quantification. So very less DNA contained here in this one. DNA contained in this one, contained to bihybrid. So more or less, this shows that our bihybrid is much better compared to the normal bovine pericardium. So the conclusion is we have fabricated aligned biohybrid scaffold, uniaxial mechanical properties shows the enhanced properties along the axial direction. Biaxial analysis also showed anisotropic property of the bihybrid scaffold, a 20 times more the strength of the stiffness of the axial direction. Isolation of the VIC and other adhesion and proliferation of the bihybrid scaffold, and potential material for autologous valve tissue engineering. That's we predicted in this one. Third thing was that alignment. How to align these cells into the direction? Because it's very important. I showed you with the very first slide that pericardium, the pericardium versus this heart valve, both are different alignment of the cells. So we have to see that one also. So we do the laser micro patterning of the bioscaffold and study patterning of the biocompatibility and study of the patterning of the mechanical properties. These three experiments we did it. So here you can see here in this side that this is not laser ablated. This is a nanosecond laser ablated. You can see how aligned fibers can be created on those things, but exposing to the nanosecond of the laser in this one. So same image of the decellularized pericardium here, same image of the bihybrid scaffold after ablation, 60.64 microjoules, which are very, very minimal, and energy is very little in those ones. So they don't destroy the cell, but they just align those things in this one. And then effect of the laser, you can see energy compared to the dBm micro, they're always increasing the patterning in this one. And that also shows the bihybrid patterning was different. So it's in this case, joules energy point of view. We also characterize with the FTIR that there is no bonding is lost in those things basically. So here is this one. This is FTRI. This is a DSC basically. So it's close to the what is the native versus the bihybrid, and also scaffold shows that Young modulus. Young modulus is basically tells about the properties and strength of those things which are comparable in those after laser treatment. That's not destroying the property of the tissues basically. So you can see here very nice alignment scaffold here in this one. And this basically groups are very important because cell infiltration has to be there. Because of cell infiltration, we require those kind of things. So image showing the adhesion of these are MSC molecule, which are mesenchymal stem cell as taking it there in this one. Before and after the laser ablation, you can see here nicely this one. This is the biological characterization of those things. So we can see here that is stained with the fibrin. They are all left. There is nothing. So you can see very nice cell adhesion on top of those groups, basically on top of that. And the groups are still visible in this case. And this is the basically correct another way of showing potential, showing them. This is biohybrid and decellulite. They have a similar property, but better biohybrid has them in this one. So the conclusion is that nanosecond pulse laser can be used to selectively ablate the portion of the polymer layer on the hybrid scaffold with preserving their overall structural integrity, which is very important. Optimization of the fluence in step and the mark time added to the microchannel with optimal width of the depth. The depth of the microchannel is very important. And fibroblast and the stem cells, so the better adhesion in both cases. So here is our final thing is there. We take the bio scaffold, we do the nanosecond ablation, and you see the micro patterning start in this one. And then cells are attached on those things, characterize them. And now this scaffold, and this is ready for making these valves in this one. So this is our conclusion, which I showed is the last objective is very fabricated microchannel biohybrid scaffold using nanosecond laser ablation achieved enhanced cellular colonization in the biohybrid scaffold, which is required for the tissues basically. Further, we would like to test these things because nowadays there is, I was talking to somebody told me that there is a artificial intelligence is there these days, which can give you the total size of this valve, how much required. So if you can get from patient, we can cut this valve into particular size and replace with them is a better option. So this is the one which we need you guys to help us in doing those things. These are some of the publication I can share with you. Janvi was the first, that was the lady I was talking about, Sarvapalli Janvi, and this we have 3 papers out of these 3 work basically. Every chapter has given you 1 paper. Thank you all. If any question, I can answer. Not related to medicine, but chemistry, I can answer.
Regeneration testing has been done.
Yes, it has been done.
How long period?
We have done 6 months. Yes. And
Calcification has-
calcification, there is no calcification in that one. Actually, calcification can be, we cannot say 100% because it has to go into the tissue, then only we can do that. Because we wanted to do in mice or rat, but they are so small heart that we cannot do this. We need to do the clinical studies in this one. जी बताइए.
How your laser ablations aligns the fibers in the.
Actually, this is because providing energy at the limited quantity, the groups are formed. The groups are already there. They just come into the alignment. This is what we talked about the previous papers in that case. And the energy which you are providing during the ablation has to be very minimum.
No, I know that is the 0.6.
Yeah, microjoules basically. Yeah. And it happens automatically. We don't know how it happens, to be honestly.
It's surprising to me,
Yeah.
because how they are aligned after ablating the fibers. So
Mechanism, I don't know, but we got the result because we did so many. It was breaking, it was, so many things we did. And we did so many things. This was done in actually Anna University.
Maybe the direction of the laser,
Maybe that thing, yeah. How do you do that? Yes.
Thank you, sir. Now I would request, एक मिनट sir, अब उसको बाद में कर लीजिएगा. I would request our director, Dean, and Dr. Pandey to present the oration plaque to Dr. Verma and the shawl. तो सर पीछे बैठ जाइए, तो कुछ नहीं होगा। हाँ, हम ऑनर के लिए कॉल कर लेते हैं, फिर बाकी लेक्चर हम लोग कर लेंगे। Now, before we start the two other talks of related to the department, because our director and dean has to go for another meeting, I would like to request them to honor our ex-faculty members and ex-staff who have contributed a lot to the department. So, first of all, I would like to invite Professor A.K. Srivastava. If he is not there, I would request Dr. Pankaj to accept the Dr. Vivek Kanhare. Dr. Sachin Talwar. I think he has gone off to sleep. So can Shiv, you accept it on his behalf? Dr. Sushil Singh.
Thank you.
Professor Gauranga Majumdar. Now the next group of people to be honored belong to the perfusion department. I would request Mr. S.V. Singh if he is there. If he is not there, I would request Dr. Pankaj to, Pankaj please for S.V. Singh also. Vivek, please accept for Abhay. Mr. Abhay Bapat is now working in Bhopal. They were the founder perfusion people of our department. Gyan Srivastava. So he recently retired from our department. Tanveer Hussain. He actually was a researcher yeah, he's retired. And he has done a lot of work for the department, both clinical as well as for research. Anju Kapoor. She is in CPM. Savitri Bose. I think she has not come, so again. Thank you. She is currently working in CMS office. And now come the most important member of the staff who have not only contributed to the patient care, but also taught us a lot in the patient care, both in the ward, ICU, as well as OT. So I will start with Sister Chaya Mehta. She not only built our department, but also built the department of neurology, the ICU, that has been built up by her only. And after that, she also contributed to the institute SCNO. Renu Roy. She was instrumental in starting our ICU. Now, Neelam Singh was supposed to come. She started our OT, but I would request Sister Esther to take it for her. And she is also supposed to take her own award.
Thank you, sir.
Rani's sister, whose real name is Esther Peter, because we have always called her Rani's sister. Sister Sunita. नहीं इसकी जगह वो लगाना है स्टेप लगाना है अभी इसको हटवा के स्टेप लगवा दूंगा मैं
और डायरेक्ट आ जाए सिस्टर्स पे ना रखने पर मैं पता करता हूं हां थैंक यू
Sister Chaitali. Sister Rekha. Sister Rekha Singh. अच्छा उनके पैर में चोट लगी हुई है तो कैन यू रिसीव इट फॉर हर एंड Rekha Saxena. Vijay sister. This rainy season has caused a lot of accidents. So some of our people are recovering. And last but not the least, Mr. Ram Bharose. No, because he was the attendant of our department. Now he's working in another department, and because he's going to retire in a month or so time. So,
I take on his behalf. I communicate this.
Thank you, sir. So it was a great honor.
Thank you. Thank you. Thank you.
Sir, who will you put it? Sir, who is सर राम भरोसे आ गए हैं. Now to continue our program, Professor Mittal was supposed to deliver his talk directly, but unfortunately he had to rush to USA because his son's graduation was there and he could not miss it. But he agreed to send us his talk on video. So we are going to play his talk now. यार उसको बुलाओ किसी को. वीडियो चलाओ ना सर. ऐसा ही लगाओ. ऑलरेडी है सर. क्या कर रहे हैं सर? जो वीडियो है उनका डॉक्टर मित्तल वाला सर, ये यूट्यूब से डाउनलोड करके लगाया था. डेवलपमेंट ऑफ डिपार्टमेंट. ये सर स्टार्टिंग दिस वन. हाँ. स्टार्ट कर.
Firstly, I would like to thank the organizers, especially for the work you are invited to deliver this talk. Today, I would like to share with you what one thing of establishing the CVTS department at SGPGIMS. These corridors land many members from the country. In fact, every site that I go in has countless stories to tell, but I will keep it brief for now. Let me start with a little bit about myself. I underwent my CVTS training at KM Hospital in Mumbai with Professor Paul, who I still remain indebted to. He grew me not only to be a good surgeon, but also a good manufacturer. Training under him was really tough and very stressful. We had to stay on the airline continuously for many months. It became our home. Every day was very demanding, but I remained determined not to quit, endure the pressure, and I'm glad that I did. The training set a great foundation for law followed. In the guidance of Professor Parulkar, I performed nearly 200 surgeries and many times played the roles of perfusionist, operating room nurse, and ICU nurse. In addition, the physiotherapist and manager for blood bank, oxygen bank, and officer supplies. Professor Parulkar instilled the value of ownership, how to manage inventory, and procure the consumer. He encouraged me to be a researcher and a thinker. As a result, I have published few original articles. All this knowledge came handy once I joined SGPGI. I came to SGPGI in 1987 and was the first faculty to develop the CVTS department. As you see from the aerial view, that time the entire area was under construction. I joined the institute on 16th of July 1987 and was allotted room number 303 in the administrative block. This was the room where all the work to build the department was initiated. Later, when the work block was ready, we moved to the core area of cardiac ICU. Subsequently, moving to the designated Cardiac Sciences Center in August of 1989. This was the view from my room. As you see, the construction work in full swing all around. The structure of the main hospital building was there, but interiors were yet to be completed. Beside the administrative block, only the 30-bed hospital was ready and functional. Well, within a few days of my joining, I was handed over a huge stack of files to organize and procure everything for cardiac surgery, as nothing was offered in Japanese family. Even the architects wanted the final details. I had to write the teaching and training curriculum along with as part of the service. The only other person available with me was Mr. S.P. Singh for his. I was totally at loss where to begin from. I took guidance from Professor Swadhyaka, who was the advisor to the institute and head of the staff selection committee. He sent me a long letter with encouraging words and advice that is stated, "Thank you for your letter. I'm happy to know that you have joined Sanjay Gandhi Postgraduate Institute as a first staff member. I have no doubt that you have made the right decision, as the institute has a great future." The procurement was not easy, as the available information was very scanty. There were very few centers doing regular and heart surgeries in North India, and almost none in the state of India. I gathered the information by writing various vendors, collated and trained the specifications for all desired equipment,
instruments, consumables, and other samples before the tenders were floated. Subsequently, all the bids were technically evaluated by me, which took something like this. The reports of accepted bids were then sent to purchase department for financial evaluation before the release of purchase orders. The task was even more daunting for selecting surgical instruments from various catalogs, defining the sizes, the quantities for 3 operating rooms based on anticipated various cardiovascular surgery. It was indeed an uphill task. The tender evaluation of this was even more tedious. I had to look for the equivalents in various tender bids, the instrument that I needed. Being a young faculty, I often had to face many biological exams to justify the requirements, right? The need for multi-mode ventilators, multiple pressure channels in electronicals, heating cooling machines, and the need for polypropylene sutures. I had to provide detailed information to Mr. Puri, the chief architect, who was less conversant with the cardiac surgery sector. We did many dummy exercises, cut to sizes on paper, about the equipment placement, detailing the ergonomics before finalizing the designs. Professor Gujral and Professor Venugopal helped me in finalizing the course curriculum for training, evaluation, and the examination for awarding the MCH degree. I started cardiac surgical outpatient services in September 1987 at 30th Hospital. From February 1988, most of the equipment started to arrive and their commissioning began. Our perfusionist and staff nurse also returned from training in KM Hospital in Mumbai. They prepared surgical ICU and cardiac surgery facility in neurosurgery operating room. I scouted around the scientific supply stores in Dhaka and convenience store on Rakesh Road in the city to have the first prototype of chest training artillery. I had few of my own personal surgical instrument, the remaining instrument, along with consumables I borrowed from Mr. Condi, the store in charge in KPM's surgical department. I carried out the first PDF closure on 31st August 1988. My team comprised of Dr. Pradeep Bhatnagar, who was a general surgeon in Perthville Hospital, Dr. A. Barokan, Dr. Mrs. Das, Sister Nitan, and Mr. S. Singh. Meanwhile, the outpatient department, along with the daycare ward, was commissioned in May 1988. I approached Professor Sisagua, who granted me permission to utilize this designated area in the daycare ward for developing cardiac OR and post-operative ICU. The engineers of UP, RNN, and biomedical engineer lent a full support to meet my requirement. Still, there were other challenges too, like the blood bank was very primitive, emergency lab services were almost non-existent. Besides this, there were issues of instrument, equipment, lack of protocols, and training manpower. I requested SQL Company to do part shipment of the surgical instruments to Telegram. I set up the base machine to help carve out connectors and intercardiac circuits. I got multiple polysmart oxygenator fabricated. We didn't have the oxygen supply. I borrowed few dimple cylinders from Superior Air Products, who were one of the vendors at that time. I accompanied the truck that was loaded with the cylinder to have them filled locally.
are prepared the prototype of various forms like perfusion, prescribed participation, post of orders, SIC chart, ward vitals, along with surgical notes, etc. By October 88, our team grew. It included Dr. Bhattanagar, Dr. Baronia, and Mrs. Khan, along with purchases, Mr. Singh and Mr. Bhatt. In addition, the staff nurses Neela, Esther, Renu, Alka, Pamela, etc. They all work tirelessly, always enthusiastic, eager to learn and deliver. We did many mock drills before putting our first patient on table. Despite the deficiencies, I did first aid closer on 28 November 1951. Successfully. This was the operating room where we started from with very, very limited space. My colleagues from KM Hospital gave a further boost to streamline the open heart surgery program, including Professor Kande Paukan and Mr. Joshi, the chief of business. We recruited first batch of senior residents, Dr. Bhattanagar, Dr. Monati, Dr. Prasad, and Dr. Chandra. By the end of June, we did 47 surgeries, of which 16 were open heart surgery. The trends were very early by now. As we chugged along, other faculty members joined. Professor Bosch was the last one to join. The vision of Professor Bosch was to produce technically well-trained, experienced, reliable, and academically conversant trainers who have different departments in the country. To initiate experimental research and clinical trials for appropriate technologies to develop indigenous base in India for high-tech surgery. To develop subspecialty in cardiovascular and thoracic surgery to be at par with current regular international norms and practices. He also defined the first areas as ischemic heart disease, reconstructive surgery, neonatal and pediatric surgery, and stage heart disease and transplantation, and allograft program. His vision and functioning of the department was shared in the very first meeting with CVTS faculty on 22nd August 1989. Professor Ghosh gave a push for academic excellence to seminars, journal club, clinical rundown, and combined meetings. He also initiated patient data collection for reading and publication purposes. He submitted the departmental report saying for evaluation and finally received a letter for MCHD recognition. We made two major contributions to the institute. One was to be an active player of hospital development fund, and another one was to design the institute logo. Very few will know that the logo of the institute was designed by us. We participated in the logo presentation of different artists and got selected by the evaluation committee. I would like to wind up my talk with a message to the junior fraternity. Success is not an accident. It is hard work, perseverance, learning, studying, and sacrifice. And most of all, love of what you are doing and never to give up. Thank you. And I must thank the audience for me.
After this historical introduction of the founder consultant of the department, now I would request Dr. Abha Chandra, she was the founder resident of the department, to share a few words of her experience. And then we start with the academic agenda of the day.
I have a small presentation, but I think after Dr. Pramod Mittal's presentation, this would be something which would be only strictly to the residents who were there in the cardiac surgery department, what we were supposed to do. So you've already heard the background, how the department came up. I had seen a couple of things which Dr. Mittal used to do. And I would just request the computer people once. Presentation.
क्या करिए आप जब नया स्पीकर आता है
कौन-सा बोला था?
जिसकी भी है उसको याद दिलाइए
आपका पैड लगे है ना, छोड़ दीजिए।
So I'll just start till they open the talk. I'll just give a background. I did my MBBS and MS from Aligarh Muslim University in UP. And thereafter, after I finished my MS in 1987 July, I worked in pediatric surgery. That was general pediatric surgery as a registrar. And then I was asked to join there as a lecturer in general surgery department. But fortunately, I just wanted to come back home, so I came back to Lucknow. And that was the time when Sanjay Gandhi had advertised for senior residents. So since once back home, and I had applied for the senior residency, I was asked to come for the interview here. So we had a MCQ exam and entrance test in which 3 people were selected after the final interview, which I was one of them. Dr. Ramasubramaniam, who's now presently in care in Hyderabad, he's the other one. And the third one was Dr. Mukul Chandra. Dr. Mukul Chandra is not amongst us anymore now because he had suffered from COVID. He was in States. He left the MCH course also, and he had went to States where he was giving services to the COVID patients. In that process, he acquired COVID. And then he was treated also. Finally, he went into renal failure. He was waiting for the transplant. He recovered from the dialysis part initially, and then they wanted him to go for a lung transplant also. But it was just 2-3 days back when I saw on his Facebook, his friends had given some tributes to him. Then I remembered, Mukul is no more now. So that's how I just came to know a couple of days back, Mukul is not there. So he was the other resident who had joined as after I had joined. So I had joined on 1st of June, 1989. And that was the time with the pediatric surgery background after 2 years working there and coming again to the adult area. It was slightly different for me. But since I was a hard worker and I was quite dedicated to my work, I just thought, let me, after my exposure with cardiothoracic surgery, whatever I had with Dr. Beg at Aligarh Muslim University, I thought this would be my second option. And when I came here, I found cardiac surgery to be quite interesting. And with the background of the cardiothoracic surgery, what I had seen at Aligarh and Dr. Gujral coming and doing the open heart procedures also there a couple of times. So it was something very enthusiastic for me. And I just came to the department, and the very first day, of course, Dr. Mittal was there and Dr. Ganju was there. These were the 2 persons who I had met. And I met Dr. Srivastava also on the same day, but I met him in the auto when I was going back home. So he only introduced me, ki I'm the other faculty who has joined. Oh, you have joined after me. So he had joined one day before me. So it was Dr. Srivastava was there. And then of course we had Dr. Mahan coming up after a couple of days. And Dr. Ghosh, of course, came in the month of September 1989, and he came and joined. So the entire faculty, we had 5 faculties at that time. And I was one of the residents in the department. And of course, everybody used to keep asking me to do night duties. So I do remember Dr. Pramod Mittal, when he operated the first case on the very first day when I came and joined, he gave me a chance to be the second assistant on the table. And of course, he said, next time when you come, you have to come prepared. Come, you should read and come. Don't come without reading, otherwise I will ask you to go out. I said, okay, sir. So he was a very hard worker. He used to stay with this patient overnight. He used to keep me awake. He used to make me stand next to the patient and ask me to count the drops of urine. So, and that was where I learned how you can detect the patient is not doing well. And then we had the Bennett ventilator, the huge one, which I never could work on it. And it was always Dr. Mittal used to do the work on that ventilator. And we had the anesthetist around. Dr. Baronia was there that time. He used to be there in the night times also helping us. So we had Sister Renu, and who was one of the staff nurses in the ICU area, who used to help me. And of course, that was the time when a lot of centers in India were coming up. And of course, UP, this was the only center which had come up, and besides the BHU, which was already established there, but they were not doing much of open heart. Hardly any open hearts were being done there. And as every institute had a learning curve, this institute also had a learning curve in the beginning. And we all understood the physiology, what extracorporeal circulation does, what are the changes it makes in the particular patient's body. So all these things were coming up at that time. Better understanding of the entire fact led us to the better results which came up later. Of course, the most important thing had been the myocardial protection. And when you come to the myocardial protection, of course, that was another aspect which at that particular instant, we were using crystalloid cardioplasia. And crystalloid cardioplasia here in this institute, I still remember, I used to be asked early in the morning at 6 o'clock, go to the theater, and in the Ringer's lactate bottle, we would prepare the cardioplasia and keep it in the fridge for the usage of that particular days. So we had the different components like the dextrose, the mannitol, soda bicarb, the gentamicin, and what else we had? 1 second. So and of course the mannitol. So these were the ingredients which were added to it, and they were kept in. The bottle was sealed and kept in the fridge to be used at the time of surgery, and it was prepared freshly on that particular day in the morning. That used to be my job, I remember, because I was here in the hostel, and I used to get up very early, so that was my work to do. So I used to go and prepare this. But at that particular time, it was, you would have people who were there at that time, Buckbur's papers were coming out on different substrates of cardioplasia, and everybody was trying to see which substrate is best for the patient. So it was later, people did come up with the blood cardioplasia and the different ways of perfusing it, how to deliver the cardioplasia to a particular patient, dependent on the pathology of the particular heart, plus also, if required, dual delivery also was to be made, with whether it was retrograde or antegrade. So these things we all learned through that. And of course, in the ICU, our main job was to shift the patient once it's done from surgery OT. We used to shift it with whatever the small portable monitor we had along with it to the OT area. But in the recovery area, we just had, in the beginning, the OT you saw was the daycare OT, which we had in the main building. And close to it, there was a single room where the patient used to be kept till it got stabilized. So it is that we were not doing cases every day in the beginning. So we used to ship the patient there, and then we had an adjacent ICU with 4 beds where the patient would go once it is stabilized. And later we started using those 4 beds for regular OT when our numbers increased. So close monitoring, of course, I learned here how it is to be done and how important it is. How to tackle the virus complication, of course, by using crystalloid cardioplegia, we saw a lot of arrhythmias coming up in the post-operative period, which was a little difficult to deal with. It was very difficult, and at that particular instance, the we had not understood the physiology of arrhythmias, also were not very well understood at that particular instant. So, of course, the electrolyte imbalance, what was there, had to be corrected, of course. And there were not many drugs, antiarrhythmic drugs at that particular time. So we had seen a lot of mortalities also. So that was what we had and later we had moved to a bigger ICU and a bigger OT complex with 3 OTs and an ICU of, I think, 16 beds. And that was the main bed when I was doing my MCH. So if I would just tell you that I had joined initially as a non-MCH senior resident for 2 years. I was here from 1989, 1st June till 15 July 1991. And then I got into the MCH course and I completed in July 1994. So coming to the research part, as Dr. Mittal has already told, that Dr. Ghosh was quite insistent for collecting literature and doing a lot of research. So literature search was very difficult. Unlike today, we have Google, we have a lot of other, we could go to the PubMed, or you can go to any, there are so many sites where you can go and collect the literature. And I think most of us are also registered on a lot of journals. So you can have online journal access also, which was not possible in that days. And that was the time when I remember we didn't have a very good library with old journals. The only library available was the British Council Library, or you go to KGMU. Now I used to go to KGMC Library. I used to dig out initially my work was to read about the subject, take out as many references I could take out, then go to KGMC, get all the references. So they have a very huge library. They have very good collection of old books, old journals. And there I used to go in that dust area on a Sunday early morning, taking out those journals, articles, getting them Xerox, and in the evening coming back to the campus. So that is how we used to do the literature search. Data collection, of course, again, we didn't have the computer that time. So it was the Doxmetric which had come, but I was not very comfortable operating it. So I used to make an Excel table on my register. And that is what I used it even when I was in Tirupati. So I had an Excel on the computer as well. I had a duplicate copy of my data in the register form also, and I still have it today. So if time permits, I would be coming out with my results later on. Then coming to the statistics, again, like now we have the Innova, we have the SPSS packages and all those things on the computer, which is very easy to analyze, to find out the statistics. But in those days, statistics was a little difficult. And I remember I had a scientific calculator in which I used to do the statistics myself. And I had collected a lot of statistics book. I read about statistics, and it was compulsory for us here to finish the biostatistics as one of the part of, we had to pass that biostatistics program to be eligible to appear for your MCH exam. So that was part of it. So we did the course here only. Of course, there are a lot of characteristics. What I learned here when you are there as a cardiac surgeon, as a trainee, you should have a lot of skills in yourself. You should be intelligent enough to use your thoughts and mind. And there should be a well-structured training program, which was already there with us in this hospital. And of course, luck and patience is the other thing, which is very important. And patience, dedication, and your commitment to the work is really very, very important, especially as a cardiac surgeon. That is what I learned here. And of course, not going into the details here, I'll had a chance to meet C. Walton Lilly High. when he came to India. That was in 1994 in the ICTS con at Agra. And this is one of the pictures of that time. And I was really like overwhelmed to meet him. He's the father of cardiac surgery. We had read so many things about him, but that was the time when I met him. And he was very generous and he spoke very nicely to us. I think you were also there that time when we were meeting him. And this was the first convocation of Sanjay Gandhi in which I received my MCH award. So that's the only picture I had. I had a couple of pictures, but since my things have still not opened up, the boxes are still kept packed, I couldn't take out much photographs from there. So this was from where my actual journey as a cardiac surgeon started. And it was once I received my MCH from Sanjay Gandhi Institute, I moved to Bombay and I was working in Bombay Hospital with Dr. Dev Saxena. And Nimisha also was there, Dr. Bhattacharya was there. So these were the other people I came across later on my fellowship re-beds. I had met Dr. Neetu Manke, worked with him for a period of 6 weeks and got associated with him also in terms of that he wanted me to come back as a valve surgeon to his hospital. But unfortunately, after his death, I could not go. And I continued my journey in Tirupati from where I retired, and I'm back in Lucknow, in my hometown. I'm quite happy as a dean at Integral Institute of Medical Sciences and Research, Integral University in Lucknow. So at the moment, I'm doing vascular surgery, but I'm looking after mainly the education part of MBBS doctors and MSMD students. So that is my journey till now. And my experience I've already told. Dr. S.K. Agarwal can add some more things to it, if you remember. Thank you.
I don't think that I will be able to add anything to what Dr. Mittal and Dr. Chandra have said. And so now we will move back to the academic session. May I invite the chairpersons, Dr. Gaurango Majumdar, Dr. Bharat Dubey, Dr. Sandeep Gautam, Dr. Khalid Iqbal. Now I would request the panelists of the session, Dr. Anirban Kundu, Dr. Mubin, Dr. Ambrish Kumar, Dr. Amit Chaudhary, Dr. Amit Shrivastava, Dr. Arvind Pandey. So I think of so many people, we have only 3 of us available here as chairperson and panelist. So I would request them to start the program. The first talk is, the session is on valvular heart disease, session 3. And the first talk is going to be with on the topic of small aortic annulus, and Professor Shiv Chaudhary is going to speak on that. You see the video immediately.
सर इस पे आपको लाइव गूगल चाहिए जूम चलाना पड़ेगा इसको ऑन करने के लिए
ये तो कनेक्ट हो जाता है
सर हमारा इसमें और कनेक्टेड है लोग वाईफाई खुली से SGPG लाइब्रेरी So Zoom button कर लीजिए
में मीडिया प्लेयर है क्या? नहीं मैं कुछ करूँ पेन ड्राइव से
आई थिंक पता चल तो रहा है वीडियो में।
नहीं उसमें मीडिया प्लेयर है कि
हाँ सर।
खोल के देखो। एक मेरे को पेन ड्राइव कॉपी करके दो। किसी के पास पेन ड्राइव है क्या?
You send the email. I have to edit that.
नहीं वो बहुत वीडियो फाइल है, बहुत बड़ी फाइल है तो लोड। मैंने इसीलिए एसके से पूछा।
In a second, I will go.
बड़ी फाइल 2 GB का
इसी से रन कीजिएगा पेन ड्राइव से रन करिएगा।
हाँ।
आप देख पाएंगे।
सर वाईफाई चलिए जूम खोलिए सर एक बार, अगर जूम चल जाएगा तो आप इससे हो जाएगा सर।
जून से हो नहीं पाएगा। फिर से देखें।
हम जूम कनेक्ट करेंगे आप अपने सिस्टम कर सकते हैं सर, कोई दिक्कत नहीं सर। लाइटली हो गया सर कनेक्ट जूम जी। Sir, join the meeting.
नहीं उसमें वीडियो अगर प्ले करूंगा तो
सर आपके सिस्टम में चलेगा सर, यहाँ ये हो जाएगा सर।
वही में चला मुझे पीछे से हैंडल रन करना पड़ेगा ना।
अरे छोड़ पेन ड्राइव से ट्रांसफर करते हैं, देखते हैं क्या होता है। पेन ड्राइव अभी तो ये कॉपी भी नहीं होगी, है बहुत पुरानी कुछ पेन ड्राइव है। सब करके देखो। हाँ हाँ अभी तो ये पुरानी वो पेन ड्राइव है, कोई फास्ट ट्रांसफर नहीं हो रहा है इसका।
ज्वाइन मीटिंग
आईडी बताइए।
8954
8954 17
66
66
46
46
7
7
join.
We all are victims of technology. ये सारा कसूर एसके का है। He promised that this will work. वही कोशिश कर रहे हैं। पासकोड
22
22
89
8
89 83
83
से join. नहीं जरूरत है सर, ऐसे
ये भी इसमें कॉपी नहीं हुई। फिर हम इसमें भी हो जाता है तो इसी से कर लेंगे हम मुश्किल में। नेट बिल्कुल स्लो है, वो इतनी वीडियो फाइल वगैरह स्ट्रीम नहीं कर पाएगा। बैठे अभी करते हैं। ऐसा करो, इनका कनेक्शन करवा दो, उतनी देर में हम दूसरा लेक्चर। नहीं हो गया बस 1 मिनट। ठीक, ये
1 मिनट इस पे भी ले रहे हैं, ये भी कनेक्ट नहीं हो रहा है।
मुझे कनेक्ट नहीं हो, 1 मिनट इसमें करके फिर उसी से करते हैं। ठीक है,
इसमें ज्वाइन विद ऑडियो कर दीजिए।
Recording in
छोड़ ये बस हो जाए।
सर बेटर था, आप इसी से कर पाते हैं, उसके वीडियोस भी चल जाते हैं।
उसमें तो मल्टीमीडिया है ना, मल्टीमीडिया है ना। वो एक्चुअली पेन ड्राइव भी जो है ना, मेरे को इसमें पुरानी जनरेशन की दे दी, उसमें कॉपी होने में 1.6 GB का डेटा नहीं, वो तो 3 दिन लग जाएंगे। नहीं हो गया, मतलब थोड़ा सा बचा। जूम में नहीं कनेक्ट कर रहा है। नहीं फिर वो भी मैं उसमें जाएंगी। ठीक हो गया,
डायरेक्टली वहाँ पे प्ले कर दीजिए सर, स्टार्ट हो जाएगा।
वही कर। हाँ, कुछ सफलता मिली।
Which one? Sir, which one?
फोल्डर तो कौन सा है?
सर ट्राई ना कस्टमर।
नहीं इसमें SGPGIMS
this one.
SGPGIMS।
No, you can start.
Good afternoon, and extremely sorry for this technical glitch. And let me say in beginning that my talk is primarily meant for our residents, because when SK told me that it's a CME, so I prepared it accordingly. So I hope the senior members will not feel offended when I say something in a didactic manner, that don't do it. And so understand that it means that usually we should not do it. Okay, so this is the valvular surgery to provide competent valve without physiological significant obstruction. The word is, just pay attention on this word, physiological significant obstruction. So what is that physiological significant obstruction? How do we define that when we replace a valve? So what would define a significant physiological obstruction? So people have done some study and they recorded the gradients across the transplanted valve. And then they found that as the index effective orifice area was decreasing, there was a cutoff, this 0.85, that when the index effective orifice area was less than 0.85 centimeter square per meter square, the gradient would rise sharply. And similar finding was noticed during exercise also. So more or less,
0.85 centimeter square per meter square effective orifice area became our cutoff figure. So for my young colleagues, I don't want to confuse, so would explain the terms whatever I am using. What is effective orifice area? The blood does not pass through whole of the prosthetic valve. This prosthetic valve has got a housing. So whatever is the area, in this case, this yellow area inside the housing is geometric orifice area, but the blood doesn't passes through whole of the geometric orifice area. Then if we remove the valve mechanism, the leaflets, studs and everything, so whatever is remaining of the geometric orifice area becomes clear orifice area. But in physiological state, when the blood is flowing through this orifice, it does not occupy the whole of the clear orifice area. Because of the the rheological properties of the blood does not occupy it completely. So only part of the orifice which is occupied by the blood during physiological state is our effective orifice area. Now you can see we started with yellow this much, but finally we landed with this red. So the effective orifice area may be 70% to 90% of the geometric orifice area through which blood actually passes. So this is of our concern. So if index effective orifice, index means the effective orifice area of the valve has been divided by the BSA, body surface area of the patient in meter square. If index effective orifice area is less than 0.85 centimeter square per meter square, the prosthesis is considered obstructive and it's called patient prosthesis mismatch. A clinical and practical definition: if the prosthetic valve behaves like a moderately or severely stenotic valve, then it is a patient prosthesis mismatch. And for people who believe in patient prosthesis mismatch, it's an important clinical consideration and it impacts this long-term survival adversely. There are some people who don't believe it, but my talk is focused only for believers. And PPM becomes more relevant when we need higher cardiac output, especially in young patients, in athletes, where we need more cardiac output. And similarly, if the heart is not able to tolerate distal obstruction, whatever may be the magnitude, PPM becomes important. So if LV dysfunction is there, then also PPM becomes important. So now let's come to the small aortic root. How do we define small aortic root? People have used different definitions that if the annular size is this much, if the prosthesis size is this much, nothing would fit. A single parameter cannot define small aortic root. For example, if you say 25 millimeter of annulus, it may sound large for you, but think of a patient and a patient with a BSA of 2.2. This 25 may be small for him. Then a young athlete of 25 years, a 23 millimeter annulus may appear small to me. And in contrast, if an 80-year-old person is there, who is more or less living a sedentary life, 23 may sound good to me. So small aortic root or PPM cannot be defined in isolation. This is for just theoretical consideration. PPM has been graded as moderate and severe. Moderate if the index effective orifice area is between 0.6 to 0.85 centimeter square. and severe if it's less than 0.65 centimeter square. But when we put definition in terms of number, we should take into consideration about the obesity also. If person is obese, then the cardiac output does not increase in proportion to the BSA. So for obese patient in whom BMI is more than 30 kg per meter square, there is a change in the definition of ppm. Moderate is less than 0.7 centimeter square and severe is less than 0.5 square centimeter. So when I was talking about definition of small aortic root, a small aortic root is an interaction between the anatomy. Anatomy means the annulus size. I gave you an example. The body size, say 5 feet tall Indian woman of 40 kg. For her, the annulus size and ppm would be different than a large person of 2.2 meter square area. So the body size is also an important consideration. Then the physiological condition, as I gave you an example of what is the physiological requirement of the cardiac output. And of course, what prosthesis are you going to use? If you are going to use a bad prosthesis, everybody will have ppm. If you are going to use a good prosthesis, maybe you can eliminate ppm. So whenever we define small aortic root, it should be a combination of the annulus size, body size, physiological condition, and the prosthesis which we are going to use. So in decision making also, we consider all these factors by which we can prevent ppm. So management of small aortic root is essentially prevention of ppm. Before I go for prevention of ppm, just for clarity of thoughts, I would introduce some very basic terminology. Implantation technique, we can implant a valve in the aortic annulus in 3 manners. This one, the whole of the valve, including the suture ring, goes inside the annulus. This is intra-annular implantation. In this one, the metal housing goes inside the annulus, but the suture ring remains above the annulus. This is supra-intra implantation. Third one, the whole of the metal housing and the suture ring remains above the annulus. This is supra-annular replacement. This thing has an important bearing. I will explain when I come to these things down the line. Then the suturing technique is also important. You see, this A, B, and D. These are placing the valve intra-annulally. Only C technique, this technique C, that is mattress suture with loop or pledget on the ventricular side, is putting the valve in supra-annular position. So when we are talking about a small aortic root, we have to just focus on this technique. So we should know how to take sutures for supra-annular placement of the valve. Because we may choose a prosthesis which is meant for supra-annular placement, and then we choose this technique of everting mattress suture which places the valve intra-annulally. Your life will be very difficult. You won't be able to put that prosthesis inside the annulus. Now, it is important to know the valve also. This is a prosthetic valve in which we can focus on 2 components. This is the metal housing which we see, and this is the suture ring. Metal housing and the suture ring. Inner one is not relevant as far as my talk is concerned. So suture ring and metal housing. In bioprosthetic valve, again, this stent, this is stent, and then the suture ring. So when we tell about these valves, we should remember these dimensions. What is this? IOD, internal orifice diameter, not much of relevant for surgeon, only for assessment of the value. This tissue annulus diameter. Tissue annulus diameter is this diameter is important because actually this is the label size of the valve, and secondly, this will come in touch with the annulus. For all practical purpose, if you are going for a supraannular implantation, then this will be the line of demarcation where the valve should touch the native tissue. And then this is external suture ring diameter. This is the diameter of the suture ring. If you are putting the valve in intra-annular manner, then this suture ring goes inside the annulus. So the space required should include, should have consideration for this suture ring also. So intra-annular placement and supraannular placement, both are different things, and sizing is also done differently, and they have different connotation. For coming to a bioprosthesis, we have internal diameter, that means internal diameter of the stent. Outer diameter of the stent is also called tissue annulus diameter. This is relevant for us. And of course, external suture ring diameter, which is no brainer, all of us understand it. Another word which we will be using in this talk is performance index of a valve. Performance index is the measure of efficiency of a valve. How efficient is the valve, or how non-obstructive is the valve. And performance index is the ratio of effective orifice area divided by tissue annulus area. That means we have just learned what is tissue annulus diameter. So if we calculate the tissue annulus area, basically tissue annulus area is the area which is required to place the valve in supraannular position. So if we divide effective orifice area by tissue annulus area, we will get the performance index. So higher the performance index, better is the valve, more efficient is the valve, less obstructive is the valve. So prevention of PPM, let's take stepwise manner. Plan surgery. If on echo, if we find that the annulus is small, we should order for a CT angio. I see two things on CT angio. Aortic annulus is usually elliptical. It's not rounded. And on echo cuts the LVOT plane in sagittal section, sagittal plane. And usually it is the smaller diameter of LVOT and aortic annulus. The larger diameter we can see in the coronal sections, echo cannot provide us. So a CT angio will give you a better definition of the size of the aortic annulus. And secondly, LVOT can also be seen on CT angio if we find any muscle hypertrophy in aortic stenosis patient with smaller LVOT. In at least 10% of the cases, you will find that the muscle is bulging in subvalvular plane, which may produce gradient in postoperative period. Then second thing is use valves with higher PI. Now comes performance index part. I told that we have to use more efficient valve. Thirdly, avoid pledgets. Maybe most of you will not agree, but I don't use pledgets, so I always say that pledgets rather are enemy of the surgeon. Now you see that this is the annulus which is available to us. And these are three techniques of valve insertion. This violet is where the blood is flowing. So larger the violet area, we know that the more area is available for flow of blood. Same annulus. In this one, intra-annular, because suture ring is also inside the annulus, we see that this violet area is small. Supra-intra, somewhere in between. But if you place the same valve in supra-annular manner, we see that there is large violet area. Same annulus, but now we are getting more orifice through which blood can flow. The currently available valve in India, I am not talking globally, but whatever the valves are available, I will just touch on those. So high performance index mechanical valve, intra-supraannular, St. Jude Regent, Onyx, and Miltonia AP, not Miltonia routine. Miltonia standard is intra-annular valve. So it will not give us high PI. Miltonia AP is supra-intra valve, and St. Jude Regent is the valve market leader. Then purely supraannular, presently in Indian market, we have one mechanical valve, that is bicarbon oval line. Onyx, whatever may be the cuff design, but the implantation technique is supra-intraannular. You can see the effective orifice area even for a 19 size valve is quite good, 1.5. That means if we insert a 19 Onyx valve up to a BSA of 1.7, 1.6, there won't be any PPM. And 21 effective orifice area is 1.8. So overall, Onyx is a good valve. Miltonia AP, you see 20 size valve has got an effective orifice area of 1.7, which is fairly big. Bicarbon O-line, the 20 size valve has got an effective area of 2 square centimeter. Again, very efficient valve. Regent. The Regent is the most efficient valve available in the market at present. A 21 size has got the effective orifice area of 2 square centimeter. Don't get confused Regent with other St. Jude valves. St. Jude in India, they are presently marketing 3 types of St. Jude. St. Jude Master, that is standard valve, not old one. St. Jude Master series, then St. Jude Master, HP high performance, and finally Regent. If you see this green color, green or blue, this designates the area of blood flow, and it is maximum in case of Regent. And we can see that at 21, it has got an effective orifice area of about 2 square centimeter, which is sufficient up to a BSA of 2.2. At 2.2, this is in green, so we can be sure that the 21 St. Jude is good enough for all these patients. Now coming to the tissue valve, in market we have got 3 tissue valves available, which have got high performance index, and these tissue valves are always implanted in supraannular fashion. If we implant intraannulally, we will be able to put only very small valve. Magna Ease, all of us are very familiar with Magna Ease. A 21 size gives effective orifice area of 1.9 square centimeter. Another addition by the Edward group is Inspiris Regelia. The hemodynamic features are almost similar. This is a dry valve, it doesn't require any preservative. This chart is similar to that of Edwards Magna, but the important difference is that this valve can be dilated in future when we are going for valve-in-valve implantation. The stent is designed in such a way that there are overlapping plates, and when you dilate with the help of a balloon, these plates move away from each other, and we can achieve at least one size larger orifice inside where we can put it the TAVI part. The Make in India daffodil, this is less efficient than Magna, but still better than other valves which were being used till recently in the country. Another group of high performance tissue valves include sutureless valve. These are recent addition in which you see that there is a stent, the expandable stent is there which goes inside the annulus. So the valve, this prosthetic material which occupies the annulus is very minimal. So we get a better flow if we use a sutureless valve for the same annulus. For example, if you see this one, this is In this one, a 23 Intuiti has been used. In this one, 23 Magna has been used. So the turbulence with the Magna is grossly perceptible. But Intuiti is not available in India. This valve is available in India, Percival. So, of all the available bioprosthesis, Percival is the largest effective orifice area for a given size. For 21 size annulus, if we see, the available valve area, effective orifice area, may reach up to 2.2 square centimeters. So it's very efficient valve. But the drawbacks with the sutureless valve is that very high incidence of complete heart block, because there is this stent, the expanding mechanism compresses upon the conduction system and patients may land in complete heart block. Various reports have reported from 10% to 25% of complete heart block after using these sutureless valve. So when one is going for it, one should be careful about it. So once we have understood the hardware and all these things, how to proceed? Simple thing, I will just enumerate the steps. First, decide what patient is going to require, mechanical or bioprosthesis. Then calculate the BSA of the patient. Calculate the required effective orifice area for that patient, that is 0.85 multiplied by BSA. There are ready-made tables available, so there is no need of doing multiplication. Then select a prosthesis which has got an effective orifice area more than the required effective orifice area. So suppose if our required effective orifice area comes 1.5. So our prosthesis should provide us an effective orifice area 1.5 or greater. Each these manufacturer supplies this chart. Whatever prosthesis you are using, you can procure this chart and hang in your operation room and can decide which one. For example, if this patient has got a BSA of 1.7, and if I see this is coming here, that means if I am going to use this prosthesis, this model of prosthesis, I will need a 23 size prosthesis, because if I use a smaller 21, it will be red. That means patient will have patient prosthesis mismatch. So this is a very simple algorithm which we follow. Now see the tissue annulus diameter of the selected prosthesis. Usually it is the labeled size. Again, tissue annulus diameter is the labeled size. Then minimum diameter required of the annulus is tissue annulus diameter required +2. And annulus diameter, we have the value in front of us. If our annulus diameter is less than the required diameter, patient will go for annular enlargement. If annulus diameter is more than the required diameter, we simply choose our prosthesis and put it in place. So this was about the need for the root enlargement. The steps may appear little complicated, but it's very simple if you follow this. There is nothing big about it. You see what diameter you are going to require. If it's the annulus is less than that, go for a root enlargement. Another indication for root enlargement in current scenario is that if we are going to put a bioprosthesis in a middle-aged person, suppose 60-65 year, who is otherwise healthy, who is a future candidate of TAVI. That means we are making a platform for future valve-in-valve. So in this patient, it has been realized that the valve is less than 23 millimeter. The internal orifice of the valve is less than 23 millimeter. Then there will be problem of future PPM when we are going for valve-in-valve. So people recommend it that if you are preparing a platform for valve-in-valve, then we should have at least 23 size of the valve, or if we are going for Inspiris, which can be dilated, expanded in future, we can go for a 21 size valve. This will give us a good platform to insert a sizable valve at second intervention. Root replacement, I think I will just show two videos quickly rather than talking about these things. Anterior root enlargement and posterior root enlargement. By posterior root enlargement, usually we get a size increase on 1 to 2 valve size, whereas anterior root enlargement, we can gain up to 3 size increase. The most popular one is going through the between the commissure of non-coronary and left coronary sinus, what we call Manogian. I'll just show up now quickly some video. How can I come out of it? Can somebody help me in this? इसमें से मेरे इसको बंद कर दीजिए. This is not yours. Video इसमें ये पहले रूट इसको कर उसको प्ले मल्टीमीडिया नहीं मल्टीमीडिया प्लेयर नहीं है इसमें इसकी स्पीड नहीं कंट्रोल कर पाएंगे. We just push pause. Okay, now this aortotomy incision has been extended in between the commissure of the left and non-coronary sinus. This commissure, we have gone into the aortomitral curtain. We have not gone up to the AML. If we go up to AML, we will have to open the left atrium also. I use this graft, Decton graft, because it's available and there's no problem of sizing and handling. So we suture this, and while suturing, you would notice that I take the adventitia of the LA also. I take the left atrium also, so that I don't have to put a patch to cover the left atrium. While putting these sutures, be meticulous, because the suture line becomes inaccessible, and if it starts bleeding, it will be very difficult to control from outside. After reaching here, we stop, we interrupt the suture, and then we take the valve sutures. Valve suture for supraannular placement, as I mentioned earlier. After sizing, we are taking the valve suture. This is the transition zone. The native annulus, once we have taken the sutures from the native annulus, we come to the patch. And in transition zone, we take one bite in the native annulus, another bite on the patch. Now these sutures are placed through the patch from outside. These are proline sutures, because polyester sutures will make big hole in the graft, which will keep on oozing. After putting these 4 proline sutures. We pass these through the valve, which we have selected. Lower down the valve, tie the sutures, and then extend this graft as a patch on the aortotomy. Don't terminate this patch in a short fashion. Just take this patch along the whole aortotomy. Otherwise, that area will become crumpled and it will bleed. So we take this patch along the whole aortotomy. You can see this, it will reach to the, this patch will cover the whole aortotomy. I'll show another small video of a Kono procedure. कहाँ गए? ये वहां दिख नहीं रहा होगा ना, शेयरिंग नहीं हो रही है इसकी. हाँ नहीं, वो जूम से जो शेयर करने की कोशिश कर रहे हैं वो नहीं हो रहा होगा. This is a 7-year-old boy who has got this ascending aorta and distal ascending aorta dilatation with a severe aortic stenosis. The aortic annulus is only 14 millimeter. So we decided to do a Bental and hemi-arch replacement after enlarging the annulus with Kono procedure. So this is left button is being developed. Right button is being developed. Now 2 stage sutures are placed on the aortic annulus where we want to cut it. In this area, underlying will be interventricular septum. These stage sutures just help you to cut precisely, and your assistant is little relaxed. First, we enter in RVOT, make a small nick and see where the pulmonary valve is there. Once we are sure about the position of the pulmonary valve, we increase the incision. Now we are cutting in the interventricular septum. We go on measuring intermittently till this ventriculotomy is sufficient to take up the desired valve. Probably this is the only suture line where I use flagellated suture. So, the flagellated sutures are placed along the whole V length of the ventriculotomy. The pericardial patch is selected. Sutures are passed through the pericardial patch. And then pericardial patch is lowered and tied. This will be the first layer of ventriculotomy closure. Now with trioproline suture, I always place another running suture so that there is no question of development of a VSD or suture cut through. And once we reach angle, we interrupt this suture. Now After selecting the appropriate size valve, we put these valve sutures. In this condition, in this case, we have gone from out of the aortic annulus and come inside. Here we take these valve suture through the pericardium. The patch, some people use a piece of graft here, but I will use the same patch to cover the RVOT. That's why I have used pericardium. In isolated cono, inside we use a prosthetic graft and outside we put a pericardial patch. So now the suture placement is complete. The appropriate size conduit is selected. We pass the suture through this valve conduit. Conduit is lowered and tied. Now this is the second layer of suture. This proximal suture line, I take a trioprolene and in over and over running suture will cover it. This suture line is really hemostatic. We suture the pericardial patch also for this purpose of second layer of suture. Once we have placed this layer of suturing, there are very less chances that this proximal suture line will bleed. So once this suture line is complete, we cover up the right ventriculotomy part. In a running fashion, big needle, 3O, 25 mm needle. On the other side, the same thing, we run over and complete the. One should take precaution that while closing, one should not compromise with RVOT. So one should be little liberal with the patch. Some redundant patch will not harm, but if we use a small patch, RVOT will be narrowed. So after putting this, the routine part of the Bental and hemi-arch replacement, which I have not included in this clip of video, and this is the final picture. Thank you. Thank you. I have not done it anterior and posterior combined, because anterior you can increase the size by 3 valve sizes. So and even if you want more, we can go deeper. So there is, I have not done.
Redo of root plan.
Redo, yes. If in pediatric age group, if somebody has inserted a 17 valve and now it has grown up, this time, if somebody needs, then definitely I will have to go anterior root enlargement only. Posterior once somebody has already done, so we don't have any chance but to go for anterior root enlargement. We rarely, I think I have done only one redo root. So
Any particular choice of the valve, do you go always for a bilateral, do a root method, or you can go with the
I don't have, personally, I have not used TTK because the performance index of TTK Chitra is, in comparison to St. Jude Regent, is much lower. Even St. Jude Regent at size of 17 will give us an effective orifice area of about 1.5 square centimeter, which will be good enough for an average size adult. So we have been using routinely St. Jude Regent only. So I don't have any experience. Maybe you have such large experience with the Chitra. But Chitra, once I tabulated all these effective orifice area, and since then I have this impression that Chitra is not that efficient valve when it comes to its use in restricted area, small and less. It's not a very good choice.
Everyone asking, sir, but we are running short of time.
Yeah. Thank you.
Next topic is very interesting. Just for protection. That is the next topic. The role of bioprocesses in terms of evolution.
Yeah. Hello. How do you change that? Yeah, what we did. How do you change this line? You marker, point out. I don't know. Are you looking at that?
Jason, tissue bring.
Yes, yes. There's some problem in the system?
Yes, sir.
Huh?
Hang on. Jason.
Yeah, yeah. Dr. S. Agrawal, thank you very much. Thank you for inviting me. It is always a pleasure. Because of your wonderful hospitality, it's always a pleasure to come to my erstwhile hometown. And we always enjoy this wonderful meetings you organize. Thank you very much. And thank you also for giving me a topic of tissue valve, which is always a pleasure to talk about. You decided for me to give this talk on this subject. If the tissue valve is in young patients, is it a right choice for India? I can't answer that, but I think we have to answer this ourselves. But what I can do is I can share some of my experience, some of my thoughts of the tissue valves, which I've been using for last more than 20 years. This conflict is always going on with what to choose, the tissue valves or the mechanical valve. But there has been a conventional wisdom among the surgeons that if a young patient use a mechanical valve, if the patient is old, use a tissue valve. Now, how did we get this conventional wisdom, as I say? I think the part of the reason of this wisdom was two historical trials, randomized clinical trials, which were done in late 70s, because when these valves were made available to us in earlier days,
surgeons did not know what will be the long-term results of these valves. And I think we are calling it historic randomized trial because after that, to my knowledge, there was no randomized clinical trial comparing tissue and mechanical valves. And both these Edinburgh heart valve trial and Veteran Affairs cooperative studies, it gave the result of both trials showed a small survival advantage of the mechanical valve. And they compared the first generation porcine valve and the Bjork-Shiley valve, which was, can I get rid of this mark here?
This one?
Yes, thank you. Yeah, they compared the first generation porcine valve and Bjork-Shiley valve, and both valves are now obsolete. But what is not obsolete is the impression these trials left in our minds, that the mechanical valve is good, it will last longer, the survival benefits is there. But I think a lot has changed from that time. There is not very little progress in design of mechanical valves in the last more than 45 years. We are still using the valve which was developed many, many years back. And but on the tissue section, in tissue valves, we keep hearing about new developments almost every day or almost every month. Some new design change, some anti-calcific treatment, all these things are coming up every now and then. We keep hearing about this tri-leaflet mechanical valve for quite some time, but to best of my knowledge, this has not been yet been launched, and I have not read any report of this clinical use, but supposed to be a game changer in the mechanical valve section. We'll have to wait whenever this is launched clinically. In my experience, like most adult cardiac surgeons, majority of my work is coronary artery bypass surgery, but we do fair number of valve surgeries too. Yeah, I used to do congenitals, but now there are separate units doing that. And that's my experience of last 32 years. I'm not a basically repairman in valves. Most of my valves are replacements. I do repairs very rarely when they're very straightforward cases, but there are other colleagues of mine who are more in the repairs. So most of the patients of valves go for replacement. Excuse me. And majority of the valves majority of the patients had mechanical valves. But as I said, the last 20-25 years, I have tried to use more and more tissue valves. And these are the numbers. And I use tissue valve in all ages. And it's not the only age, is not the only criteria. There are many other criteria which I decide whether to use tissue or a mechanical valve. And if you see that out of the total number of tissue valves which were used, more than nearly 45% are patients below 60 years of age. I take this consent, special consent, I wanted to show because I want everybody to take this kind of a consent for many reasons. Because when we talk to the patient, we didn't explain everything. But ultimately, when we put the valve, they may come back to us, questioning why we decided this particular valve. So I've decided for the last many years, because it happened to us. And after that, I'm taking a special consent for whether I'm using a tissue valve or not, after explaining everything to the patients beforehand. See, this debate is always on with mechanical versus tissue, and sometimes it is so heated that we almost come to blows among the surgeons that what is a better valve. I don't know about that, but what I find advantages of tissue valve is that, of course, it has a lower incidence of thromboembolism, as you all know. No catastrophic emergencies, which happens in mechanical valve, big advantage in our country especially. No risk of disc impingement, especially in the mitral position, where most of us save the subvalvular structures, we preserve the cordis. There we are always worried in mechanical valve whether disc movements are free or not. The question is, of course, durability, possibility of non-surgical catheter intervention. Once we put a mechanical valve, we take away that possibility of any non-surgical catheter intervention in the future, if at all required. And durability is the question which I think we have to address. There have been multiple reports of very good long-term results. And this report especially was published in 2004 or 2006, actually it was 2004, it was sent for the publication. It shows equivalent late 15-year survival between tissue and mechanical valves. Unfortunately, we don't have an own country data, and that is why we have to depend on the data of Western countries and make our conclusions and decisions. So they show almost equal survival in both tissue and mechanical valve. There are multiple reports like that, which shows quite a good survival and durability of tissue valves. There is no point discussing all these reports separately. I just put them together to show that, of course, you can show many variety of publications where mechanical valves are seen to be superior than tissue valves. If you see the American Heart Association recommendation, note the first line: the patients who cannot or will not take warfarin class 1 indication. I think large majority of our patients come in this class. Patient who cannot or will not take warfarin. And also the line 3, possible compliance problems, again adds to the our situation more appropriately. This is an interesting study I'm quoting here because this compared the projected future of 30 years of comparing mechanical and tissue valves. And this is on the basis of all the published data. They come out with this conclusion. And if you see the last line, the total risk of morbidity and mortality in mechanical section after 30 years is 108%. That means every single patient who, of course, will have some major complication after mechanical valve if they live for 30 years. We don't see too many patients of 30 years of valve replacement. But in bioprosthetic section, this number is almost half, despite having a redo surgery. So there are some myths which we carry about mechanical valve, and these myths we convey to the patients. And that is, this mechanical valve lasts lifelong. They may, but very rarely. There's no reoperation. That's not true. Mechanical valves also develop significant pannus after 20-25 years, and many of them we have to replace. The risk of thromboembolism is minimal in anticoagulation. We know it is not. Coumadin therapy is simple. We know it is not. We tell the patient we have to take one tablet and that's all. It's not that simple. And the reoperation is very risky. Again, we know it is not. Not anymore. Reoperation is not all that difficult and complicated. The biggest problem with mechanical valve is, of course, lifetime anticoagulation. The compliance consideration of young Indians, I think we have to consider that every time we put a valve. Economic and educational standard, we know. Marriage and childbearing, very important consideration for Indian ladies and women. People don't talk about that, but the busy schedules and earning livelihood, traveling, which is a compulsion for men or for people in young age, I think keeps them away from the medicine lifelong therapies. Mood swings, again, nobody talks about it, but we all face it. One fight in the family, one fight with the spouse, and the first thing they will do is stop taking medicines. And there any family trouble, any problem, which often time happens in young people more. I think these are the reasons why they discontinue taking long-term medication. And of course, the medical infrastructure, a lot has to be done still to improve that. I came across this information that there's only about 2,500 labs in India who are NAB accredited. I believe there are more than 1 lakh pathology labs. And after putting the mechanical valve, we are sending the patients in the periphery, and totally their future treatment and life depends on the results from these labs. So we have to be careful where they are going to go and how they are going to be treated, because this is a lifelong situation. It's not a few days, months, and years. Redo valve surgeries, we keep doing. We try doing different approaches. Robotic, we tried 2 cases from some help from proctors. Thoracotomy we used to do earlier for mitral valves or redo cases, but now I have switched back to sternotomies, which is, I think, much better. It takes a little half an hour extra for dissection. Harmonic is very, very helpful in redo situations, and I recommend that please use it. I started using it recently. It has made hell of a lot of difference in dissection in redo situations. The question which I ask myself, question I ask you, question I ask everybody is that we know that all heart valve procedures are palliative. We know that any palliative procedure in body, non-malignant, requiring re-intervention after 12, 15 years, maybe CABG, maybe a PTCA, maybe anything else, maybe a joint replacement in other cases. If they require re-intervention after 12, 15 years, it is considered a good result. We do bypass surgery, a patient requires PTCA 12 years, 15 years later, it's very good. But why do we have a different yardstick for a heart valve replacement? The factors which we are affecting the choice of valve should not be age alone. There are multiple factors, and we all know that your social economic, pregnant, whatever, life expectancy, and we know all that. We all surgeons here. These are the new valves which claiming to be very long durable. They call it the Inspiris Resilia valve. They're claiming that they will work for 25, 30 years. I said I will not be there to see that, but yes. And the possibility of future and more durable valves is always there in the future. This freestyle valve, which I am very happy with this particular valve because I've used more than 120 valves of this kind. This is a freestyle valve, can use only in aortic position. For some strange reasons, even the Medtronic, which is a supplier of this valve, they're also not promoting it very well. But I'm happy because last 20, 25 years, I've never had a chance to redo any of these valves, but this is available only in aortic position. This Foldex, the new valve, which is recently had a trial in India. I was talking to the people who have used this valve. This is, of course, ultimately we thought this is the final solution to the valve problem. These are biopolymer valves, which does not require anticoagulation and expected to last very long. But the clinical trials here done in India have shown some problems, and the aortic position at the moment, I believe, it has been withdrawn because the leaflets stored in some patients. So that's about it. So in conclusion, I would say that the choice of heart valve is a life-changing decision for our patients. It is not such a simple operation. And we should consider the valve very, very seriously, having a lot of criteria about that, what is patient's requirement. Age alone should not be the major criteria. And that's why I believe in fact, yesterday I had a patient who came and consulted me, 36-year-old athletic man. There is a very active life. He wants to travel, he wants to do activities, had a severe AR, had developed over the period of time. And I discussed with him, I said, what kind of valve you wanted? And we told everything. Then he himself opted for, no, sir, no problem. I will take a mechanical tissue valve and we'll have a redo afterwards. Who knows? And I think after 10, 15 years, catheter intervention will definitely improve. God only knows what kind of technology will be available to us at that time. But if we put a mechanical valve, we are preventing all that future benefits, if at all, to these patients. The improved durability and the better redo surgery results make the tissue valves more attractive, especially in India. And finally, I think we have to use our brains, of course, but always listen to your heart, because even though it's on your left, it is always right. So thank you very much, and thank you very much for the time given.
Any question from next topic that is issue was young population, population.
Good afternoon. It's not evening yet. I think part of this presentation started because the last I was here on the dais at SGPGI, I was talking about my experience with about 160 mechanical valves in children. So one of these days, SK and Shantanu rang me up and said, "Wo repeat kar doge kya?" And I said, "I will, because I don't have to work very hard then." So we will be talking about valvular heart disease in the young and mechanical valve in the young. And for the definition of this talk, young will be somebody less than 14 years of age. So we are all aware that rheumatic heart disease still happens. Dr. Prasanna Simha was very eloquent in the morning, telling us about how there are differences between Bengaluru urban and Bengaluru rural. What we do not realize, and I think I've discussed this with Dr. Hiramat, who's here, is that the sub-Saharan Africa and in the Indian subcontinent particularly, it doesn't take 25 years for the manifestation of chronic valvular effects of rheumatic heart disease. So we will, in our practice, and before we go any further, I practice in a tier 2 city. And one more disclaimer, I'm the last cardiac presenter for the day. So I am the least in the wine bottle, you see. Everything is gone. Gone are the Ozakis, gone are the repairs, gone are these fancy procedures. I'm going to talk about good old-fashioned mechanical valves. So rheumatic heart disease contributes a large amount. It's still more than 50% of the pathology I see in young children who come to me. The smallest and the youngest rheumatic I've replaced is 5 years old. A lot of congenital valvular pathology also occurs. And in this, forget the mitral valvular lesion, we will have what is dreaded, parachute mitral valve. Then we will have dilatations of the annuli, or maybe cardiomyopathy, or maybe Marfan's borderline. Dr. Chaudhary might disagree with me, but at about the age of 13 or 14, you have a good chance of getting one of the Marfanoids to have a repair to do. Similarly, a bicuspid aortic valve. Aortic stenosis by far is the commonest congenital heart condition which presents. And a bicuspid aortic valve with perhaps not as fancy as a post-stenotic root dilatation requiring Bengtal, but yes, small aortic roots and bicuspid aortic valves. Forget about, I'm not really truly, dyed in the wool pediatric heart surgeon. So let's forget about hypoplastic left heart. Interestingly enough, most rheumatic pathologies which will require either aortic or mitral, which will require valvular intervention, are generally regurgitant in kind. So if nature decides to give us a rheumatic pathology to operate at young age, nature also decides to perhaps give us either pure regurgitant lesions or regurgitant with stenosis, mixed lesions. So maybe the annulus is not as much of a concern there. This slide, everybody will show, and people will wax eloquent about various kinds of valves, homographs, Ozakis. It doesn't exist. There is no ideal prosthesis known to man, whether it be mechanical, whether it be bioprosthesis, or whether it be anything else. This again is going to be very funny. Remember at the start of my talk, I said we are going to restrict our talk to children less than 14 years of age. These are small patients. Not all of us, at least my setup, we don't have a transesophageal which will work in children less than 20 kilos of age. 15 or 17 is what we will go. I'm sure there are institutes where they have small infants and neonates also perhaps get transesophageal. You read up reports 1.4, 1.5, small things, which if the probe goes here and there, it affects the lie of the endotracheal tube. That's what we're talking about. Interestingly enough, before all these diagnostic modalities came up, I don't know how many of us remember the good old double dilution technique. So there was a double dilution technique in which you went transeptally into the LV, injected dye, and took samples from the left atrium and the aorta, plotted a computer curve, and calculated your regurgitation. This was before the echo. I happen to have used it and seen it. I am that old. Dr. Iyer presented a paper somewhere, actually wrote a paper in a pediatric journal where he stressed upon epicardial echoes. Again, I am not familiar with, I would appreciate the audience telling me if they are using epicardial echoes as a tool to diagnose. There you see, Dr. Prasanna's hand goes up. As an epicardial echo as a tool to diagnose valvular lesions in pediatric population. We'll skip this. I am also going to not talk about this. This has been extensively covered and this is not my brief for the day. But with one caveat, if you are good enough, if you can get away with repair, please do it. Even in young children, do not consider valve replacement as the first modality of choice. That's the only reason why I bring up this slide here. And these two papers, interestingly enough, I'm quoting, are from Scandinavia. One goes on to say that pediatric mitral valve repair can be performed with low initial mortality, but should be reserved, and mind you, these are important words, should be reserved for medical and reconstruction failure. Bileaflet prosthesis larger than 23 millimeters. How many of us actually wind up putting a 25 mm bioprosthesis in metallic prosthesis, mechanical valve in many of our young female patients? So anything more than 23 in their hands in West requires less chances of reoperation. There are reports of a 16 valve turned upside down, a 17 valve turned upside down, i.e. the aortic valve mechanical being used in the mitral position, which is what the second paper from Scandinavia says. But you know, we are really scratching. These are patients I would wish upon my enemy. I would not keep them myself. I would wish upon my enemy. But if you're pushed, if push comes to shove and you have to operate. Another interesting technique, and again, feedback from all these learned audience is appreciated. Another interesting technique is to perhaps place the valve way up in the left atrium in the hope that you can get a bigger size mechanical valve in these small children. Again, Dr. Shiv Chaudhary took you through an entire EOA and whole stuff. So an ideal aortic valve must result in an unobstructed competent aortic valve, which is also durable and accommodates the growth of the child. Doesn't happen. In real life, doesn't happen. Again, you get a very small child with aortic stenosis. For God's sake, send him to a pediatric cardiologist with some structural experience who will dilate him, give him minimal aortic regurgitation, let him grow a bit before you start attempting any aortic valve surgery is my mantra of choice. I would be really drag kicking and screaming to do small children. Again, pretty much the same. If you can repair, please repair. If you can do an Ozaki, yes, sure. One of my junior partners is very interested, and I'm sure he will one of these days find himself in Bengaluru in one of these Ozaki workshops, and maybe we will do some Ozakis before we even think of replacing them. Interestingly enough, Ross in a juvenile rheumatic, Dr. Sampath's articles from the All India Institute tell us that it doesn't work. Ross in juvenile rheumatics doesn't work. So you're then pushed to, maybe a mechanical valve with root widening. I'm going to come to that. On an aside, in an aside way, we talk a lot about these choices, but how many of us are aware that Arnold Schwarzenegger has had 3 aortic valve surgeries? First Ross, then a re-replacement of the pulmonary Ross, pulmonary part, and now finally both the pulmonary and the aortic re-replaced. The smallest size mechanical prosthesis available for use in children is 16 millimeters. There was a talk of Nick Manoogian and Kono. Tissue prosthesis, I think I saw a slide which said 17 is available, but only on specific prescription that I cannot put anything less than 17. Homograft and Ross, yes. We are going to extrapolate what happens to congenital heart disease, left to right shunts and VSDs and tetralogies, and take them over to our patient population, which requires valvular surgery. Once you replace, repair valves, growth recovery is excellent. If they are indicated to have a valve surgery early in their life, and you give them a good, competent or replaced valve or a competent repair, whatever delay of their secondary sexual characters has occurred, it takes up. There is a paper which quotes long-term survival after aortic valve replacement in juvenile population, 81% at 10 years. The aortic atrioventricular valves surprisingly do not do very well. And the same paper which quotes aortic atrioventricular valve goes on to say that if you place the atrioventricular valve in the left atrium, slightly higher than the annulus, it actually produces more complications than if you put it in the annulus. So these days they are again talking about children with aortic pathology, and then they are talking about how planning, and this slide has been shared at least by 2 authors. Planning, how do you go? You go about with the Ross and then maybe then move to a mechanical, then move to a tissue, and then maybe a valve in valve. This shall be the bane of my talk if we are recommending mechanical valves in children. How do you anticoagulate them? Can you imagine telling an 8-year-old boy in this country, don't play cricket? वो cricket की ball सर पे लग जाएगी, warfarin खाता है, bleeding होगी. Try doing that. It doesn't work. Till about 6 years ago, the lowest warfarin or acetocomerol dose you had was 1 milligram. 0.5 would not come. And the same fellow, dawai wala, would sit in front of you and say, sir, dawai aadhi nahi karna, uski bioavailability ki koi bharosa nahi rehta hai. So you could not, lower dose. Now 0.5 is available. We just saw a slide. How many of them are NABL recognized? How many of them understand the true value of INR? I mean, I'm here speaking on mechanical valves, yet I'm condemning this. And I tell you, and I think I will have the house on my side if I say that the operative mortality in valvular surgery, the leading cause is oral anticoagulation. We don't kill as many patients with our operative procedures as warfarin does. And then the reason, as I said, why we are here is because I just, that was last annual conference and I presented 150. The number has since then gone up to 185. And we've kept this cutoff age as 14. The commonest pathology is rheumatic. And in rheumatic also, we've been very lucky to replace pure rheumatic stenosis. We will try and get away with OMV and some form of repair. So if it is rheumatic and most likely mitral because of regurgitation, we have been very lucky to escape with a size of 25. I have put a 25 millimeter mechanical in a 5-year-old child and gotten away with it. At least so far, till warfarin gets him. We have had a couple of cases where aortic repairs failed after a VSD closure and the aortic repair failed. And we took them back and put in a mechanical valve. This day and age, and as I said out in my earlier part of my presentation, if yes, there was one of us who learned Ozaki, and maybe I will, I'm sure Vinayak is going to roast me over the coals. Why can't you go and learn Ozaki? So if one of us does, then maybe there was a talk of monocusp Ozaki or bicusp Ozaki, and then maybe we will just get away without replacing aortic valves in this patient, in whom actually VSD is not very big. But it's that venturi which is sucking that leaflet and is causing more of a damage. We also take, I mean, we are a tier 2 city, we take all takers. So we have had Epsteins come up to us. And I've repaired a couple. I worked with Gordon Danielson for 6 months. So I repaired a couple, but these days our choice is actually replacement. And we've had a horrible experience with bioprosthesis, which was Gordon's favorite choice of valve in the Epstein. If he had to replace was bioprosthesis. We've had a bad experience with bioprosthesis, young females, it degenerates fast. So we've put in mechanical valves and gotten away with it. We have done only about 12 aortic root enlargements between the non-coronary and the left coronary cusp going down. The only difference I have with Dr. Chaudhary is that I'm using native pericardium in a teardrop fashion. I do not use a dacron. but I do not know about that. And forgive me for this. About 10 years ago, I went to the local Council for Science and Technology, very perturbed with the fact that warfarin was killing my younger patients. And I asked for funds, and I got a fund. Initial fund granted was 15 lakh le jaiye, Doctor Sahab. So I got a fund. And we proposed a trial wherein we would have 2 arms. All patients who required mechanic valve replacement in population less than 14 with small left atria and in sinus rhythm would be assigned either to a bioprosthesis or a mechanical valve. And believe me, I failed to recruit patients. The exact reason was that when you start as a part of informed consent, sitting down and telling them कि ये valve है, इसमें आपको खून पतला करने की गोली खानी पड़ेगी, जांच करानी पड़ेगी, और हो सकता है 10 साल बाद आपको ऑपरेशन कराना पड़े। ये valve है, ये valve कुछ नहीं करना पड़ेगा, लेकिन 10-15 साल बाद ऑपरेशन करना पड़ेगा. Finished. And as I said, we are not talking to very well-learned and well-educated patients. So, I mean, this is the reason why we are talking of mechanical valves in the young. The trial failed to recruit patients. I had to return the money back. I have failed to recruit patients. So my conclusion is that smaller size valves in mitral position are a feasible option. Some centers have reported supraannular placements of mitral valve as a long-term incremental risk factors. Small size aortic valves are an option. The smallest is 16. We are actually following 2 patients of 16 who come every 3 months, get a serial echo done. And one of these days, I'm sure I'm going to have to reoperate on them, but so far haven't had to, and I'm not rushing into reoperations. Increasing the size of the aortic root is one of the easiest techniques which all of us who practice valvular surgery should learn. Aortic root enlargement is this is stupid and I apologize again. Increasing the aortic root size is the easiest technique and it's widely reproducible and we should learn this. The anticoagulation continues to be a challenge. None of the newer oral anticoagulants will ever work. And regular follow-up of these pediatric patients and actually getting them back for redo. The risk for redo actually is minimized when you get them in an optimal position with the ventricle still preserved. If you get them when their ventricle has started going down the hill for redo, your results will also go down the hill. So a regular follow-up with impression. And yes, for God's sake, I think all of us as surgeons need to take away this impression out of our head that mechanical valves are a one-time option. They are not. These valves will have pannus, these valves will get stuck, these valves will do all sorts of circuits. But having said that, in a smaller center, if you are going to deal with some rheumatics, some congenitals, less than 14 years, consider mechanical valves as a valve of choice. Thank you.
Brutally honest presentation, if you got experience. Any quick questions or comments from your
Just loudly, everybody can hear. We are all heart surgeons after all.
Sir, this is about younger patients that you said.
where the problems can occur. Pre-op preparation of the patient is very important. We have to look at the pulmonary functions, right? Any kind of comorbidity as far as the lung problem is that and all that, because that will immediately tell you on the oxygenation side. Third thing is that, see, oxygenation means we try to hang on to 98, 99% of saturation or something like that. Well, whenever you are doing an isolation, then we have to think about and look at two things. One is permissible hypercapnia. I have seen that sometimes not the oxygenation is fine, right? 94, 95, and PO2 is fine. But the people are actually struggling, and they are actually trying to control the carbon dioxide levels, entitled CO2s, that may be going up to beyond 45 to 50 or 52 or 55. That is actually permissible hypercapnia, and we do not get too much concerned with that at that moment of time. But we look at that why it is going. The other thing is that always I remember that whenever you are putting if you're working on the one lung with the thoracic procedures, whenever you are doing a lung procedure, you put the patient on the lateral side. In the minimally invasive cardiac procedures, right, you don't turn the patient completely on that. You just slightly raise the side which you are doing on the surgery. So actually, when the effect of atmosphere, if your pleura is being breached and also the mediastinum, that is not playing on the lung, which is supporting the oxygen. So there is less of problem as far as the hypoxic pulmonary vasoconstriction is concerned on that lung, you see. So what happens that lung is actually perfusing a lot. So I don't think that we must have done so many, right? In the last 35 years, must be 800, 900 or 1000 isolations, right? I have never experienced such kind of oxygenation problem. Only if we have a problem with to begin with, if supposing a patient has got any kind of like emphysema or something like that, already on that. So those are the things. And the second thing is, you said pulmonary edema, right? See, that occurred in those, I think 10, 20 years back, right? I only saw once in 90s. This pulmonary edema. The reasons for this pulmonary edema, most of the times, probably, because the exact physiology behind that is not described. What I think, this is actually a reperfusion phenomenon. Reperfusion phenomena in the sense is that your lung is like that. It is totally collapsed. Now, it is working as a solid organ. It is only getting the blood, right? And blood is flowing a lot. As soon as you open up the oxygenation to that lung, now oxygen, there is a deluge of oxygen and calcium. So oxygen paradox and calcium paradox. These two things are actually causing a reperfusion phenomenon, right? Breaking of the lung vessel barrier, and that results in this edema and all that, right? So that is there. Somehow, because you see, many a times when we are doing putting the patient on pump, then the steroids are all used. So probably that is there, and there is a role of steroid to begin with, because that will take care of edema here also, and also with this reperfusion problem with the lung, right? So that is there. Somehow, I think we have not seen pulmonary edema. I think in the last 15, 20 years, we have become more rigorous with minimally invasive and doing so many procedures and all that, but we have not seen one. Probably we are understanding oxygenation more. That could be the reason.
Is there any difference in the incidence of low low electrolysis, in comparison to using of DLTs and normal ETUs?
And normal ETUs with blocker.
Yes,
right? With blocker and DLTs.
Yes.
No, it's this atelectasis occurs only that lung on which you are relying for oxygenation once you have put the other lung down. So this is the problem of the ventilated.
Now, whenever, as I said, the way the body is positioned, right? If supposing you are doing a lung resection, in that case, your pleural breach, the whole atmospheric pressure is also playing along with the weight of the mediastinum on the other one, right? So atelectasis sets in early. And that is why I said that whenever, even if you are using, I said PEEP in blockers, but if you are using a DLP, we usually use PEEP there also. To begin with, right from the beginning, we don't wait for the oxygenation to fall to a certain level and then employ PEEP. No, we, from the very beginning, we start with the PEEP, right? Probably that helps in taking care of atelectasis. Atelectasis is bound to occur. And as far as hypoxic pulmonary vasoconstriction is concerned, that also occurs in that lung which is ventilated. We wrongly go after the lung which is non-ventilated, lying like a solid organ, and say, oh, hypoxic pulmonary vasoconstriction is happening here. No, this is a phenomena where there is a differential oxygenation knock. So that occurs again in the ventilated. And then we are very careful about that if you use inhalational anesthetic agents, then probably you are inviting more of hypoxic. This means this hypoxic pulmonary vasoconstriction is actually reduced. If you are using IV-based anesthetics like propofol, right? So it is more preserved. So that's what we do.
One thing that you told that the right ventricle overload is there when there is a DLP. So how you deal with that right ventricular?
Yes, again, see what I have seen probably, yes, I think few days back I asked, how many of you are using dopamine? I think the dopamine has gone out of practice. Along with the, but it is hanging on to a white hair. I think all the white hairs must be thinking that yes, dopamine is also a good drug. Right? It's not very bad drug. So what happens if we are actually looking at it, right? We have to support, I support right ventricle. Again, if supposing slightest oxygenation problem is there, and we think that we are using probably more on the more fluids. You know that whenever you are putting the lung down, you try to restrict the fluids because the lung, after you restore oxygenation, this lung has been injured. So they try to actually accumulate lots of fluid, not in the interstitial space, as he has said, that probably or in the alveoli, but in the interstitium and all, right? So we try to restrict fluids whenever we are actually playing with the lungs. So now, what do you want to use? So some kind of a touch of support, right? And a small dose of dobutamine or dopamine, I think it plays wonders. It gives you enough weight because RV, when goes on strain, the first thing is happening is, supposing you find you started with a 70 heart rate. Now this heart rate has gone down to 60. Now this is the red flag and you have to catch it early at this point, right? So 60, why it should become 60? Right? If you are doing a transesophageal echo, then you will immediately find, because we always keep on, we just don't look, we always measure everything. So we are measuring the right ventricular function. We are doing fractional area change, we are looking at the tape say, we are looking at the S prime, we are also doing a 3D evaluation of the right ventricle, right? So we immediately find, it may not be obvious to you, but you measure it, those figures will tell you that yes, RV is suffering. It was not how you begin with it. Right? It needs support. So a touch of dopamine.
Is it dopamine or milrinone?
See, milrinone is a bigger deal for these kind of surgery. Why? Because milrinone will again increase the flow into that line, which is line deflated. So what's the fun? Right? So don't do that.
Thank you, sir.
One question for you boys.
Yes.
When you're standing and if you take a deep breath, where does all the air go? That will explain in the lateral position how the patient is being ventilated.
Yes.
Thank you, sir. Thank you.
Okay, thank you.
The next talk is on recent advances in pain management in CVTS surgery. Dr. Sujit Kumar.
I know a lot of people.
Hello, everyone. First of all, I would like to thank the organizers for inviting me in this forum of cardiac surgeons. And it's the last presentation, last talk for today. So I would like to keep my talk as much focused as I may. So post-operative pain is important for any surgical intervention. And as far as cardiothoracic surgeries are concerned, it is critical because the chest case contains the heart and the lungs, which are very vital for the recovery in the post-operative period. And if we look at the key challenges, key post-operative challenges after cardiothoracic surgery, these include respiratory complications, hemodynamic instability, prolonged ICU or hospital stay, and also persistent post-operative pain, which is very common after cardiothoracic surgeries. And its incidence is somewhere around 40% at 3 months to 20% at 2 years after the cardiothoracic surgery. And all these challenges or complications increase if we don't maintain the adequacy of post-operative pain management. Hence, pain management perioperatively is very important. So these are the analgesic modalities. A combination of systemic and regional analgesic techniques is primarily used as far as pain management perioperatively of cardiothoracic surgeries is concerned. I will discuss salient features of these modalities individually. And towards the end, I would like to discuss few of the regional analgesic techniques, which are being more commonly used over the past few years. So first of all, paracetamol, we all know that it is the safest analgesic which is available with us. And though it offers modest pain relief, but it should be used because it helps in decreasing the perioperative opioid consumption. Then the NSAIDs are a better analgesic as far as paracetamol is considered. But owing to its side effect profile, specifically the platelet aggregation, its use in cardiac surgeries especially is advised that it should be used with caution. So that's one point that should be considered always while and before using NSAIDs. Now, opioids are the traditional analgesics which are basically used in cardiothoracic surgeries, and with the definite side effect concerns, including nausea, vomiting, pruritus, and respiratory depression, they are going to delay the recovery in the post-operative period. So that's why this opioid sparing strategy is there, that we should use opioids, but higher doses of opioids should be avoided in the perioperative period. And drugs like dexmedetomidine help us in limiting the doses of opioids which are being used perioperatively, because it's a very good analgesic, and side by side it carries lesser respiratory depression effects. So it helps in limiting the doses of opioids while during these surgical procedures. Now coming on to the regional analgesic techniques. This thoracic epidural analgesia is a very good modality and provides very good analgesia, and also it helps in facilitation of early tracheal extubation. But despite this fact, its use in cardiac surgery has not gained very acceptance because of the associated risk of epidural hematoma. Hence, the advice is that whenever one is considering the use of thoracic epidural analgesia, always consider risk-benefit ratio with respect to an individual patient. So that's very important. Intrathecal analgesia is a very nice choice because it though offers modest post-operative analgesia, but it helps in reducing opioid requirements in the initial 24 hours. And also it doesn't have major adverse events or effects, specifically morphine, which we use for this purpose in the doses of 5 to 10 mics per kg, provides us very good analgesia with very little side effects. Paravertebral analgesia also offers good analgesia, which is comparable to the thoracic epidural analgesia and very minimal side effects. And it is useful in all these cases, surgical interventions. And also there is negligible possibility of epidural hematoma associated with paravertebral blocks. Local anesthetic wound infiltration, we basically in this with this modality, catheters are placed at the site of the wound and continuous local anesthetic infiltration is done. And it helps in improving pain scores with reduced opioid consumption. But despite that, this technique is not very commonly used because of the associated seepage of local anesthetic through the site of wounds, and also the fear of infection with the catheter. So probably this may be this may offer more benefits, but more research is required, specifically in the area of the side effects which are associated with it. So these are the techniques which I have discussed so far. And over the past few years, interfacial plain blocks have been very commonly used for the perioperative pain management. So I shall be discussing the basic facts associated with this interfacial plain blocks, and then the recent evidence which has come up for individual techniques. Well, interfacial plain block, local anesthetic is basically injected in a facial plane. And this is usually done under real-time ultrasound guidance. And this local anesthetic basically blocks the nerve fibers which are running in a specific facial plane. So the basic concept is that spinal nerve ventral rami give rise to the intercostal nerves, and these intercostal nerves, which provide somatic supply to the thoracoabdominal wall, basically run in different muscular facial plane. During its course, and it's also give branches, and all these the intercostal nerve and its branches are running in specific muscular planes, and at various sites we can target the nerve or its branches to provide a variable somatic block depending upon our requirement. So what are the basic advantages? It is technically easy because it is being performed in a superficial target plane. Then it's safe because it is away from major vasculature and also from the central nerve axis. And there is less risk of bleeding, especially in the presence of anticoagulant therapy, because the target planes are superficial, they are compressible. And finally, side effects are less, especially the hypotension, because these are the primarily somatic blocks. Autonomic nerves are not blocked, so hypotension incidence is less. Few lacunas, it is less potent than central neuraxial blockade. There is, because it's primarily a somatic block, so visceral pain is not addressed. And finally, the response is unpredictable because the response depends upon the spread of local anesthetic in a facial plane. So these three blocks are primarily used for different cardiac surgeries, and I shall be discussing the salient feature of each block followed by its evidence. So first of all, the rectus spinae plain block. Well, this block, local anesthetic is injected in the plane between a rectus spinae and transverse process, 2 to 3 centimeter lateral to the spinous process, as you can see over here. And it provides, it basically blocks both the dorsal and the ventral rami, and it provides somatic block along whole of the chest wall. So it is a very good modality for both the median sternotomy and the thoracotomy. And if you look at the evidence, this randomized control trial, which has studied the role of rectus spinae block, plain block, for patients undergoing adult cardiac surgery via median sternotomy, the authors found that it provided good pain relief as compared to systemic analgesics like paracetamol and tramadol. Then this randomized control trial has compared rectus spinae plain block with thoracic epidural analgesia, and it has concluded that the ESP block provided comparable pain relief to thoracic epidural analgesia as far as medial sternotomy surgeries are concerned. So good evidence is coming up as far as the use of rectus spinae plain blocks for median sternotomies are concerned. Then this serratus anterior plain block. Here the local anesthetic is given either superficial or deep to the serratus anterior muscle. These are the two planes where the local anesthetic is injected along the mid-axillary line, and it blocks the lateral cutaneous branches of the intercostal nerve, and it provides analgesia along the anterolateral and the posterolateral chest wall. The midline anterior is spared, so it provides good analgesia in cases of thoracotomy or the minimally invasive cardiac surgeries.
We did this randomized control trial where we evaluated serratus anterior plane block for pain relief in patients undergoing minimally invasive cardiac surgeries. And we found that SAP block reduced postoperative pain scores and opioid requirements as compared to systemic analgesics in these patients. Subsequently, a good number of studies are there which are supporting the use of SAP block in minimally invasive cardiac surgeries. And they are telling us that it is a simple and safe alternative to neuraxial and paravertebral analgesia in patients undergoing minimally invasive procedures. Finally, the parasternal block. Here, a local anesthetic is injected lateral to the sternum between pectoralis major and intercostal muscle, as you can see over here. And it blocks the anterior cutaneous branches of the intercostal nerve, thereby providing sensory block along the anterior chest wall. Hence, it's a very good analgesic option for median sternotomies. And regarding the evidence, this systematic review and meta-analysis published in 2022, it has included around 18 RCTs who have evaluated the role of parasternal block for median sternotomies. And they have told us that PSB helps in reducing postoperative pain scores and opioid use after cardiac surgery. So a considerable amount of evidence has came up for the use of parasternal block for median sternotomies. So here in this picture, a combination of interfacial pain blocks have been used for post-operative pain relief after robotic-assisted cardiac surgeries. 2 or 3 interfacial pain blocks have been used, but the only thing to be considered is that a large amount of local anesthetic dose has to be used. So local anesthetic toxicity should always be kept in mind, and local anesthetic should be used appropriately. So if you look at the rational approach, multimodal analgesia is the answer, and a combination of analgesic drugs should be used to achieve good analgesia with minimal side effects. So these are the options I have discussed earlier on. So our basic goal for perioperative pain management should be a combination of drugs from this box along with any of the regional analgesic techniques which are available based on the proper sensory block which it is given. So to conclude, multimodal analgesia approach should be considered, and the drugs which are appropriate to be used include paracetamol, opioids in the form of tramadol or intermittent fentanyl, intrathecal analgesia, and interfacial plane blocks. For median sternotomy, ESP block and parasternal blocks are useful. For minimally invasive cardiac surgeries, electrospinal plane block and SAP blocks are useful. Well, interfacial plane blocks, these are the simple and safe technique. Less potent analgesia as compared to neuraxial blocks, but it helps in reducing opioid consumption in the perioperative period in a multimodal pain management model. And since large amount of local anesthetic solution is used, local anesthetic dose should always be kept in mind. Thank you very much.
From personal experience also, there is a use on me. Tramadol makes you, and this is what even the patients are told, it's a lovely drug in the sense, it makes you not want to complain of pain, but it does not get the misery out.
Okay.
And that's something which patients have told me, and I have also experienced it. So that's why I prefer morphine or fentanyl or butorphanol. But tramadol produces very poor pain relief. I know it's the darling of many of even my colleagues keep giving tramadol. But personally, this happened because patients have told me that, and I personally experienced it. Misery is there of pain, but you don't think of pain, complaining. Same for gabapentin.
Okay.
These are two. That's why when I thought tramadol, my this is because of actually what happened is you don't want to complain. Misery is there.
Okay.
And we also, we are using multi-modal this, but one of the, call me old fashioned, but my first was the morphine infusion. Low dose morphine. I find even in my dressing, one of the things which I'd always tell is that in great government state, if a child cries, it's considered a failure of anesthesia. It should not cry. That's something which I keep harping to everybody and everyone, that surgery should be an anamnestic experience, but somehow children are the ones who are most neglected in that way.
True.
Right from putting the line item and everything. And there are people who do it well under average, but that's something which somehow people tend to neglect babies. They can't complain.
Sir, in post operative period, as you said, we should use multimodality approach. So along with the blocks, we usually use paracetamol. But the recent studies are saying that ibuprofen has a better control, RB control with a lesser kidney disease. What's your take on that? What do you think?
Well, you need to see the patient subset in which you are working. If it's basically revascularization is being done for CVT surgeries, definitely I didn't include it because literature is not very clear as far as the role of NSAIDs, the inclusion of NSAIDs and CVT surgeries is concerned. So, but apart from CVTs, you may go ahead, and it has to be supported by literature. That's what I can say.
Recent studies are saying that ibuprofen is far more safer.
Ibuprofen is the safest.
And another problem is that now when we're talking of ibuprofen, you have to be careful in CVT because it has also been associated with higher incidence of graft loss and that's a concern. Yeah, it's well described now. So we used to use ibuprofen, diclofenac, everything used to do. Today we hardly use it. We just use it. And one other thing is IV paracetamol takes care of it. This is something which I tell all junior people. IV paracetamol takes care of dull pain. It does not take care of fat pain. You need to have an opiate or you have to have something to control blocks, something to control fat pain.
Yeah, sure.
Thank you.
So what takes for the cardiac surgery, in routine thoracic surgery also we are incorporating that we do it all. So till how much of we have to give accordingly, decide according to the pain or something fixes there, we should adjust 48 hours or 24 hours.
We basically use continuous infusion. So what I could get that basically as an anesthesiologist, we are concerned regarding side effects which are associated with the boluses or top-ups or continuous infusion. So it depends upon how you are monitoring the blood pressures and heart rates while these drugs are going to be used. Because we in wards with, I mean, we are practicing like continuous infusion, low concentration, something like that. So 4 to 6 mL per hour usually we are keeping depending upon what exactly is the patient's pain scores are. If the patient is comfortable with lesser amount of drug, we tend to decrease it. But if the patient's pain is there, we tend to keep up 4 to 6 mL per hour. We may add some additives also, but we have to be really wary of what kind of blood pressure patient is having while in the wards. It's the kind of setup where monitoring is essential.
One question, is there any role of patient control in our setting?
Yeah, patient control analgesia devices are very useful, and basically for interfacial pain block, continuous infusion is more common. Thoracic epidural, it may be used. IVPC is intravenous opioid for opioid usage. Definitely intravenous patient control analgesia are being used. They are very common.
Actually, have you ever tried to cryo-analgesia?
Cryo.
Because some pain management people told us and we are using it for quite some time now. Very effective and very good.
Cryoanalgesia is.
I used to use it.
Yes.
You have problems 3 to 6 months down the line, and some of them when you graduate. No, we have been using it, but we have had patient. I used to use it a lot, but then yes, it does happen. It does happen. That's why I stopped using it. I was very fond of it. Yeah. No, you get late neuralgic.
It's basically useful for chronic pain.
Yeah.
As far as acute pain is concerned,
No, we start complaining of
we are quite towards using
I was a big fan of it till I started encountering this. It looks to be very clean. But when you actually what happens is. Afterwards, you can have various kind of thing. It's not, and only when you start asking them, you start. Only for because I was also a fan of it. I think I can't really take it.
Yes, earlier it was mentioned that pre-operative gabapentin 600 mg night before surgery reduces opioid need, so pain control after surgery. How useful that is?
Gabapentin, few studies are there. But the thing is that a reduction, pain scores have been reduced, but the opioid reduction has not been found. That's the thing.
Most of these studies were by that company, number one. Number two, I told you, even a personal basis and when we used it in government, you don't want to complain of pain. Misery remains.
Basically,
upfront and personal. I'm not joking when I was put, I was
Especially for coronary artery surgery, we have used subarachnoid block.
Yeah.
Morphine, 300, 200, 300 just one dose. And it takes care for at least 24.
I'm a big fan of Master.
No, he was like
Even with that, when we were putting epidural also with
a lot of restrictions in using morphine and paradox.
because persistent postoperative pain is very common in cardiac surgery, so its role has to be studied because very literature is not available, not very many studies are available. Pain scores have been reduced, but opioid reduction or opioid related side effects have not been found to be reduced with gabapentin.
That's because again, pain scores appear reduced because they don't.
Yeah.
I mean, I tell you literally, like I don't think I'm a dumb fellow, but I did not think that I have to tell my wife, who's an anesthesiologist, cardiac anesthesiologist, that I am having pain.
Yeah.
It never occurred to me. And I was suffering.
So you mean to say rather than anesthesia, it creates paresthesia?
It's not paresthesia, it's that you don't want to complain of pain. The idea that you need to, your response to pain is, you don't, I mean, this is the only way to describe it. You are suffering, but you don't think that I have to complain for them. So then, I think that's good. No, it is that you are having misery. You are having misery. You are having misery. You are suffering, but you don't think that I should complain. And then actually, and then when a neurologist actually told me, when I told it to my neurologist later, that's exactly what happened. Why did you take it? No, they only put it, and then
Sir, I think we should call it a day for today. And we have planned a musical evening and a gala dinner. It is here only. The musical evening is on the same floor. The dinner will be in the basement. And so if somebody wants to go to hotel and come back, then that is possible. But otherwise, we would request, we have something in the guest house, some rooms in the guest house, and we can take you there and you can relax there for some time and then come back. So whichever way you wish. And that is why, no, that is not far because in 20 minutes you will reach there.